how was the paper according to you from the perspective of microbiology?
Sir, from the perspective of microbiology, there were so I think micro was one saving grace subject for students this time because overall paper was not very one-liner heavy. But micro may still they could get use of their buzzword knowledge. Even though they also tried to integrate it a lot with pharmacology and they did try to give images. बहुत time से images थोड़ा सा missing था microbiology से. So microbiology में जो एक main problem आ रहा है sir, that is recall. Students are not able to recall because इतने direct भी questions नहीं थे. They had to read a long stem and then they had to make out what they're asking और वो answer तो mark कर दिया. But recalling is a big problem this time. And overall, also the feedback that we've gotten is moderate to tough paper. With, of course, the googly of video questions, which I'm sure you're going to talk a lot about.
So micro questions, could they answer in 50 seconds? Yeah, STEM was quite long enough and it was difficult.
नहीं ऐसा so for microbiology they have hardly recalled very few questions और जो उन्होंने recall किया है that is more or less doable for them. But because of this difficulty in the language, long stems is other language difficulties what the student is saying. Like students के terms में बोलो तो बड़ी sophisticated language, like probably more focus on the way of presenting the question where they are used to just getting a simple question of a sewage worker with jaundice and they would immediately mark leptospira. This time they started the question with a flooding place and then so वो direct hints were missing, इसलिए उनको recall करने में भी problem हो रहा है. That is what the feedback was for micro sir.
नहीं रिकॉल में एक और वजह से जो डिफिकल्टी आने वाली है दैट इज बिकॉज पेपर काफी इंटीग्रेटेड है एंड एक पर्टिकुलर क्वेश्चन को वी कांट टेक द क्वेश्चन एंड से कि दिस क्वेश्चन बिलोंग टू दिस सब्जेक्ट ओनली. For example, I cannot take just the pharma and say this is pharma only. Maybe even if there is a question on rheumatic chorea or there is a question on arrhythmia that is related also with the medicine. Even Santosh sir will also be saying, okay, this belongs to medicine as well. So there were questions that was having integrated heavy, we'll say, and I think this has been the pattern. This is not the first time that this type of question has been asked. And with respect to one-liners that we got to know from the students, there were one-liners, I mean, small questions as well. One-liner in a screen, that means there were a little easy question as well, especially in paper 2 also there were one-liners. So paper was kind of a balance, but we can't say that it was very easy. And as many students are also writing in the comment section, that paper was on the tougher side, tough to moderate side, and paper 2 was something that saved many students according to their language, if I can use, that it was moderate to on the easy side.
Like sir, for example,
repeats, ICT repeats topic.
That one question of history of ENT with the radiology image and treatment of mucor and a diabetic patient. So is that a medicine question, ENT question, radio question, pharma question, or a micro question?
Everyone will be discussing that. Exactly, everyone will be
discussing. It's difficult to place.
MBBS question.
All right, it's an MBBS question. So we will be saying that this is all going to be a medical science question, and I think this is what CBME is all about. When you look at the CBME pattern, something that NB is trying to implement for so long, this is what CBME is all about. That there will be integrated pattern and there will be integrated question. You can't take a question and you can say this belongs to micro or this belongs to only PSM, because maybe leptospira is discussed in PSM as well. Some of the programs in the PSM and some of the programs that is discussed also in the pediatrics. So there are questions that are well integrated between the subjects.
Sir, on a सीरियस नोट, इस बार तो वीडियो बेस्ड एमसीक्यूज भी आए थे. हम एंटिसिपेट कर रहे थे कुछ साल से, बट दे मेड देयर वे इनटू द एग्जाम दिस टाइम.
राइट,
आई फील इट एज एन अनफेयर मूव. आपको क्या लगता है? आई वेलकम द वीडियो बेस्ड क्वेश्चंस बिकॉज टेस्ट तो क्लिनिकल नॉलेज के बेसिस पे होना चाहिए. रटे रटाया इंफॉर्मेशन चेक करने के लिए तो एग्जाम्स नहीं होने चाहिए. बट द वे इट वाज इंट्रोड्यूस्ड विदाउट एनी फॉर्मल इंफॉर्मेशन दैट दिस एग्जाम इज लाइकली टू हैव वीडियो बेस्ड क्वेश्चन, बस थोप दिया था स्टूडेंट्स के ऊपर. सो मेडिकल फील्ड में हम ये कहते हैं कि कंसेंट जरूरी है. विदाउट कंसेंट वी कांट टच द पेशेंट. ट्रांसपेरेंसी नीडेड, बट एग्जाम में ट्रांसपेरेंसी बिल्कुल मिसिंग है. सो
नहीं है, बिल्कुल. जैसे हर चीज का एक ब्लूप्रिंट रहता है ना. जैसे फॉर एग्जांपल अगर आप यूएसएमएलई देते हैं तो उसका भी ब्लूप्रिंट अवेलेबल है कि किस तरह क्वेश्चन आएगा, एंड दे फॉलो दैट. In FMGE also there is a blueprint, but they never followed the blueprint. That is what we were discussing a while ago as well. and now even the pattern of the question is also not being followed. If you are planning to ask video based question or clinical patient ka image dikha karke, at least you should put it on your sample questions as well, because on the website
Exactly.
also there is a sample question where the student can go and practice and assess how to attempt the question. At least you include that so that the student will be well ready. स्टूडेंट को गूगली देने से कोई मतलब नहीं है, ये दिस इज ए स्क्रीनिंग एग्जामिनेशन फॉर गॉड सेक, एंड स्क्रीनिंग को अगर हम स्क्रीनिंग के लेवल पे रखें, दे हैव नॉट गॉन इनटू देयर इंटर्नशिप येट, अभी इंटर्नशिप किए नहीं है, है ना, दे विल गो टू द इंटर्नशिप आफ्टर दिस वन.
एंड दिस वाज
एंड
नॉट इवन
वन
गूगल,
मोर
ये
थिंग दैट,
ऐसा
यस,
हुआ कि आईपीएल का मैच अनाउंस किया और फिर स्टेडियम में फुटबॉल खेला रहा है.
हाँ बस समथिंग लाइक दिस, समथिंग लाइक दिस. एंड वन मोर थिंग, जो बच्चों ने मुझे बोला कि सर जितने भी चीजें मतलब आरआर या छोटे छोटे चीजों को हम यूटिलाइज किए थे एज और मेन कंटेंट. देखिए आरआर का मतलब क्या है, रैपिड रिवीजन. यू रिवाइज इट वंस यू हैव डन विथ योर मेन नोट्स, है ना. अब जो क्लिनिकल क्वेश्चन आए थे, स्टूडेंट्स को इस बात का रियलाइजेशन होगा कि क्लिनिशियन ही क्लिनिकल सब्जेक्ट पढ़ाए तो बेहतर है ना. आपको सोशल मीडिया पे बड़े सारे ऐसे वीडियोस मिल जाएंगे जो कोई भी उठ के गायनी पढ़ा रहा है, जबकि गायनी और ऑफ्थेल्मोलॉजी एज ए सब्जेक्ट अगर ऑफ्थेल्मोलॉजिस्ट पढ़ाएगा तो उसका एक अलग ऑरा है ना. वो जब आपको इनडायरेक्ट ऑफ्थेल्मोस्कोपी रेटिनोस्कोपी पढ़ाएगा तो उसका एक अलग ऑरा है. आप किसी भी एक्स वाई जेड से अगर पढ़ोगे तो वो आपको सिर्फ रटी रटाई या किसी टीचर का कॉपी किया हुआ नोट्स पढ़ा देगा, राइट. तो इसलिए क्लिनिकल सब्जेक्ट अगर क्लिनिशियन पढ़ाए, मेडिसिन सब्जेक्ट अगर मेडिसिन का फैकल्टी पढ़ाए, वो चीजों को लेकर के फिर आप आरआर से रिवाइज करो, दैट विल मेक मोर सेंस rather than you are starting your notes with the preparation with the RR. इतना सा आरआर है, उसमें से याद इतना रहता है, एग्जामिनेशन में आते आते कम हो जाता है. तो योर कंटेंट इज क्वाइट ह्यूज, यू हैव टू स्टार्ट फ्रॉम हियर, सो दैट यहां से स्टार्ट करोगे इतना आरआर में, एग्जामिनेशन तक आते आते इतना बचेगा. आप स्टार्ट ही इतना से कर रहे हो तो आते आते तो कम हो ही जाता है. तो इसलिए ये मुझे बच्चे ने बोला कि सर ये जो हम लोग जो गलत अप्रोच लिए थे, आरआर पढ़ के चले आते थे, उससे गड़बड़ हुआ. लेकिन इस बार मैं ये चीज करके आया और मुझे काफी बेनिफिट हुआ. क्लिनिकल सब्जेक्ट लाइक प्रसन्नवीर सर के या सुधा मैम के क्लास से या संतोष सर के क्लास से मुझे काफी बेनिफिट हुआ, क्योंकि उन्होंने क्लिनिकल पेशेंट को लेकर के जो चीज बताई, राइट, उससे हमें बेनिफिट हुआ.
एक बात तो तय है सर, अब जिस स्टैंडर्ड पे एग्जाम पहुंच चुका है, स्टूडेंट्स हैव टू स्टडी राइट फ्रॉम देयर एमबीबीएस डेज. ये पुराना मेथड कि हाँ पहले एमबीबीएस तो आराम से कर लेंगे, इंडिया वापस आके फिर पढ़ाई
नहीं नहीं
स्टार्ट
नहीं नहीं
करेंगे,
सर,
ये
वो
शायद आगे.
पॉसिबल ही नहीं है, वो पॉसिबल ही नहीं है. अगर आप सोच रहे हो कि 5 साल 6 साल हम एमबीबीएस कर लेंगे और इंडिया में आके 6 महीने में पढ़ लेंगे, तो आप तैयार रहिए, कम से कम 1-1.5 साल और फिर पढ़ना पड़ेगा आपको. 1-1.5 साल आपको लग जाना है निकालने के लिए. इफ यू आर वन ऑफ द स्टूडेंट की प्लान कर रहे हैं कि जाएं और 5-6 महीने में तैयारी करके, या गए और तुरंत जो भी अपियरिंग एग्जामिनेशन है दे करके निकालना है, देन यू हैव टू स्टार्ट स्टडिंग फ्रॉम द मेडिकल कॉलेज. आपके मेडिकल कॉलेज में पढ़ाई हो रही है नहीं हो रही है वो सेकेंडरी मैटर है. आजकल सर हर एक कंटेंट बच्चों के स्मार्टफोन में अवेलेबल है. हमारे आपके सबके लेक्चर सब में हर जगह अवेलेबल है. आप किसी भी जगह पे हो, कहीं से भी हो, आप पढ़ना शुरू कर सकते हो, राइट. आई थिंक वी शुड हियर मोर फ्रॉम अश्विनी सर एंड सुधा मैम.
Sudha ma'am,
Yeah.
I think there were a lot of image-based questions. So, what's your take on today's paper?
Well, ophthalmic topics were the same. And last time we, like in the Jan exam, we had 17 questions with 16 images. And इस बार बोल रहे हैं around 20 questions से कुछ 10-12 मुझे मिले हैं. They are all image based only. And there was one video based question on Shermer's. They are doable, but at the same time, you need very in-depth reading. जैसे सिराज sir बोल रहे हैं, well, like all of us have been saying, that you have to start studying from your college days and you have to follow the main videos. क्योंकि RR में तो we are only discussing the important topics,
Right.
and that is, while at the same time that is good for a final wrap up. जो जिस डेप्थ का क्वेश्चन है वो एक किसी रैपिड रिवीजन से या एक क्विक रैप अप से नहीं हो पा रहा है. लाइक द इमेजेस फ्रॉम ऑफ्थेल वर लाइक they are not always the regular kind of images also. Like you don't expect to get a video on Shermer, though I would say that introducing video based questions was completely unfair. ये बिल्कुल भी नहीं करना चाहिए था without prior information. And also these kids are pre-internship. We don't expect them to know so much. How can we expect कि उसको इतना कुछ पता होगा, especially in a subject like ophthalmology, जिसमें internship करने के बाद भी बच्चों को slit lamp वाले images पूछो तो they may not be able to know. But now we have brought them to a level where at least basic images वो identify कर लेते हैं. Now you ask them to identify videos in a subject like ophthalmology. It's not fair. Question was moderate, topics were same, but type of questions were difficult. I mean, if you have done the main videos properly, if you have studied from your undergraduate days, if you have given lots of GTs, so yes, then doable.
And the thing is, once they introduce the videos, अगर videos ही 30-40 seconds के हैं और फिर STEM पढ़ने के लिए और 10-15 seconds कम से कम
हाँ,
लगेंगे, it becomes it's kind of a burden on the student to
of
Yes.
course. 1
address
minute,
those
one
questions.
question पे चल रहे हैं ना हम 50
हाँ,
minutes. Like we
yeah,
have 1 minute, one question. So
one question
30-second
exactly.
video, you read the question, look at the option, think and mark.
Yeah,
अब
if
कि उस
they
बच्चे का खत्म ही नहीं होगा ना एक क्वेश्चन
exactly
1 मिनट में.
if they were planning to introduce video based question, तो time frame भी उसके हिसाब से change करना था. They would
चेंज
have
करना चाहिए था.
allotted another 5 minutes of extra time each station.
Correct. And it was like,
That's why
or you could have kept one module for image based और उसमें क्वेश्चन कम कर देते, टाइम बढ़ा देते, कुछ करते. एक तो वो फॉर्मेट फॉलो नहीं करते हैं. फर्स्ट पेपर में भी ऑफ्था के क्वेश्चन थे, सेकंड पेपर में भी थे. आई मीन इट्स दे यू हैव टू से ना कि फर्स्ट पेपर में ये पूछेंगे, सेकंड पेपर में ये पूछेंगे, इस टाइप के क्वेश्चन पूछेंगे. कुछ भी फॉलो नहीं करते हैं. दे आर जस्ट डूइंग वॉट एवर दे वॉन्ट.
Yes.
बट as like if I were to tell something to the student, I would say कि जो जूनियर बच्चे पढ़ रहे हैं, जो अभी कॉलेज में हैं, बच्चों पढ़ना शुरू कर दो. मेन वीडियो से पढ़ो, इन डेप्थ में पढ़ो, सारे इमेजेस को समझो, डिफरेंट सिमिलर इमेजेस को कैसे डिफरेंशिएट करते हैं, सिमिलर कंडीशंस को कैसे डिफरेंशिएट करते हैं, स्पेशली इंटीग्रेटेड पढ़ो. मतलब लाइक फार्मा, पैथ, माइक्रो को मेडिसिन के साथ इंटीग्रेट करो, एनाटॉमी को सर्जरी के साथ इंटीग्रेट करो. ऐसे सोच के पढ़ना शुरू करो, बिकॉज दैट इज हाउ द एग्जाम इज प्रोग्रेसिंग.
Exactly.
इट बेटर टू बी प्रिपेयर्ड देन टू बी सॉरी लेटर.
Exactly.
Yes.
Exactly.
Sir, PSM का
Ashwini
क्या
sir, few
हाल?
points from you.
PSM का क्या हाल था सर?
हेलो, एक्चुअली एक स्टूडेंट है विश्वनाथ, वो मैम के लिए कह रहा है, सुधा मैम के लिए बार बार, कि आपके पढ़ाने के चलते मेरा ऑप्थल क्लियर हुआ और न्यूरो एनाटमी वाला पार्ट आपसे बेस्ट नहीं पढ़ा सकता है कोई. तो ये पार्ट वहाँ एग्ज़ाम सेंटर पे भी बार बार सुनने को मिला. सेम तरह की बातें लोग, कुछ सिराज सर के लिए कह रहे थे कि फिजियो के साथ जो फार्मा पढ़ाते हैं फिर मेडिसिन ले जाते हैं तो उससे फ़ायदा हुआ. फिर गायनी वाले सर के लिए भी लोग कह रहे थे कि वो जो क्लिनिकल वाला पार्ट लेकर आते हैं तो उसके चलते इंटीग्रेट करके पढ़ाने से हम लोग को क्वेश्चन क्लियर होते हैं. और यही बात सारे टीचर्स भी कह रहे थे कि हमें इस बार से जो प्रिपरेशन का पार्ट है वो पूरा ही इंटीग्रेट तरीके से लेके चलना चाहिए शुरू से, अगर एग्ज़ाम देना है तो. पीएसएम वाले पार्ट पे क्लिनिकल वाले जो क्वेश्चंस आते हैं न्यूमेरिकल, उसमें सारे बच्चे फंसते ही फंसते हैं. और एक्चुअली देखा जाए तो वो टॉपिक्स सिर्फ 12 टॉपिक हैं जिससे न्यूमेरिकल आते हैं. तो अगर उस 12 टॉपिक की वीडियो आप न्यूमेरिकल पे फोकस 2-3 घंटे टाइम दे दो तो आपकी न्यूमेरिकल्स मोस्टली पकड़ी जाएंगी, सारी नहीं बट 99% पकड़ी जाएंगी. लेकिन हम लोग के अंदर मैथ को लेके ऐसा फोबिया है कि हम वो 2-3 घंटे टाइम भी सेपरेट नहीं दे पाते. तो एक तो उसको हम लोग सॉर्ट आउट कर सकते हैं. दूसरा पार्ट पब्लिक हेल्थ से रिलेटेड जो बेसिक्स कंसेप्ट्स हैं उससे भी क्वेश्चन आए हैं इस बार. सिर्फ वो टफ वाले नहीं आए थे, थोड़े बेसिक कंसेप्ट से भी आए थे. तो आई थिंक कि ये जो भी सारे आप देख रहे हो कि संतोष सर भी, मैम भी, सब हम लोग यही कह रहे हैं बार बार आपसे कि मेन वीडियोस को बेस बनाओ. सिर्फ और सिर्फ क्वेश्चंस के जो मतलब एक थोड़े शॉर्ट से नोट्स हैं उनसे बनाने से कई सारे क्वेश्चंस नहीं पकड़े जाएंगे. और एग्ज़ाम, सिराज सर का एक क्लियर प्रेडिक्शन है कि आने वाले टाइम में ये टफ से टफ होते चला जाएगा. तो इसीलिए आपको क्लियरली सुधा मैम कह रही थी कि अभी टाइम है, स्टार्ट कर लो ताकि बाद में सॉरी ना रहना पड़े. और जो बच्चे अभी एग्ज़ाम दिए हैं और अचानक से वीडियो क्वेश्चन आने के चलते उनके रिजल्ट अफेक्टेड हो सकते हैं, इस तरह की जो उनको है, तो आप परेशान ना हो. हमेशा आपको एक मौका होता है कि आप तैयार करके फिर से उसको बेटर करके दो. और आप अभी रिजल्ट जानते भी नहीं हो सकता है कि आपके 20 क्वेश्चन वीडियो वाले गलत हुए हों, लेकिन कहीं आपने जो सबकॉन्शियस माइंड से कुछ क्वेश्चन देखे थे वो सही हो गए हों. तो अभी तो एग्ज़ाम खत्म हुआ है, आपको रिलैक्स करना चाहिए ताकि
Exactly.
फ्रेश माइंड से दोबारा तैयारी कर सके, ना कि ज़्यादा लोड लेने का एग्ज़ाम का. और बहुत बहुत खराब मैनेजमेंट, उसके लिए तो जितनी भी हम लोग बुराई करें 10 बार बोलें तो भी कम है. क्योंकि गर्मी में बच्चों को एसी ना देना, पानी ना देना, लिफ्ट ना देना, ये इनह्यूमन है. और ये मतलब क्या कहा जाए इसको,
हम इसकी कड़े
एक
शब्दों से
स्टूडेंट
निंदा
से देखा
करते
जाए
हैं.
तो उसकी हालत सोचिए. 1 साल 6 महीना इतना प्रेशर से तैयार किया, पूरा एक्सपेक्टेशन लेके जा रहा है और एग्जाम हॉल में उसको नॉलेज की जगह उसके पेशेंस की टेस्ट हो रही है और अलग चीज़ों का टेस्ट हो रहा है। ये
एग्जैक्टली
बहुत बहुत अनफेयर है, बहुत अनफेयर है।
एंड ऑल्सो एग्जाम फीस भी कुछ कम नहीं है। एग्जाम
हाँ।
फीस
7,000
जितना है
यस।
ऐसे बेसिक सर्विसेज तो प्रोवाइड कर सकते हैं ना बच्चों को।
7,000
एक तो
मैम।
ऑलरेडी उनके लिए ऑलरेडी इतना स्ट्रेस है, इतनी सारी
हम्म।
चीजों को लेके वो गए हैं, एंड
हम्म।
देन यू ट्रीट देम लाइक दिस, इट्स नॉट एक्सेप्टेबल।
नॉट नॉट एक्सेप्टेबल, नॉट एक्सेप्टेबल। हम लोग तो सिर्फ बोल सकते हैं, लेकिन मतलब उनकी जो प्रॉब्लम है, वो जो उन्होंने फील करी। अब किसी बच्चे का 2 क्वेश्चन गलत होने से रुक गया और उसकी गलती नहीं थी, वो उसका कूलर, एक बच्चा बता रहा कूलर लगा के मेरे मुंह पे ही छोड़ दिया। अब
कान
उस
के
तरह से
पास।
अगर कोई को छूटता है तो वो पूरी जिम्मेदारी तो सिस्टम की हो गई ना। सिस्टम ने उसको हम लोग ये पढ़ाते हैं यूथेनिक्स में कि जो ऑटिस्टिक जीन भी आए हैं, अगर हम उनको ट्रेनिंग दे देंगे तो बेटर इन्वायरमेंट में अच्छा एक्सप्रेशन देंगे। ये जस्ट यूथेनिक्स का निगेटिव यूथेनिक्स यहाँ एग्जाम में कर रहे हैं कि उनको ऐसा इन्वायरमेंट दे रहे हैं कि जो पढ़ के भी आया है वो बेचारा वहाँ पे परफॉर्म ना कर पाए। तो इस तरह का ये एटीट्यूड एक एंटी स्टूडेंट एटीट्यूड है। बिल्कुल मैं एग्री कर रहा हूँ संतोष सर से कि वीडियो क्वेश्चन आपको देना था तो या तो टाइम बढ़ाते, या तो आप पहले वार्निंग देते कि वीडियो क्वेश्चन दे रहे हैं। और एकदम टू द पॉइंट अनुषा मैम और सिराज सर भी इसको बार बार इसीलिए कह रहे हैं कि आप जिनसे एग्जाम का जो पैटर्न है, जो आप पूछना चाह रहे हो उनसे, वो इंटर्नशिप के बाद के भी नहीं है। मैम कह रही थी ना ऑप्थल में वो क्वेश्चन तो पीजी में भी समझने में
पीजी
टाइम
में भी नहीं
लगता है,
पूछते सर, एसएस के
पीजी
लेवल
में
पे
भी नहीं
आते हैं वो
पूछते हैं,
क्वेश्चन,
उनको
एसएस में
आप
आते हैं
पहले
वीडियो
दे
बेस्ड
रहे हो।
क्वेश्चन। एसएस और एमसीएच वाले जो एग्जाम होते हैं ना, उसमें आते हैं वीडियो बेस्ड क्वेश्चन। संतोष सर
हाँ।
ने एसएस वाले बच्चों को पढ़ाया है, उन्होंने देखा भी है पेपर, है ना, तो एसएस वाले बच्चों का पेपर था, है ना, तो नया क्वेश्चन नहीं मिला तो सोचा चलो एसएस
वहां पे
वाला
भी
पेपर एफएमयू
तीन
डाल देते हैं।
वहां पे भी 3 सेकंड्स 5 सेकंड्स के वीडियोस होते थे जिफ वाले। अब तो ये
हम्म
30-40 सेकंड्स के वीडियोस डाल रखे हैं, तो क्वेश्चन पढ़ना, वीडियो कंप्लीट करना, टाइम टाइम मैनेजमेंट वाज प्रोबेबली अ चैलेंज फॉर मेनी स्टूडेंट्स।
And also, they're completely forgotten the basic fact that this is a screening exam. Yes,
हम्म।
Yes.
this is to make sure that these kids have enough knowledge to treat and work as a primary care physician. Now, primary care physician कहाँ पे ऑफ्थाल के slit lamp images देखता है, आप मुझे बताओ।
हम्म।
Which even like which primary care physician has a slit lamp in his OPD to look at these things? You can ask basic questions and you can ask basic theory. And if you want to ask clinical, you have to ask clinical which is relevant to a primary care physician. You cannot ask something which is not relevant to, like, which is very specific to a specialty ophthalmologist who is sitting in a tertiary care place and who has all instruments and everything at his disposal. ऐसे क्वेश्चन को आप एक स्क्रीनिंग एग्जाम में कैसे पूछ सकते हो? आई मीन इट इज they've completely forgotten the purpose of this examination in a bid to make it more and more difficult, and it is something which is very sad.
लेकिन मैं एक बात इस पे मैम बस कहना क्या चाहूंगा कि आई नो सिस्टम को आप गलत मान सकते हो स्टूडेंट्स के एटीट्यूड से, लेकिन एग्जाम को तो आप अपना दोस्त ही मानो, क्योंकि अगर एग्जाम से नफरत हो जाएगी तो आपको तैयारी में वो प्यार नहीं आ पाएगा। एग्जाम तो आपको एक बेटर डॉक्टर ही बनाएगा। हाँ टफ है तो उससे और फायदा ही है आपका। ऑफ कोर्स सिस्टम आपके अगेंस्ट है, सिस्टम से गुस्सा रहो, लेकिन एग्जाम को थोड़ा एक प्यार वाले एटीट्यूड से देखो,
करेक्ट, आई दैट्स
क्योंकि
व्हाट
वो
आई एम
आपको
सेइंग।
बेटर
जो
बना रहा
जूनियर
है। या
बच्चे देख रहे हैं, बस समझ लो कि क्वेश्चंस आर गोइंग टू बी डिफिकल्ट, दे विल बिकम, आई मीन दे आर ऑन अ ट्रेंड दैट इट्स गोइंग टू बिकम मोर डिफिकल्ट। तो जल्दी पढ़ना शुरू करो। वी विल आल्सो ट्राई टू टीच यू इन एन इंटीग्रेटेड फैशन। वी विल ट्राई टू
यस
इंक्लूड
डेफिनेटली।
मोर images. We will try to incorporate videos, clinical integration, and do whatever is possible. But ऐसे आरआर पे रिलाई करेंगे, लास्ट में मैराथन सुनेंगे, सिर्फ ऐसे पीवाईक्यूज करेंगे, उससे नहीं होगा। इट्स गॉन
एग्जैक्टली
बियॉन्ड दैट, उससे बाहर चला गया ये।
I
बिल्कुल
think the
बिल्कुल।
students are quite eager to see the recall.
I
And
think
Dr.
yes,
Are you ready with the
students
questions?
are eagerly waiting to initiate. I think Santosh
Dr.
sir,
Ranjit is also
who is
ready.
our first
So
faculty, please invite
देन गो फॉर
and
इट।
you guys can watch it out. और एक disclaimer दे दीजिए सर क्विकली कि ये सिर्फ फर्स्ट स्टूडेंट्स ने जो पहली बार उनके दिमाग में आप बताए हैं। यू गाइस आर फ्री टू गिव योर फीडबैक एट एनी गिवन पॉइंट एंड द रिफाइंड फॉर्मेट विल बी प्रोवाइडेड टू यू आफ्टर फ्यू डेज।
ठीक।
Yeah.
थैंक यू सो मच।
Ranjit, thank you all guys. Thank you all.
थैंक यू
Thank
सो
you.
मच।
Thank you, sir. Thank you.
So hi
एंजॉय
folks,
पार्टी।
Dr. Ranjit is ready with the questions from pathology, and we will begin the recall now. Dr. Ranjit,
Ranjit sir
over to you.
can initiate.
Hi, sir, Salman. Thank you. Thanks a lot. Hello, guys. Am I audible? Okay, so they had a very good discussion on the pros and cons of the exam. Now let's get into the real questions. I've got 12 questions in pathology. Some of them had got a little bit of STEM. I've tried to recreate the STEM and give the 4 options appropriately. If anything is wrong, do let me know, right? Let's go quickly. and we'll see one by one. And I want you guys to tell if the answer is right. If it's right, let's go through it. If it's wrong, if there's any error in the question, do let me know. I'll note it down and we'll give a perfect question soon, right? So they said there was a question on testicular tumors. Just added a history, painless enlargement of right testis. The information students gave was a normal beta HCG that kind of rules out choriocarcinoma, that because that's a marker for choriocarcinoma. A normal alpha fetoprotein that rules out a yolk sac tumor, and a biopsy image was given, right? Similar to this, something similar to this, right? So you have lymphocytes in the septa, and you have clear testicular tumor cells. That's a characteristic finding of, you guys know, that's a characteristic finding of seminoma. Obviously, it's not a teratoma, right? So it's a classical question. We had this question in the FMG predictor as well, because this is something which keeps on repeating. At least with respect to pathology, they didn't give any videos. Happy. Hopefully next time also they won't give any videos. There were a few images and that were also doable, right? Okay. Perfect. Perfect smooth specialist. Lymphocytic infiltration, seminoma, classical answer. I am sure most of you must have got it right, right? How many of you got this question right? Let me know in the comments. This question, again, I have recreated the question. The inputs given to me was, there was a history of lupus nephritis because a young female with a history of joint pain and renal involvement. Sorry, let me know if it is right. Apologies for that. Fine. So if this was the question, the exact question was, what is the pathogenesis with respect to lupus nephritis, right? Was this the question? If it is right, let's go to it. If this is right, perfect. So the question, if it's a lupus nephritis, if that was the question, and the answer is to be simple, it is to be the deposition of immune complex with complement activation. That is the reason it destroys the kidney, right? Okay. So glomerular basement membrane, you know that it's a Goodpasture syndrome. T-cell mediated immunity. T-cell has nothing to do with lupus. Lupus is a type 3 hypersensitivity, which is an immune complex mediated B-cell related problem, and definitely it's not ANCA mediated. ANCA mediated will be vaginous and others, right? I want a bit of more clarification. Some of the students said that there was a question related to RPGN also as a histopathological image. Was it there or not there? Can anyone help me with that? Okay, I'll ignore the frothy discharge. It is a question on lupus nephritis, right? Great. If there's no question on RPGN, let's ignore that, right? There was a question on lupus nephritis. And the answer is immune complex mediated activation, complement mediated destruction of the glomerulus. That's the answer. History might be here and there because this stem of the question, I'm sure it will be difficult for any student to recreate, right? Sorry, my throat is not good, so bear with it for some time. Okay, was this question there? Read through the question and let me know. The history given for me was simple. History of a lung cancer related history and weakness and fatigue. Was this there? If this question was there, it's simple. It's a paraneoplastic syndrome of lung cancer, the Lambert-Eaton syndrome, right? It is a difficult question. I will not deny it, but you can easily take it from the weakness. Some of them said it's hypercalcemia. It's actually a paraneoplastic Lambert-Eaton syndrome, which is the classical history of proximal muscle weakness, walking the patient will have pain, right? And Lambert-Eaton is something seen in small cell carcinoma of the lung, right? Okay. Okay, something related to that. If something it's not exactly the same, we'll definitely change it. But there was a question related to Lambert-Eaton syndrome, and the answer is small cell carcinoma. We have discussed that small cell carcinoma has multiple paraneoplastic syndrome, but they gave a clinical scenario related to that, right? Perfect. This question. This was the easy question, right? How many of you got this question correct? It's a very simple question. The classical clue here is the difference in the arterial pulse. That's a classical pulseless syndrome. Young patient, young female with radial pulse weaker on the left hand and then the right on the arm. It is classical history of the pulseless disease and arthritis, right? Hello, RCB fans. If there's anything else, please do comment. We'll definitely change that. Fine. Perfect. This is a very simple question. You will not, I'm sure most of you must have got this question correct, right? Okay, let's move to the next one. I was told there was a history of colonic adenocarcinoma and the mutations were asked. So I've just recreated the history. This term might not be exactly correct, but there was a history of colonic cancer. And what is the mutation which is seen commonly in case of a colonic adenocarcinoma? Undoubtedly, it is KRAS. KRAS is a common mutation which is seen in colonic adenocarcinoma for the adenocarcinoma sequence. It's one of the important things which also reduce the prognosis of the colonic adenocarcinoma. BRCA might be seen, but BRCA is not as common as KRAS. So KRAS will be a better option than BRCA. Fine. Okay, we'll add PIF3. Fine. If PIF3 is also there, I will still prefer KRAS than PIF3 because PIF3 is seen something later, but KRAS is a very, very important mutation seen in the adenocarcinoma sequence. Okay, now this complicates. If MMR is also there, I need a little bit more emphasis on the history, right? Because MMR is Lynch syndrome. Again, if there's no particular history on saying which is Lynch or familial adenomatous polyposis, still I'll prefer KRAS over MMR because that becomes the most common. If KRAS is there, I'll prefer KRAS any day over any other mutations. Fine. Okay. It's based on incidence, Ajay Kumar. That's all, right? MMR is Lynch syndrome, which is not that common compared to a KRAS. KRAS is definitely common, not only in the syndromic, also in the sporadic case of adenocarcinoma, KRAS is common. Fine. See, if it's a gynecological related question, colonic adenocarcinoma and endometrial, see, this changes the entire thing. If it's colon plus endometrial, then I would prefer Lynch syndrome. But again, let's get the exact recall from all of you. Then we'll think about whether it's an MMR Lynch syndrome or a KRAS-related sporadic adenocarcinoma. If it's endometrium plus colon, the entire thing changes. Bloating, I wouldn't consider as a problem of endometrium. It should be an endometrial adenocarcinoma. If it's an endometrial adenocarcinoma along with colonic carcinoma, then the entire thing will be Lynch syndrome. Then it will be MMR. If it's a random history of colonic cancer alone, with no other correlating findings, no other cancer, then I will prefer KRAS, right? These are two options. If it's endometrium plus colon, yes, you are right, MMR. Otherwise, it is fine. Perfect, Cash. Okay. Okay. This was a simple question. Can anyone tell the answer? It's a very simple one, right? You had the onion skin peeling appearance of periosteum, small round blue cell with PAS positive. It's a classical history of Ewing sarcoma. And Ewing's, the right answer is 1122, right? I'm sure this is one thing which is a PYQ. I'm sure you must have not made the mistake there, right? Ria, two options, endometrial plus colon. I'll go for Lynch syndrome and we'll mark MMR. If it's sporadic colon, we'll go with KRAS. Fine. You wrote the answer, so you'll be the better judge of that. Fine. Okay, done. Next question. This was the history given to me. Right. So 12-year-old boy with mild yellowish discoloration during fasting. See, whenever a body is put into stress, if that time alone the patient has jaundice or icterus, that's a very, very classical clue for Gilbert syndrome, right? And it's unconjugated, right? So unconjugated hyperbilirubinemia of this Dubin-Johnson cannot be, your Rotar cannot be, because these both are conjugated hyperbilirubinemias, only these two. Crigler-Najjar presents during infancy, at birth. It's not going to live, the kid will not live even till 12 years. During stress, having a jaundice, rest of the time asymptomatic, unconjugated hyperbilirubinemia, the undoubtedly answer is Gilbert syndrome. And I'm sure you must have made this right. Just rule this out and you must have definitely made the right one. Fine. Okay. Answer. This is a very simple question. I'm sure you must have not made a mistake here. Can anyone tell me the right answer? This I'm not sure. Because vegetarian diet has nothing to do with B12 deficiency or megaloblastic anemia. Vegan, yes, but vegetarian is just leading towards it. But one of the important histories was this. Has tingling sensation of peripheral neuropathy. If it's peripheral neuropathy related, vegan diet, undoubtedly I'll think of vitamin B12 deficiency and megaloblastic anemia would be the right answer, right? Okay. Fine. Perfect. No errors. This was a very simple question. Again, history might be something different. The clue which most of students said was Burkitt, and we had read this in multiple places. We always said it's Burkitt. It's Burkitt. If it's an EBV or translocation, whatever is the answer, options, go with that. It's Burkitt lymphoma, translocation 814, could be c-MYC, translocation 814, or EBV involvement, all of them, right? Yes, if it's neuropathy, undoubtedly, yes, B12 deficiency or megaloblastic anemia, that should be the right answer. Okay, we'll put B12 deficiency definitely, guys. Okay, done. Great. Was this a question there? Because only one student gave me a recall of this question, so I'm not sure about it. There is an elderly person having history of bladder cancer. Which of the chemicals was the person most likely to be exposed to, right? Benzidine or aniline dyes or aromatic amines. Any of this could be the right answer, right? Was this question there first? Sure, but I will take ABV also as the answer. We'll go with that. Okay, if this question was there, then the answer would be any one of them is the first option, benzidine, aniline dyes, or aromatic amines. Whatever is that will be the right answer. Fine. So this is one question which came from general pathology, the carcinogens, because almost no question came from the general pathology. This is one of them, right? And option A is the right answer for this. Great. Well done. Was this question also there? This also the same student gave me. So I'm not sure whether he got confused with the carcinogens. Was this question there? 60-year-old person working in the shipyard had a problem in the lungs. Exposure to which of them? He also said that it was asbestos fibers. It's a very simple question. Okay, something related to benzene will be right, Yash. If asbestos, if this question was there, it's a very simple question. Shipyard worker, reckyard work, manufacturing a reckyard, answer has to be an asbestos fibers. Again, a simple question, right? So when most of the students were saying the entire paper was difficult, video based, at least the lifeline could have been pathology. It's an easy one. Quite a few of them were easy. Some of them were definitely difficult, not denying. Quite a few of them were easy. I hope you must have answered all of them, right? Okay, this is again, it's repeated. Ignore that. Fine. So these are the questions which I got in pathology. There are a few more things which I don't know exactly whether it came or not. Some said that CMV came. Some said that Hodgkin's lymphoma RSL came. I am not sure about it. You guys have to tell whether these questions came or not, right? Some of them said that Hodgkin's lymphoma and EBV was there. Some students said that no, it is not Hodgkin's and EBV, it's Burkitt's and EBV. So I just added Burkitt's and EBV alone. I have not added Hodgkin's and EBV alone, fine? Yes, Patel. At least a ray of hope. Something would have been easy. You use that subject to score beyond 150. That's the ultimate goal, right? CMV was there. I would say appearance. See, it's a basophilic inclusion. CMV is nothing but basophilic inclusion. Classical wholesale never comes in CMV. It can be single inclusion. It can be intranuclear. It can be intracytoplasmic. Anything of them, CMV will be there, right? Basophilic, outside purple, outside it has to be CMV. Image-based question. I'm sure you must have answered that as well, right? Path was doable, right? I hope the other paper also is doable, and I hope you guys will complete the exam in flying colors and meet all of you soon at Delhi, right? Dr. Jasir, sir, are you ready?
Yes,
Okay,
sir.
over to you.
Ready. Thank you, Ranjit, sir. I hope I'm audible and visible. Just like all of our faculties were mentioning, a very mixed responses coming from our students this time. And in dermatology, I have collected almost 10 questions, which I would like to discuss with all of you. And you can just let me know whatever is the feedback, whatever the changes exactly. I hope that the derma questions were pretty much doable when I'm getting responses of other subjects. But one basal cell carcinoma was there integrated with derma. Okay, something with brain involvement. Fine, we'll see, Dr. Kashyap. Let me go one by one. So let me just start with the first question now. So in the first question, which I have got, it says that there's a 17-year-old patient who was having a severe acne vulgaris. And the MCQ itself was telling you that the treatment has to be with oral isotretinoin. And which of the following baseline investigations should be performed before initiating the therapy? Can anybody confirm if the question was almost the same? Yeah, it was there. Done. So here, as we know that when you are going to start a patient on isotretinoin, this isotretinoin, once you start the patient on isotretinoin, you will have to do all the routine examinations like CBC, LFT, RFT, and lipid profile. Lipid profile, especially because this isotretinoin, it can derange the cholesterol profile and the triglycerides, right? But in the options, you can see either it was a combination of CBC plus lipid profile, LFT plus lipid profile. Now, if this was the kind of options that you had, I would say that the best option should be LFT plus lipid profile. In one option, 3 tests was there. I marked that. Okay, RFT was not there. Fine. If RFT was not mentioned, but still RFT, it is routinely done, but not very significant in this case. But yes, a liver function test as well as a lipid profile, they both are going to be very significant tests, especially when you're starting a treatment for a patient on isotretinoin. Clear? ESR tha. Okay, I'll just note it down that ESR was present. Or PT was also given. Okay, if it is ESR and PT and all, those are not going to be relevant here. So you can easily rule out ESR, PT and all. But if you can find liver function test and lipid profile, please go for that. Okay, that should be the right answer. Shall I move to the next one? Now, moving to the next one. Yeah, a 25-year-old sexually active male presents with swelling in the inguinal region. So it is about a swelling in the inguinal region. On examination, there is an enlargement of both the inguinal and the femoral lymph nodes, producing a groove sign. So the person who gave me this question, he told that groove sign was specifically mentioned on an inguinal swelling MCQ. If there is a mention of a groove sign, in which disease are you expecting to see a groove sign? Can anybody answer? HbA1c was there. Okay, the previous question I understand. I will just note it down since you're telling about all those things. I will add HbA1c also. So once we come with a proper recall, we'll make the questions more accurate. Now coming to this one. Yeah, groove sign to tha hi nahi. Okay. Now because there are two questions I think which has come from the inguinal region. The second one was scabies. I'll come to that question in a while. Yeah, L1, L3 tha answer mein. Yeah, L1, L3. Now what is this L1, L2, L3? That is caused by chlamydia trachomatis. Okay, painless was there. Okay, there was a painless ulcer. Good. There was a history of a painless ulcer. Now, are you able to correlate now? If it is a painless ulcer along with a groove sign, the answer should be LGV. The answer should be LGV. And what is the causative in LGV? It is chlamydia trachomatis. And if you have gone through the last FMG exam, in the last FMG exam, they gave you the same topic. They asked you which serovirus is going to cause LGV. And the correct answer was, the most common was L2. Isn't it? L1, L2, L3. And L2 was the most common. And the organism is going to be chlamydia trachomatis. So this one should be the right answer here. Okay, thank you for giving all your feedbacks. I have noted down painless ulcer and groove sign. Okay, painless ulcer and groove sign. Thank you. So now let's move to the next one. There was a question something like this where a image was given. Someone was saying that there were two images of the axilla and the groin area. So if you could see a red color fluorescence in a wood slum image, and the MCQ was saying that the patient is having a asymptomatic lesion or a non-itchy lesion, non-itchy or a asymptomatic lesion, and a wood slum image was given. Now in such cases, what could be the diagnosis? Could anybody tell me? Okay, exact question. Painless ulcer he had after 3 days, groove sign. Okay, thank you. No, the answer, this is not Klebsiella granulomatous, because Klebsiella granulomatous is caused, that is the causative for donovenosis. We are not talking about donovenosis here. So in donovenosis, please remember, in donovenosis, you can see a pseudo groove sign. Pseudo groove sign. Now in this question, it was a groove sign. Groove sign should be LGV, and LGV is caused by chlamydia trachomatis. Done. No problem. Coral red was mentioned. Okay, if they have mentioned that it is coral red, the diagnosis is pretty clear. What is the diagnosis? The diagnosis should have been erythrasma. And remember, erythrasma, this topic also in derma, this is all repeat because erythrasma was also asked in the previous year, right? So what is the causative in erythrasma? Erythrasma is caused by, is it a fungus, is it a bacteria, or is it a virus that causes erythrasma? Coral red tha option mein or image different tha. But then coral red fluorescence can be seen, right? And यहाँ पे जो causative organism है, causative organism is Corynebacterium, isn't it? The causative organism should be a Corynebacterium, which means it's a bacteria. And what was the options given? Option not this. ठीक है, Nizaruddin, just tell me what were the options that were given. I can also correct the MCQ. along with you. So the takeaway message is, if it is going to be erythrasma, the answer should have been an antibiotic. And just check for which antibiotic. Maybe it can be a topical mupirocin which was given. Maybe it could be a fusidin ointment which can be given. Can be oral erythromycin, it could be given. So anything that is antibiotic should be the answer. Okay. Topical clotrimazole was there in the option. Okay, topical clotrimazole. Clotrimazole is an antifungal agent, so that cannot be the answer. Thank you, Ankit, for adding it. Antibiotics का history था. LAM plus fluconazole था. Okay, fluconazole is also already mentioned. Okay, so please go. In this MCQ, the correct answer should be a oral erythromycin. It should be an oral erythromycin because that is an antibiotic. Okay, and here the only changes that I will bring is, okay, terbinafine was given. Okay, steroids is there. Oral and topical erythromycin was given, sir. Fine. If oral and topical erythromycin is given, that could be the correct answer. Okay, that is about erythrasma because that is a bacterial infection. Moving to the next one, a patient presents with a linear depressed lesion over the forehead extending into the scalp associated with a localized alopecia. Now this question, I would say it's a bit difficult if they had not given you the image, because if with an image it could have been an easy diagnosis, but here you will have to try to visualize this based on the sentence. Because when I asked the students who gave me this question, they were like, image was not given. It was only mentioned that there was a linear lesion, depressed lesion in the forehead and along with an alopecia. Now, what are we talking about? And they said that there are multiple options, all sounded Latin or French. This is exactly what the student told me. Now here, why is it a linear lichen planus, N. coupe de Saber, alopecia areata or DLE? What could be the answer? So Kunal, clarithromycin, if it was there in the option, then that is a better one. I mean, among all the options, some of you are saying erythromycin tha, somebody is saying no. But yes, if there is any antibiotic that is given, then please go for that. Okay, alopecia question mein tha. Okay. Now, yeah, image was not given. Now, this is exactly the image what we are talking about in this MCQ. Okay, once you get a depressed lesion, it is taking a shape like a sword. Okay, if you get an injury with a sword over the scalp. Now, this kind of a lesion can be seen in a type of morphia. Okay, it's seen in morphia. And this morphia is a type of scleroderma. Scleroderma. So this is a linear morphia which you can see, and this linear morphia, because since it takes a shape of a sword, that is why this name called de Saber. So this should be N. coupe de Saber, and that is seen in a linear scleroderma or morphia. Clear? So Shahir Azim, thank you for confirming. Yeah. Atropica something was given in this question. Yeah, okay. Atropica something. We'll check. So anyways, in this one, there's no confusion. N. coupe de Saber, it can be seen in linear morphia or scleroderma. Moving to the next one, there were two questions from leprosy, right? Let's see the first question from leprosy. A patient with borderline leprosy was mentioned and is already taking a multi-drug therapy, presents with redness and swelling of the existing lesion. You need to confirm whether the changes in the skin was mentioned in the MCQ or was it given as an image. Image of a borderline leprosy was given. Okay, I just wanted to know that. And what change in the treatment is required was asked. B hoga answer. All the questions were straightforward from Dharma. Yeah, I felt most of them were straightforward. Yeah. Now here, let us see. Yeah. Here, continue MDT, because we all know that lepra reaction is what is being mentioned here. In a lepra reaction, since it is not a drug reaction, you are never going to stop the multi-drug therapy. The answer should always be continue multi-drug therapy. But what are you going to start here? Are you going to start a thalidomide or are you going to start a steroid? Image nahi tha, symptoms tha bas. ठीक है. Done. Yes, the same question. The answer should be steroids, not thalidomide. You start on steroids. Okay, start betamethasone. Okay, if it was mentioned betamethasone, yeah, go for betamethasone. It can be prednisolone, it can be betamethasone, any steroid. Okay, that is a treatment of lepra reaction. So here the diagnosis was a lepra type 1 reaction. The diagnosis was lepra type 1 reaction. And in the first paper, again, the surprising thing was in the first paper, I got to collect few questions from Dharma. Now, what is the question here? A 28-year-old pregnant woman is newly diagnosed with a multibacillary leprosy. What is the most appropriate treatment? Was there a question on leprosy in pregnancy? That too in the first paper today. Could you confirm? After 3 months treatment, he skipped the medicine, then start the skin lesion. ठीक है कार्तिक, if that is also mentioned in the previous question, still fine. आपको क्या करना चाहिए? Continue करना चाहिए multi drug therapy, right? And after that, you start the patient on steroids as well. Okay. Now here, yeah, if same tha, option different. No, it was like what's IR? Okay, so if there is a pregnant woman who is having a leprosy, then are you going to defer the treatment? Are you going to give a single dose of rifampicin or only dapsone, or are you going to continue with the standard MDT? If this was a question, we never had mentioned in any of our class that there is a specific treatment in pregnancy. In pregnancy, the standard MDT is going to be applied. Okay, there's no specific other treatment in pregnancy. The standard MDT with all the 3 drugs, that is dapsone, clofazimine, and rifampicin. This could be the answer in a patient who is having leprosy. Doses mentioned tha or question ye nahi tha. Okay, normal treatment of leprosy was in the option. In that, rifampicin 600, dapsone 300, and the third drug. Okay, so the question is mostly adding the doses as well. So in the doses also, yeah, you just need to go for the same adult dosage. Okay, you should go with the same adult dosage. But many of you are saying that ye nahi tha. But some of you are saying that this was asked as well. But please remember here, just go with the same standard regimen if you feel that the same question was asked. Doses wala different question tha. Okay, there was another question of leprosy drug doses, right? Okay, clear. Leprosy hypopigmented lesion with radial nerve involved. Was there another question as well in leprosy? How many questions came from leprosy? So someone else is saying that leprosy 3 hypopigmented lesion with radial nerve involvement. Was that asked as well? Possibacillary था, less than 5 lesions mention किया था question में. Dosage पूछा था MDT का. अच्छा, okay. So this is the same question asking the dosage. Rifampicin 600 mg was there. Okay. Clofazimine, was it mentioned? 300 mg and 50 mg daily. Dapsone 100 mg. So if there is any deviation from all these things, that could be the odd one out, right? Okay, done. Thank you. Thank you for confirming. We will make these changes in the active recall later. Okay. Now moving to the next question. Thank you for mentioning it here. Okay, fine. Now, a 4-year-old child presents with fever, oral lesions, and vesicular lesions over the palms and soles. And again, this topic, 2 questions had come from the same topic, that is hand, foot, mouth disease. One question, what I could understand is it was asking like, what is the diagnosis? The second one was mostly asking regarding which is a causative organism. Now, if this question was regarding the diagnosis, pretty easy one, right? I'm sure that none of you must have made a mistake. If you understand vesicles over the palms, soles, oral mucosa, and the trunk, along with fever, the answer should be a hand, foot, mouth disease, right? First, my pregnancy with previous abortion trying to conceive, which drug should be avoided tha? Okay. Coxsackie virus in the option. Yeah, Coxsackie virus ka ek question hai. This is the next question which I've collected because what I could confirm from multiple students is that 2 questions came from the same topic. The second question was, a child is diagnosed with HFMD. What is the most common causative organism? And the only confusing 2 options were, in one option, it was Coxsackie virus A16. The other one was Coxsackie virus B, A or B. So even if you remember it is Coxsackie virus, you should be more specifically knowing which one, right? Because this is a disease which can also be caused by enterovirus. Luckily, that was not there in the option. What's the correct answer? Yeah, Coxsackie virus A. Okay, only A was there, 16 nahi tha. Okay, so I'm just striking off 16. So Coxsackie A, Coxsackie B was there in the option. Done. एक क्वेश्चन था Coxsackie virus A and B. हाँ, Correct. Done. Thank you for confirming that. Now moving to the next one. This question again, paper 1, if I recall it right way. Cauliflower-like growth was seen in the genital region, but there was no image was mentioned. It was only told to me that there was a cauliflower-like lesion that can be seen in the genitalia. So when you have to visualize a cauliflower-like lesion, what could be the diagnosis? The diagnosis of a cauliflower-like lesion should be a condyloma acuminata, isn't it? A condyloma acuminata, as in genital warts. So what is the causative of a genital warts? Yeah, that could be human papilloma virus. Did they ask you very specifically like 6 and 11, or it was just HPV? Yeah, Binav Pandey, Kashyap, all of you, thank you so much for confirming. और एक क्वेश्चन था सुमिट्रिप्टन जिसमें ओके, बट आई डोंट थिंक दैट कम्स अंडर डर्मा. पहले वाले टारगेट लीशन वाज गिवन. इससे पहले वाले में टारगेट लीशन वाज गिवन. टारगेट लीशन, is it in hand foot mouth disease MCQ? Target lesion was given. Just let me know. Okay, only HPV was given. 16-18 was present. वो दूसरा क्वेश्चन था, पैपिलोमा था. ठीक है, यहाँ पे if it is only HPV, then that is the right answer. Clear? And how about this question? A man presents with intense itching, especially at night, and the lesions over the scrotum. He lives in a crowded environment. The clinical image is shown below. What's the primary lesion that you can see in this condition? See, the examiner is asking what is the primary lesion of this condition. So you can see that an image was given, probably something like this. I just took one random image because it was a scrotal thing. For me in this MCQ, if there is a mention that there is an intense itching, especially at the night time, because this especially at night time shows nocturnal exacerbation. It shows nocturnal exacerbation. So if there is a nocturnal exacerbation, that happens in a disease called as scabies, right? It should be scabies. In scabies in the genitalia, you can see something like nodular scabies. Nodular scabies can be seen in the scrotum. But in this disease, what is the primary lesion? Yeah, the primary lesion should be burrows. So it should be burrows. That is why, yeah, most of them were like burrow kiya tha. Yeah, now don't get disappointed. It should be burrows itself. Okay. Okay, psoriasis was in the option. But if they are asking regarding the primary lesion, how come psoriasis will be in the option? No idea, but yes, scabies tha answer mein, right? So be reassured. Okay, if they have given options like atopic dermatitis, psoriasis and all, then scabies can be the correct answer. Okay, then scabies can be the answer. I guess in derma, that is all the questions that I could collect, and most of the topics were much predictable or the more in connection with the PYQs itself. And these are the questions which we had discussed in our predictor series as well as the FMG marathon sessions also, right? So thank you so much. The leprosy question with hypopigmented lesions mentioned, the culture was negative for M. leprae. Yeah, the culture may not turn out to be positive in most of the cases. Not easy, right? Because again, M. leprae is an organism which cannot be cultured in vitro, isn't it? So culture negative hi hoga. Done. So I think that is all about scabies ka related करके पूछा था. That is all about the questions from dermatology, and I am sincerely wishing for a excellent result. So no worries, even if you can't recall all the questions, you may feel that the exam did not go well, but the results will definitely follow good. I'm waiting for your good results, and over to the next faculty. Thank you so much.
Hi Vivek sir, over to you. So guys, Vivek sir will be joining soon, and he will be discussing the questions on physiology. So how was your experience with the physio questions? Hi sir. Over to you, sir.
Hello friends, this is Dr. Vivek Nargirkar and I'm going to discuss some physiology with you. May I start, sir?
Yes, sir, you can proceed.
Okay. So, how was your exam, students, friends? I'm sure you must have done well. And ever since the exam ended, I've been trying to dig deeper and deeper, asking about the physiology questions. But it appears that most of the students were unable to recall physiology questions because most of them said, एक तो पहला थोड़ा सा शॉक बैठा था कि वो वीडियो बेस्ड क्वेश्चंस और फिर इंटीग्रेटेड क्वेश्चंस थे. एवरीबडी सेड द सेम थिंग कि इंटीग्रेट किए गए थे. तो फिजियोलॉजी क्योंकि ये सारे ही सब्जेक्ट्स में आता है तो ये सारे सब्जेक्ट में इंटीग्रेट भी हो गया एंड देयरफॉर स्टूडेंट्स वर अनेबल टू रिकॉल मेनी फिजियोलॉजी क्वेश्चंस एंड देयरफॉर मेरे पास जितने भी क्वेश्चंस है वो हम डिस्कस करेंगे. तब तक हाँ, इमेज बेस्ड क्वेश्चंस आप मुझे बता सकते हो कि कौन से इमेजेस थे सो दैट वी कैन आई विल नोट इट डाउन, वी कैन डिस्कस इट और फिर आगे चल के कमिंग वीक में हम प्रॉपरली भी इसको एक बार फिर से डिस्कस कर सके. ऑल राइट, ओके. तो एक क्वेश्चन जो स्टूडेंट्स ने बताया वो ये था श्वोस्टेक साइन के ऊपर. एक क्वेश्चन था वीडियो बेस्ड क्वेश्चन. तो श्वोस्टेक साइन मतलब क्या, ऐसा साइन करके दिखाया था. एनीवेज, अगर वो श्वोस्टेक साइन था तो बेसिकली क्वेश्चन क्या था ये आप रिकॉल कर सकते हो कि क्या पूछा गया था एग्जैक्टली exactly. और जब तक आप रिकॉल करते हो तब तक मैं थोड़ा सा उसके बारे में बता दूं आपको कि पैराथायराइड आपको पता है इट कंट्रोल्स द प्लाज्मा कैल्शियम लेवल्स और फिर हाइपोपैराथायरॉयडिज्म लीड्स टू टिटेनी, डिक्रीज प्लाज्मा कैल्शियम. तो उसमें ये दो साइंस दिखाई देते हैं, एक ट्रोजूस साइन और दूसरा श्वोस्टेक साइन. अब ट्रोजूस साइन में ओके ओके टैप किया था फेस पे. ओके, ऑल राइट. सो क्वेश्चन क्या था, व्हाट वाज द क्वेश्चन ऑन दैट. एनीवेज, ट्रोजूस साइन या श्वोस्टेक साइन में देयर इज spasm of the muscle, carpopedal spasm, that's in the Trozus sign, and facial muscles go into spasm when you tap over the angle of the mandible, that's Schwostek sign. लेकिन क्या आपको पता है कि ये जो Trozus sign है, when you apply the BP cuff and raise the pressure in the cuff, तब जाके आपको वो carpopedal spasm नजर आता है, या फिर टैप करने पर फेशियल मसल्स का स्पाज्म आता है. ये क्यों होता है क्विकली बता देता हूं आपको, तब तक आप रिकॉल कर सकते हो क्वेश्चन को. बेसिकली हमारे जो न्यूरॉन्स है, नर्व मेम्ब्रेन्स, उनमें जो सोडियम चैनल्स है विच आर कॉजिंग द डीपोलराइजेशन एंड इंपल्स प्रोपेगेशन, तो उनके स्टेडी बिहेवियर के लिए प्लाज्मा कैल्शियम का एक सर्टेन लेवल मेंटेन रहना जरूरी होता है. अगर प्लाज्मा कैल्शियम फॉल हुआ जैसे कि टिटेनी में, हाइपोपैराथायरॉयडिज्म में, तो क्या होगा, the sodium channels in the nerve membrane they become unstable. और उसके बाद with a faint stimulus those sodium channels are activated and there is a continuous impulse, volley of impulses sent to the muscle. तो faint stimulus देना जरूरी है. वो faint stimulus आप ऐसे देते हो या बीपी कफ अप्लाई करके प्रेशर रेज करते हो, and that's when the muscles go into spasm. And that's the physiology of Trozus sign and Schwostek sign. तो एक अहम कारण होता है उसका, वो है हाइपोपैराथायरॉयडिज्म टिटेनी का, और दूसरा है अल्कलोसिस. इवन द अल्कलीज आर नोन टू मॉप अप द आयोनाइज्ड कैल्शियम. आयोनाइज्ड कैल्शियम जो है प्लाज्मा में, तो अल्कलीज उसको मॉप अप कर लेते हैं और उस वजह से प्लाज्मा का कैल्शियम कम हो जाता है एंड देयरफॉर दैट रिजल्ट्स इन टिटेनी. तो ये एक क्वेश्चन था. और किसी ने कहा एलवी पीवी लूप, लेकिन क्या वो फिजियोलॉजी से रिलेटेड था. नीचे लिखा है किसी ने कि ओपनिंग स्नैप वाला क्वेश्चन था, तो आई एम श्योर कि मेडिसिन में वो डिस्कस होगा. ओके, बस वीडियो था, लेकिन आगे कुछ? ओके, टैप ओवर द फेस एंड ओके, फाइन फाइन। सो ये क्वेश्चन था, और जो दूसरा क्वेश्चन जो मुझे मतलब फिजियो से रिलेटेड मिला अब तक, वो था ग्लूट से रिलेटेड। और मुझे याद है जब हमने एफएमजी मैराथन और उसके बाद प्रेडिक्टर सीरीज भी किया था, उस वक्त मैंने कहा था कि ग्लूकोज ट्रांसपोर्ट के ऊपर एक क्वेश्चन जरूर आता ही आता है। तो शायद वो क्वेश्चन ब्लड ब्रेन बैरियर से रिलेटेड था। दैट इज के प्लाज्मा ग्लूकोज लेवल दिया है वो नॉर्मल है, और सीएसएफ ग्लूकोज लेवल दिया है वो काफी लो है। सो आगे पूछा है कि ग्लूकोज कैसे ट्रांसपोर्ट होता है फ्रॉम द प्लाज्मा इनटू द सीएसएफ, मींस क्रॉसिंग ऑफ ब्लड ब्रेन बैरियर। तो बेसिकली क्वेश्चन ये था कि ग्लूकोज क्रॉसेस द ब्लड ब्रेन बैरियर बाय यूजिंग विच ट्रांसपोर्टर, एंड ऑप्शंस आई एम श्योर ग्लूट 1, ग्लूट 2, 3, 4 ऐसे रहे होंगे। सो GLUT1 is involved in the blood-brain barrier. I mean, transport of glucose across the blood-brain barrier is by using the GLUT1. Okay, तो GLUTs को एक बार बाय हार्ट करना, SGLT को प्रॉपरली देखना, इस पे एक क्वेश्चन हमेशा आता ही है एफएमजी में। तो आई एम श्योर कि इसका आंसर आपका करेक्ट आ गया होगा। ओके, so far I've got only these two questions. बाकी आप ग्लट्स बाय हार्ट करके गए होंगे आई एम श्योर, और ग्लट्स, एसजीएलटी वगैरह, तो ये आपका क्वेश्चन तो डेफिनेटली 100% करेक्ट आया होगा। सो जस्ट अ फ्यू थिंग्स, हमने एक एफएमजी प्रेडिक्टर सीरीज रन की थी, और मेरे पास तो अभी फिलहाल ज्यादा क्वेश्चंस नहीं है टू से कि हमने प्रेडिक्टर सीरीज, मैंने ये क्वेश्चंस बताए थे वो आए थे, लेकिन ये दोनों क्वेश्चंस डिस्कस हुए थे इंसिडेंटली अबाउट द पैराथायरॉइड एंड अबाउट द ग्लट ट्रांसपोर्ट। सो आप ये प्रेडिक्टर सीरीज will be a good guiding material for the upcoming batches, I believe. Therefore, हमारा marathon predictor series is mostly bang on. Therefore, I would suggest you to always, those who are preparing, आप लोग, I hope कि आपने exam दिया है and you are praying कि you don't have to give the exam again, and I'm sure you won't have to. So all the best. I'm sure your result will be great. Thank you, sir. Over to you.
हाय सर, एक दो क्वेश्चंस थे। सो अगर स्टूडेंट्स क्वेश्चंस रिकॉल नहीं कर पा रहे हैं फिजियोलॉजी के, इसका मतलब फिजियो के क्वेश्चंस थोड़े से कॉम्प्लेक्स थे। डू यू इंटरप्रेट लाइक दैट? Well, it looks like the sir has lost the connection. So guys, I think the physio questions were a bit on the complex side because sir has been trying to communicate with the students and get the recall, but students are not able to come out with the STEM. हाँ सर, ऐसा कुछ आया था, एक क्वेश्चन आया था, we are in that situation. So mostly physio were either completely integrated into clinical sciences, or they were like maybe top of the notch kind of questions. Maybe there were some image-based questions, but yeah, we'll come out with a full-fledged recall soon. Once Dr. Alekhya is ready, she will take you through the orthopedics questions as well. Dr. Alekhya, if you're ready, over to you.
Yes, sir. Hello, everyone. Yes. Can you hear me? Yes, I feel orthopedics was bit easy compared to all other subjects. So mainly from ortho, it was mainly from the nerve injuries. If you can see, there were all three important nerve injuries questions which were asked in the exam. So I'm very sure that who all attended the FMG marathon and have practiced the predictor series book, I have easily cracked all the ortho questions. Is that true? Yes, some union. Yes. Okay. Let's go through paper. Yes. So let us first see the first question. So this is the only question I've come up with the entire stem and the options. So here I'll just quickly run through the question. So there is a fracture Hi, Shafali. Ulnar tunnel syndrome. Okay, so they asked you about the neck of the fibula fracture. Okay, and they told you one important thing what we can see here is the weakness of the dorsiflexion and the eversion of the foot. Okay, so whenever there is a weakness of the dorsiflexion and the eversion of the foot, what does it mean? It is mainly the common peroneal nerve which is involved. Yes? Yes, was the answer the common peroneal nerve? All you all wrote. If it was to be deep peroneal nerve, it is only dorsiflexion, right? Dorsiflexion would be lost. Eversion is still present if it was deep peroneal nerve. So they have clearly mentioned that weakness of dorsiflexion and eversion with the sensory loss of dorsum of the foot, which is very, very important. So the answer here is the common peroneal nerve. The CPN is the answer. Okay? Yes. The first question, yes. And next, what is this? So it is very clearly, the image is very, very clear, and you all know that this is what? So this is the pointing index, right? There is a pointing index, is unable to make a fist, and you can also see there is a weakness of the thumb opposition. Okay? Yes. So the answer here is median nerve. We have already discussed anything related to thumb and the index finger. The answer would be median nerve. Very good. Perfect. C. Next, I am not pretty sure about what was asked in the carpal tunnel syndrome, but what I can recall is there some nerve was asked, there were some question given, and the answer is like the median nerve. Yes, can you help me regarding the carpal tunnel syndrome? Yes, perfect. The answer is C for the previous one. So regarding the carpal tunnel syndrome, if they mentioned you about some symptoms and asked you which nerve is involved, definitely the answer is median nerve. Okay? Yes. And the second one, the CTEV. The CTEV question was asked, and what I could only get is 14-year-old patient. So this, yes, I'll come to the ulnar nerve, ulnar tunnel also, Ajay. If it was only dorsiflexion, as somebody is mentioning, only dorsiflexion, then it would be deep peroneal nerve. Okay. Okay, now coming to CTV, if they clearly mention that it is a 14-year-old patient. So 14-year-old patient, 14-year-old patient with neglected CTEV. Yes, here you have to remember anything after 12 years of age, usually the answer would be triple orthodesis. Okay, we only try to fuse it because the bones are all completely deformed by this. Okay. So triple arthrodesis would be the answer for CTEV. So triple arthrodesis. So what are the other options would we expect? So first one would be osteotomy because we can perform osteotomy. Okay, gradual correction with the external fixator as well. So external fixator is one more thing which we can add. Right, so these two will be mainly for 14-year-old patient. Okay, so gradual correction with the CTV. Yes, it is a neglected CTV. So gradual correction would be with external fixation, but mostly it is triple arthrodesis. Yes, can someone tell me the options? Ponseti, usually that is casting, is not usually performed with this neglected CTV. Ponseti is usually not performed. It is surgical treatment what we do. So surgery is must for this case. So surgery is must. So can you mention some options which is related to surgery? No. Dennis Brown also we can't do. It is a 14-year-old, right? Not 4-year-old. Okay, so this is CTV. That is, we'll come to that radial question also. We'll come to the radial question. So what, so what they're mentioning is the wrist drop. So this, I think this is a video-based question, what one of you is mentioning. So video-based question is something like the patient. Yes, the patient had surgery to the radial neck and then there was, where did she go? Okay, if the options was Pavlik harness, triple arthrodesis, osteotomy, Ponseti, then the option is triple arthrodesis. Yes. Yes. So if there were wrist drop, so video-based question, and they've told you that there is absent of wrist extension. So something related to absent of wrist extension is nothing but your wrist drop, and the answer here is your radial nerve. So this is your answer. So answer here is your radial nerve. Right? Yes. Okay, this is about the wrist drop. I think this was asked as a long question. So this is a long question which was asked. They were given some details regarding this question, but the gist of it was there was absence of wrist extension. So that is wrist drop. Okay, right. So the answer here is radial nerve. And if they were told that something related to the forearm related, then the answer would be PIN. That is posterior introitious nerve. This we have clearly discussed in the predictor series also. Yes. Yeah, anything. If it was wrist drop and radial nerve was given, that could be the answer. If it was finger drop, if there is a loss of finger extension, then it is your posterior introitious nerve, right? Okay, pin would be the answer. If AIN and PIN are both there, then pin would be the answer. Yes, if it was finger drop, so loss of finger extension or finger drop is PIN. No more confusion regarding this. Okay, either it would be a radial nerve or pin. But if both are mentioned, it is pin. If both are mentioned, it is pin. Yes, okay, done. And the next one. So this is one they were asking about the Frohman sign. So the Frohman sign was positive, which was given, and which nerve would be involved if the Frohman sign is positive? Yes. So even if radial was present and if it is finger extension is absent, it is PIN, branch of radial nerve, that is your posterior introitious nerve. Okay, now coming to the Frohman sign, what would you think be the answer? Frohman sign is for your thumb, right? Even the thumb is involved, the answer is ulnar nerve here. So the answer is your ulnar nerve. So this is the card test they have given, and I have got to know that the Delhi Metro card something was used here. So they were unable to hold the card properly with the adduction, and then there is a flexion of the thumb. So this flexion of the thumb is called the Frohman sign, and Frohman sign positive means that is ulnar nerve palsy. Okay. Yes, ulnar nerve palsy. And then the fat embolism, the very, very important and favorite questions. I've mentioned that this will be definitely asked in the exam at the end of the series, that the femur fracture, right? Femur fracture and all the classical signs where the patient will have the breathlessness, then he will have the confusion, and then they'll have the petechiae. So if the answer with any long bone fractures, not only the femur, the options of any long bone fracture with the triad of these symptoms only after 42 to 72 hours. And this is exactly what the picture of the fat embolism. And this is a very, very important question which is expected, right? No more confusion about this. So even if you see anterior and posterior introitious nerve for card test, the answer would be ulnar nerve, right? Anterior introitious nerve is a branch of median, posterior introitious nerve is branch of radial. So no confusion in that. The answer would be ulnar nerve. Yes. For card test, the answer is ulnar nerve. For finger drop, the answer would be your and posterior introitious nerve for finger drop. Fine. Yeah, patient can't move his fingers after radial head fracture is posterior introitious nerve. Frohman sign is ulnar nerve. Yes, Sarah, PYQs here. Okay, so the fat embolism is clear, right? And then the ulnar nerve, the whatever you're telling is the ulnar tunnel syndrome or loss of sensation over the, the little finger, and all this is ulnar nerve. Or it could be the branch of, yes, okay sign is AIN. No, pulmonary embolism is not. Patient comes after post 3 days is not pulmo. Okay, what about the ulnar nerve they gave? Oh, there was no ulnar nerve only in this option. But it could not be AIN or PIN because see, AIN is the median nerve, right? So if he's able to do flexion, then AIN is definitely present. So if OK sign, we are telling OK sign is this, right? So if OK sign is positive, that means if he's completely making a O, then it is AIN. So definitely it is not AIN. If he's able to flex the thumb, flexion of the thumb is by AIN, right? So if he's doing the Frohman sign means AIN is not paralyzed. And PIN question is not. PIN is for your extension. Yeah, distal part of the ulnar was present. Something related to ulnar would be the answer. No doubt about it. Okay. So no confusion between AIN and PIN. And this ulnar nerve, again, I have not got the entire question here. Okay, ulnar nerve, again, if you see the what are the options they would get. So again, the adduction of the fingers. So adduction, abduction, both by the ulnar nerve and the sensation. Sensation mainly on the little finger side. So this is the sensations for your ulnar nerve. So 1.5 finger. Okay. So this is about the ulnar nerve. Okay, pointing index was discussed. That is your median. Yeah, Guyon's canal or ulnar tunnel syndrome is all again related to the loss of the sensations over the little finger, yes, and the ring finger, yes, and there would be hypertrophy of the hypothenar muscles, right? Your adduction, abduction, or your PAT test and DAP test. Okay, so all these are related again to the ulnar tunnel syndrome. OK sign is for your AIN, right? Or AIN is for your median nerve. CAR test is CAR test is again for your ulnar nerve. So card test. No confusion. CAR test is for your ulnar nerve. Okay, here we are talking about the Frohman sign. Here we are talking about the Frohman sign, right? Frohman sign is ulnar nerve palsy. Okay, Frohman sign is ulnar nerve palsy. CAR test is again for your ulnar nerve. Okay. Fine. Yes. Now don't get confused with the multiple questions asked. So radial nerve, you know the wrist extension. So ulnar nerve, you know all the little finger and the ring finger. Frohman sign is a specific test because it is again median nerve. But here the adductor pollicis, the only muscle, the adductor pollicis, which is supplied by the ulnar nerve is damaged, right? If he is able to do the Frohman sign, that means flexion of the thumb. Flexion of the thumb, if he is able to, flexion of the IP joint, I mean. So if he is able to do, then AIN is intact. Okay, so this cannot be AIN or PIN. Okay, it should be ulnar nerve. Okay, here CAR test was not mentioned, but there were certain signs and symptoms which were mentioned about the ulnar nerve or ulnar tunnel syndrome. Okay, so I would definitely, what about the Faber? So Faber is mainly flexion, abduction, and external rotation. It is mainly for the sacroiliitis. Can somebody mention about what is the Faber they were asking? Frohman Naita? Okay. But what most of them were told is that Frohman sign, it was clearly given as the Frohman sign. Frohman sign is different, CAR test is different. Okay. So what about the Faber? Faber is the test. It is mainly for the sacroiliitis. Yes, can somebody mention? Okay, if there is some abscess kind of question in the sacroiliitis, so something related to sacroiliac joint. So the SI joint is mainly related to the Faber test. So Faber test is positive in the SI joint. So this also we have discussed. Yes, okay. So the answer here is the sacroiliac joint if something is related to the Faber test or the sacroiliac. Yes, answer was Faber, right. Ortho card test was given, asked the nerve responsible. Again, card test is ulnar nerve. Fine. Okay, now don't get confused much. We will see this again clearly. You can keep sending your queries and the questions and options so we can come out with the full print of the entire stem of the question and the options. Yes, yeah. Thank you so much. Over to the next faculty. Thank you.
Hello everyone.
You can proceed now.
Yeah, okay, thank you. So, hello everyone, good evening. I hope that you all had a great exam. So, from radiology, I would say that very few direct questions were there, which we have recalled, and most of them were integrated, like from ENT section. And so, of course, we have done the recall, but if it is wrong or if you feel that something can be added, then please put it down in the comments and I'll try to answer them, right? So, let's start with the first question. What is the full form of radiation safety principle in that is ALARA? So it's an easy one. Just a minute, I think there is some technical glitch. Okay, yeah. So what is the full form of the radiation safety principle ALARA? So this is an easy one and it is as low as reasonably achievable. No need to see the other options as well. It's a very direct one, right? Yeah, EDH will come to EDH also. So what is ALARA? Just a quick revision: time, distance, and shielding. That is the three main principles which the ALARA focuses. We have to minimize the radiation both to the patient as well as to the healthcare worker, and it mainly depends upon three principles, that is time, distance, and shielding, right? The exposure of the radiation should be for the minimum of the time. The distance, as per the inverse square law, intensity is inversely proportional to the square of distance, and shielding, of course, you have to wear lead aprons, or a proper shielding has to be done so that the least radiation goes to the technician as well who is performing this, as well as to the patient, right? So that was the first question, very easy one. The second question, some confusion is there whether a CT image was given or whether an X-ray was given. I got a recall that there was a question, particularly this. Can you see this? This is a classical string of beads appearance or string of pearls appearance. And this is characteristically associated with small bowel obstruction. So was this question? String of beads or string of pearls. So this is mainly because of the air that has trapped between the valvula conniventus, right? Abhinav, this was not there. Okay, I got and recall that a small bowel obstruction question. Was there something related to string of beads or string of pearls? Acha, CT tha? Okay. So on CT was a question. So I'll just rectify this. A CT image was given to you on the small bowel obstruction. Okay. Was it on small bowel obstruction? No image was there. They asked the sign. Okay, there was no question. So I got this question, so I have included. But if there was a CT image, particularly again with, was there a CT question on small bowel obstruction? Acha, okay. So we'll move to the next question. I think we have not got a proper recall, and I'll come back with a better recall of this question. Okay. So let's move towards the third question. So this, everyone has given me this recall, and this is the one question which everyone is telling me that EDH was asked. We have discussed EDH in both the predictor series as well as we have discussed in the marathon as well. It's a very high yield almost every time. Either they ask a question on EDH, SDH, or subarachnoid bleed. So you can see that this is a convex shape bleed, and if it is, especially if it is associated with the fracture, more commonly it is arterial bleed, middle meningeal artery, do not cross the sutures. These are all characteristic points of EDH. Okay, some also gave me a history that cricket ball injury was mentioned. So this is a very classical EDH type of a question was there, right? Okay. is saying that there was a question on small bowel obstruction. If someone can put a proper stem of that question, that would be really useful to me so that I can get a better question for you all guys. Okay. Okay. Now moving towards our next question. Was this question there? Only one of the students told me that a question of intraparenchymal bleed, particularly a putaminal bleed, was given to you, and then they have asked what was the treatment of the given pathology. Was this question there? Okay, so if such a question was there, it's if they have really shown you such a type of an image in which there was a bleed, I would say that initially, if exactly this image was there, then the management would be a conservative medical management, particularly to control the hypertension. The target to control the hypertension would be approximately by say 140-80 mmHg. And if suppose they have given you a large bleed with a massive midline shift, the volume more than that of 30 cc, something like that, then you have to do for a craniotomy. So Kashyap is telling, yes, it was there. Some of them are saying that it was not there. So it's very confusing. It was not there. Okay, okay. So we'll ignore this question. This was not there. Okay, okay. Treatment is there. So treatment में did they give the CT image? CT image दिया था आपको कि नहीं दिया था? कि सिर्फ medically आपको SAH was there and they asked management. Okay. Putamen पूछा था आंसर में. So there was an image of subarachnoid bleed. Particularly, I would say that the bleed was located in the sulci, something like that. Kashyap is saying 100% it was there. So ask Kashyap whether this question was there. Everyone is saying no, this question was not there. Yes, Xavier, if subarachnoid bleed was there, then nimodipine will be given. Treatment option were different, ma'am. Okay, the treatment option would have been different. Okay, chalo, now let's move towards the next question. So this is also one of the questions which I am getting a lot from all these students. Diagnostic criteria for PCOS. So this was an easy one. So what is the latest criteria as per the 2023 Rotterdam criteria? Whether it is A, B, C, and D, an easy one. Would you like to answer? So the option is more than 20 follicles in at least one ovary, or the ovarian volume of more than that of 10 ml. If they have not given you directly PCOS and if they have just given you the image, then it's very easy to identify. See, the ovary are there and this black structures, this small cysts that are particularly arranged in the periphery, and there is a central echogenic stroma that is very characteristic for a polycystic ovarian morphology, right? So more than that of 20 follicles, the size is 2 to 9 mm, okay, and the volume is more than that of 10 ml. Yes, answer is more than 20 follicles. So I think this was there. There is no confusion in this one, right? Now moving towards our next question, treatment of the given pathology. So again, there is a confusion whether a MRI image was given or not. So this is particularly the black turbinate sign, where it is seen the black turbinate sign. Again, we have discussed this in our marathon as well. The black turbinate sign, it is characteristically seen with invasive mucormycosis, right? Invasive mucormycosis. So this is an integrated type of question. I'm sure that the ENT and the microbiology faculty, they will also come with this particular question. So the answer over here is quite direct. It is IV amphotericin with debridement, right? IV amphotericin with debridement. Oral, if I'm not sure whether these options were given to you, A, B, and C, but definitely for invasive mucormycosis, I think there was a hint that the patient is diabetes. Was an image given in this question? 100% there, Ankit, ma'am. One option was segment and one was ovary. Okay. Image was there. This was not in the option. So IV amphotericin with debridement, this was not the option. Okay. So some of them told me that directly the diagnosis was actually given in the question. Image was there, but they have written in the question that invasive mucormycosis was there. Okay. So I think I will go ahead with the next MCQ. Many of them have given me a thumbs up that this was the option that was given, right? Okay. Now moving towards the seventh one, advantage of brachytherapy. So again, we have discussed this in the marathon. There are two important types of radiotherapy. What is radiotherapy? Using ionizing radiation to kill the cancer cells. We have two types, teletherapy and brachytherapy. Tele means dur se, right? Brachy is close. So what is the main advantage of brachytherapy? Because we are very closely placing our radioactive source to the tumor. It will mainly target your your tumor cells, right? And your adjacent normal tissues will be spared. That is the main advantage of brachytherapy. We use mainly cesium or iridium-192. These agents we mainly use, and they will be directly emitting your gamma rays towards the tumor, right? Now, what is the advantage for the option over here? I have got only few options. I think the correct one is more important. So it delivers a high radiation dose to the tumor with minimal exposure to the surrounding normal tissues, right? This was the question. I'm not sure whether these other A and B such options were there, but I'm more concerned about what was the correct option. So yes, Abhinav, the answer is C. Now, what is the principle of PET? So was an image given or was directly a one-liner question was there? What is the principle of PET? So everyone knows that PET's principle is mainly on glucose metabolism using the FDG. But was an image given to you or directly it was a one-liner type of a question? So the answer over here is glucose metabolism. I think some of the students told me that an image of liver metastasis was given. So right question, Abhinav is telling me it's right. Okay. So this it's quite a straight and a direct question that the cancer cells, they are mainly using aerobic glycolysis, right? Because they are glucose hungry. Everyone knows the Warburg effect. So I think this was an easy one. Ma'am, long question was there. Yes, ma'am, image tha. So they have, I think they have clubbed two things. They have shown you an image, then they expected you to identify that this is a PET image, positron emission tomography image, and then they have asked you directly the principle of it. Increase glucose and decrease was present as option. So yes, it is increased glucose metabolism. 3 options were there with glucose. Okay. So 3 options were there with glucose. Particularly, I think some of them are saying that decreased glucose metabolism, something like this was given to confuse you. Acha, it was in the lung. So there was an image that was present on lung metastasis or lung uptake. Okay. But the main principle is Warburg effect, that is increased glucose metabolism in these cancer cells. Okay, now this is again a very confusing one. I didn't get a STEM, but I think it was a match the following type of a question in which they have given you ERCP image, MRCP image, and a HIDA scan. What was the question STEM? Was it match the following type of question? How to metabolize happen? एक ही था ऑप्शन में lung uptake. No, they ask what does this scan denotes? Option increase FDG activity. Okay, so Vakil, he is saying that they didn't ask the principle. They asked that what does it actually indicate? So it is increase in the FDG activity. Okay. So this was a match the following type of question. So this is very easy. The first image you can see that an endoscope is there. So that is definitely your ERCP image, endoscopic retrograde cholangiopancreatography, highest spatial resolution. Almost it's the gold standard in all the investigations because it has got highest spatial resolution. Plus you can do the management also. The second image is your MRCP. No contrast is given in MRCP. It is the intrinsic high T2 signal which is present in the gallbladder, which is present in the biliary ducts. That will give you this very nice T2 weighted MRCP image without any contrast, and it's absolutely a non-invasive procedure. What about the third image? The third image, it's a nuclear study. It is your HIDA scan. Okay, it is mainly based upon your technetium-99. What agent do we use? We use mebrofenin. Okay, and of course, this is mainly used for the functional assessment. If I want to see the biliary excretion, okay, particularly in pathologies like biliary atresia, if I want to, if ultrasound is indeterminate and I want to confirm whether there is acute cholecystitis, non-visualization of gallbladder after 4 hours. In all these investigations, particularly we use HIDA scan. Percutaneous was the fourth option. So in percutaneous was an image given to you. Arrange all for ma'am, brachytherapy, MRCP. Achha, there was a PTC. Okay. So there was an image. So I think in the recall, I will add an image. In the proper recall, I'll include an image on the PTC as well. So this was an easy question. Okay. So I think we have covered, if any other question you can recall, these were the 8 questions. Usme se bhi 2 were integrated. One was from OBGYN, one was from ENT. So this was the recall which I could get from the students. If you have more questions in your mind, if you can recall, just put it down in the comments. We'll try to answer. I'll just wait for a minute. Okay. Otherwise, definitely we are going to get a proper recall session will be there, and we will of course, we'll club all the missing questions in that, right? Okay. So we have an FMG marathon series as well as predictor series, which we did last month. And I'm glad that many of the MCQs were being tested. Of course, the predictor series, it's a very important book. So students who have not given the exam, who are going to appear in the upcoming FMG, do go through this book. It's a very good book. And there are very high chances of questions getting asked from the predictor series. Thank you so much. And over to the next faculty.
Thank you, Dr. Natisha. So we'll start with the Opthal. तो बच्चों, tell me during the recall as to whether the exact question was this or not. I am not putting up the exact stem of the questions because I know all of you are very, very tired and there was only so much that we could get even from the students, क्योंकि सब बहुत ज़्यादा tired हैं और कुछ question ही recall हो पाए हैं. But in Opthal, we have like about 14 questions. The first question was something like this. That is, and the question that was asked was identify the instrument. What is the instrument? That is what was asked, right? What is the instrument, right? So this is something which we had discussed in the TND and the FMG predictor series and QRP. ये सब मिलाके we had discussed this somewhere. So this is the Hertel's exophthalmometer. This is the Hertel's exophthalmometer. Right, I think this you would have probably answered. This is actually a PYQ from INICT, and we had discussed this in one of our sessions. Chal, let's go to the next one. This was not actually a picture; it was a video. There was a video of a test which is done like this, where you insert strips in the lower fornix. And what was asked is, what is the name of this test and what is it used for? I think this most of you would have got right. This is the Schirmer's test. This is the Schirmer's test, and it is used for evaluation of dry eye. Am I right? This is what the question was, but it was a video-based question. It was not an image. This has come as an image-based question previously. So it's a kind of a PYQ, but it has not come as an image. This time it has come as a video. I think this also most of you would have got right. Yes, the Hertel's exophthalmometer was definitely there, bache. Probably whether the name Hertel's was there, I do not know, but exophthalmometer, this question and this instrument, most of the students have recalled. Okay, so this was a video-based question. I think this most of you would have done this right. The third question, this is also something which it is a kind of an INICT PYQ, and we had discussed this either in the TND or the predictor series, I don't remember, but the image was there like this, and it was asked what is the diagnosis or what is the disease associated with this condition. I'm not sure what exactly the question was, but option may either you will have scleromalacia perforans, scleromalacia perforans, scleromalacia perforans, and or they would have asked that what is this associated with? This is associated with rheumatoid arthritis. This was there in the option. Scleromalacia perforans, or what is the disease that it is associated with? It is associated with during the recall as to I think scleromalacia perforans, or it may have, or the option could have been something like this. Rheumatoid arthritis was not mentioned. This is scleromalacia perforans. I am reasonably sure that it must have been there in the option. What is the diagnosis? Yes, what is the diagnosis? The diagnosis was scleromalacia perforans, and this is an old INICT question. Okay, let's come to the next one. The next one, predictable question. There was a picture which was similar to this, and they had probably given like lesions here like this, one lesion here, one lesion here. right? And they had said that there is a left homonymous hemianopia. There is a left homonymous hemianopia. Left homonymous hemianopia, and what is the site of the lesion? It was something like that, right? So the site of the lesion, this is something we have discussed multiple times. It is the site of the lesion is the optic tract. The site of the lesion is the optic tract. Left homonymous hemianopia. Yes, this is right. This is left. So if you have a lesion in the right optic tract, then you end up with a left homonymous hemianopia. There were two questions from there. What was the second one? What was the second one? This is one question. Was left homonymous hemianopia. What was the other question? Yeah, what was the second question? Left homonymous hemianopia was optic tract, right? What was the next one? Was it bitemporal hemianopia or something like that? What was it? The site of the lesion was the left optic tract. They asked fibers. Okay, whatever it is, I think this is something which nobody would have got wrong. ये तो हमने बहुत बार discuss किया है. This we have discussed many times. Now there was a question. Which nasal, see, if this is it is right-sided temporal and left-sided nasal. So the fibers are right-sided temporal fibers and left-side nasal fibers. Left-side nasal fibers. Okay, right-sided temporal fibers are affected and left-sided nasal fibers are affected. But that's not the field, huh? If the question is which are the fibers that are affected. Which are the fibers? It is temporal of the left eye and the nasal of the right eye. But it's a left homonymous hemianopia. Site of the lesion is the right optic tract. We will discuss this question. Yeah. We'll discuss this. We'll find a proper recall and come back to it. The fibers are left-sided nasal and right-sided temporal fibers. Not fibers, field. Field was mentioned. Field mentioned hai, so it is field is like this. It's like this. If you're looking at the field, it is right nasal, left temporal. Right nasal, left temporal. If you're looking at the field, then it is right nasal, left temporal. Okay, we'll come back to this question. We'll come back to this question after a proper recall. The field is right nasal and left temporal. Okay, the next question was a retinoscopy cross. I believe it was something like this. It was +4 like this. And it was said that this is done under atropine and from a distance of 1 meter. Right? So it meant that we had to correct this cross. So -1 is like the correction factor for atropine and -1 is the correction factor for the distance. So we had to correct it with -2 and the corrected cross becomes +2. And so the prescription for this should be +2 diopter sphere. +2 diopter sphere. Right? This was the question on retinoscopy cross. Yes, there is +4 at 90 degrees, +4 at 180 degrees, which is given in the form of a cross, but it is mentioned it is under atropine and at 1 meter distance. And so you correct it with -2 and it becomes +2 diopter spherical. Correct? Chalo. This I am reasonably sure that this was the question because this is what most students have recalled. Then there is a question, this is like a question which has come many times, that I don't know whether all of this was mentioned in the question, लेकिन इसमें से कुछ तो रहेगा ही. That elderly female patient presents with pain and redness in the eye, shallow anterior chamber, mid-dilated pupil, high intraocular pressure, or they may have said that stony hard eyeball. Stony hard eyeball. Elderly female patient, pain and redness, shallow anterior chamber, dilated pupil, stony hard eyeball. Yes, so this is acute angle closure glaucoma. Acute angle closure glaucoma. Gonioscopy was given. There was a picture. Yeah, there may have been an image of a patient with a mid-dilated pupil. But anyway, the key features in the question, either ye mentioned hoga shallow anterior chamber, mid-dilated pupil, high IOP. There was an image. Okay. There was a gonioscopy image of a closed angle. Okay, I'll just get back to it. जब हम final recall करेंगे, तो we will see a gonioscopy image where none of the angles were, none of the structures was visible was given. But I think this everybody would have got right anyway, because mid-dilated pupil or shallow anterior chamber was mentioned. Then there was a question probably like this, that there is a patient presents with sudden vision loss, but the key word was pain on ocular movements. Then it said that there is RAPD, normal fundus, and central scotoma. I think pain on ocular movements and central scotoma, these two words together, this together gives us a diagnosis of optic neuritis. Was this question was there? Was there a question like this, that there is sudden vision loss and pain on ocular movements and central scotoma? Was there a question like this on optic neuritis? Some students are saying yes, some students are saying no. I don't know whether students confuse this question with something else or not. But if it was there, I think these are the two key words which I tell you in the class also, कि pain on ocular movements or central scotoma, ये दोनों words को ढूंढना है question में, and if this is there, you mark it as optic neuritis. It was not there? Okay, fine. We'll come back with the recall later. Yeah, I think that some people may have confused it with acute angle closure glaucoma. This was not the question. Okay. So was there a question with this kind of an image of a festooned pupil? Was there a question like this with an image of a festooned pupil? This kind of an image was there? There was an image based. Yes. So did they say that there is a patient who presents with pain and redness? And did they say something like cells and flare? How is it like? No, it was not there. Okay. Okay, we'll come back to it then. Then we'll not discuss this question. Then there was this question which was on xerophthalmia staining. Staging. There was xerophthalmia staging, and there was a picture of a corneal ulcer, I believe. This was there. Okay. There was a question on staging of xerophthalmia. I will come to the question on Snellen's. Was there a question on xerophthalmia? What did it say? Something like there was an ulcer with less than 1/3 of the cornea, something like that. Less than 1/3 of the cornea. Yes, a corneal ulcer which is involving less than 1/3 of the cornea, which is xerophthalmia stage X3A. A corneal ulcer which involves less than 1/3 of the cornea. Okay. Then there was this image, this image said that there is a 7-year-old boy and he has a complaint of sore throat and he also has redness in the eyes, and there is this kind of a membrane which you can see in the conjunctiva. Correct? So that sore throat hai, so it is a kind of a viral conjunctivitis. So it is not exactly membranous, but I think among the options that were present, usko membranous ही mark करना होगा. It is a pseudomembrane actually, ये membrane नहीं है. It is a pseudomembrane, but among the options that were there, I think membranous conjunctivitis ही mention करना पड़ेगा इसको. So there was a question which was something like this, I think. It is not VKC. VKC में why would person have sore throat? राइट एंड ये वीकेसी वाले में हमेशा कौन सी इमेजेस आते हैं? वीकेसी वाले में आइदर यू गेट एन इमेज ऑफ द कॉबलस्टोन अपीयरेंस और यू गेट इमेजेस ऑफ हॉर्नर ट्रांटा स्पॉट्स. ये उन दोनों में से ही नहीं है. Then there was an image which was something like this about a retinal tear, but I don't know I think the question was something like which of the following is not true. ऐसे कुछ था. Right? There was an image. There was this image and the question was which of the following is not true. Something was like visual acuity is normal. ऐसा कोई option था शायद. Visual acuity is normal. Yeah, visual acuity is normal. ऐसे कोई option था. That is what is incorrect. Students could not recall the other options as of now. It is always unilateral, or it may be unilateral or bilateral. ऐसे कुछ था शायद. We'll come back with this question. It was about surgery or symptoms. Option was different. It is a question on rhegmatogenous retinal detachment. Now, exactly students have not been able to identify. What is the diagnosis? It is rhegmatogenous retinal detachment. It is always bilateral. It is not bilateral. It's usually unilateral. The visual acuity is decreased. It is usually unilateral. It is seen in myopes. The treatment is surgery. Treatment is surgery. The treatment is surgery. We'll come back to with the options. But the question is, it's a rhegmatogenous RD question. I think you would have been able to answer this. It is rhegmatogenous retinal detachment. Then there was this question, which I don't know, ये ऐसा कोई image था with the lashes turned inwards. I think either trichiasis or entropion, one of these. There in the options. Yes, it's been difficult to recall actually. It was not there. Trichiasis or entropion or something like that was, I think what has happened is students, there were so many images na, सब बच्चों ने एक ही questions. Okay, yes, the question said that there is an elderly female who is rubbing the eyes constantly, complain of irritation in the eyes or foreign body sensation, rubbing the eyes, ऐसे कुछ question था, right? Yes, either it was a case scenario where they said there's an elderly female patient who's complaining of irritation and rubbing in the eyes. I don't know whether the image was there, but या तो entropion या trichiasis इन दोनों में से one of the options would have been there. Then there was a question on the Snellen's chart, which was a new question. And it is, what is the angle subtended by the 6x6 line? ऐसे कुछ था. The angle subtended by the letters of the 6x6 line. Something like this. Right. So the answer is 5 minutes of arc. The answer is 5 minutes of arc. See, if the question is, it's an elderly female patient rubbing the eyes, if it says lid margin is inward, then it is entropion. If the question says lid margin is inward, tab answer entropion hona chahiye. But if the question says that only lashes are inward, then the answer is going to be trichiasis. Then the answer is going to be trichiasis. If it says lid margin is turned inwards, then it is entropion. And if it says lashes are inward, then it is trichiasis. Yes, the angle subtended by the letters of the 6x6 line or 20x20 line, the angle is 5 minutes of arc. This was like a bouncer. Chal, next one. Then there was a question on the complications of LASIK. ये भी बच्चे recall नहीं कर पाए. It said that there is a patient who comes after some complication 2 years later. And I don't know whether there was an image. I'll come back with this question later. Yeah, this I do not read this question. None of the students could actually recall. Ophtha में जो questions थे, most of them were very similar to what we had discussed in the TND and the INI-CET predictor, but I will not say that the questions were easy. Exact stem of the questions to recall कर भी नहीं पाए बच्चे, because like there were too many questions, too many images, and all of you are really tired, but we will we'll come back with the proper stem of the questions in some time, but the idea is that topics तो same ही थे. The topics were similar to what was expected. However, the questions were, yes, the difficulty level is such that until and unless you start studying early, it is difficult to answer these questions. So we'll come back with a proper recall after some time, once we get the proper stem. And I would say आज बच्चों relax करो. हो गया है अभी जो है, result के दिन पता चल जाएगा, then we'll decide the next course of action. Now I would want the next faculty to take over.
Hi, ma'am. I'll take over.
Yeah.
Hi, guys. I know medicine was, the topics were quite predictable, but then adding the images, messing up the time, making the questions quite lengthy made the things bit complex. And as of now, I was able to get only few recalls. Some of them have been already addressed by other faculty members. The reason is simple, the questions were integrated. So I will say these are my questions, but the same questions will also be owned by other faculty members. Okay. Now, let me begin with the first question. This was one of the questions. A patient with recurrent episodes of severe pain in the right great toe. So they're already giving you the potential clue, right? So they're talking about what we call as podagra here, monoarthritis of right great toe. In MCQ, the moment we think of monoarthritis, the first thing we think of is gout, if it is recurrent. And if it is not recurrent, first episode, then maybe we think about septic. If they're already pointing towards right great toe, then we are thinking about podagra, monoarthritis, typical gout. To reassure that we are dealing with the gout, the question also mentioned that the serum uric acid level was high and the joint aspiration showed negatively birefringent needle-shaped crystals, and they were asking what is the long-term management. We did have similar question in our FMGE predictor book as well, and we had covered this question in our FMGE predictor series as well, right? Monoarthritis, think of gout, septic arthritis. I told you this, and we had discussed the management as well. Grade 2 is the most common site. I had mentioned this. And then the gold standard is synovial fluid analysis. You do get needle shaped negatively by refringent monosodium urate monohydrate crystals. When it comes to management, the immediate management is always reducing the inflammation and reducing the pain. For that, we generally use potent NSAIDs like indomethacin and other anti-inflammatory agents like colchicine. But long-term management is to keep the uric acid levels under check. And for that, we use uric acid lowering drugs like allopurinol, febuxostat, or probenecid. So long-term management is about uric acid lowering. In the options that mentioned allopurinol, so that becomes our correct answer. That becomes our correct answer. Okay, so that was a pretty straightforward question. Oh, okay, they had asked management of acute. So if the question was about management of acute, then of course the answer changes to colchicine. Answer changes to colchicine. Okay, so if it was on acute, then the answer changes to colchicine, and I'm sure all of you have answered it right. Okay, so good. Then there was another question which most of you said it was a video based. Okay, so there was colchicine plus NSAID both mentioned as an option. If it was long term, yes, colchicine. If it is long term, we will go ahead with allopurinol. But if it is about acute management, we had a similar question in the predictor book as well. In the predictor book, we had about acute management. So if it is acute management, NSAIDs plus colchicine. The question is, did we have both NSAID plus colchicine? And they were asking which one gives the quickest relief. Then of course you should choose NSAID over colchicine. Okay, so if there was just NSAID, yes, you could go ahead with NSAID itself. That will be your right answer. So instead indomethacin, if it was NSAID, colchicine was there in the option or not? So NSAIDs were this, then we will go ahead with that. Fastest acting, well, you will choose NSAID over colchicine if it is the rapidity of onset of action. Now, the next question was a video or GIF based where after the thyroidectomy, patient had shown some sign. I guess the sign was pretty similar to this. Tapping on the face, there was twitching visible. Very similar video, right? So this is a very typical story of post-thyroidectomy, parathyroid glands getting knocked out, patient developing hypoparathyroidism and hypocalcemia, and this sign is Vostek sign. Though we write it as Chostek, it is pronounced as Vostek sign. So that would be our right answer. That would be our right answer. Okay, so see, pegloticase, raspbericase, no, they're not used in this setting. We used it in hyperuricemia leading to renal complications like in tumor lysis syndrome. Allopurinol is, of course, for the long-term management of hyperuricemia. So if it is about fastest relief and NSAID was not an option, then colchicine becomes your choice. Okay. Then asked fastest urate lowering therapy. Tap करके कुछ लिखा था. See, if they were tapping and if you're able to notice some twitching, then certainly it is Vostek sign. Okay. So I think there were two questions on post-thyroidectomy complications. Or maybe this question did not mention, was there a mention of post-thyroidectomy and then the video, or just the video and asking what sign it is? Nonetheless, the video is very clear. If there was tapping involved, we are thinking about Vostek sign. There's nothing else to think about. Okay. Then this was another question where we had, like this question has been already discussed by Dr. Ranjit, so I will just quickly cover this. So where we had a patient presenting with symptoms suggestive of nephrotic syndrome, because there was facial puffiness, pedal edema, hypertension, and frothy urine, and the proteinuria of 4.2 grams per day. So we're thinking about nephrotic syndrome. Of course, if it was a child, I would have thought about minimal change disease, but we're talking about adult. And then the question also mentioned that patient had history of photosensitivity, oral ulcers, and joint pains, and lab investigations reveal an ANA and anti-DS DNA positivity. So that changes the game, and now we start thinking about SLE with nephrotic syndrome. So I would think about SLE leading to lupus nephritis. So this is our final diagnosis, SLE leading to lupus nephritis. And they're asking what is the mechanism of renal injury in this particular case. They have also mentioned that the serum C3 and C4 levels are low. I think we have discussed this umpteen number of times in the SLE and other video modules that the complication that we see in SLE, the organ manifestations, the inflammation of the pleura, different layers of the heart, kidney, many of them are because of the immune complex deposition, right? Immune complex deposition along with the complement activation. So in the kidney, we have deposition of immune complexes and complements. That's why the serum complement level goes down. So every time you see serum complement levels going down in a patient with SLE, we start suspecting the onset of lupus nephritis or worsening of lupus nephritis if it is already a known case of lupus nephritis. So our answer will be option B, deposition of immune complexes with complement activation. Okay. The next question was, see, I have spoken to many students. Most of them said the video was of Vostek sign and not the Trousseau sign. But anyway, I will share a video of Trousseau sign also, so maybe we can relate whether we had seen a Trousseau sign video or a Vostek sign video. Okay, so another question with a patient having progressive difficulty climbing stairs and rising from the chair. So if you've gone through my video modules, you know that these are the signs of proximal muscle weakness, right? These are suggestive of proximal muscle weakness. And I think you must know that we get proximal muscle weakness in two conditions. What are those? Pure muscle disorders like Duchenne muscular dystrophy or endocrine myopathies, and the neuromuscular junction disorders. Those are the two differential diagnoses we would think of whenever patient has proximal muscle weakness. Now, if there's proximal muscle weakness, what clue takes me to the diagnosis of neuromuscular junction disorders like myasthenia gravis and GB syndrome? Generally, these conditions have certain diurnal variation. Either with repeated use, the symptoms worsen or symptoms get better. Well, in this question, that information is not there. But when I look at the options available, it is all about cancers. So muscle disorders like Duchenne muscular dystrophy or endocrine myopathies are not usually related to cancer. There are few myopathies related to cancer, but they are less common. So if you're thinking about a tumor and proximal muscle weakness, we think about neuromuscular junction disorder in our exams. Okay. Now, if they had mentioned that we got a anterior mediastinal mass, then I would have thought about thymoma. In that case, the diagnosis would have become myasthenia gravis. But they're talking about the lung cancer, most likely type of lung cancer, because chest imaging has shown a hilar lung mass. So if lung cancer is what we are thinking about, then this is a paraneoplastic syndrome. And being a paraneoplastic syndrome, that too with proximal muscle weakness, I would think about Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome. Though there is no information about diurnal variation, or was it mentioned? Was it mentioned that there was history of diurnal variation? The symptoms get better as the day progresses or vice versa. If that is mentioned, it becomes much more clear case of Lambert-Eaton, but otherwise we can presume that we are talking about Lambert-Eaton here. And which cancer is most commonly responsible for Lambert-Eaton? I think we had discussed the same question in our test and discussion as well as the FMG predictor series. So it's an anticipated question and the answer becomes small cell lung cancer. Small cell lung cancer. Small cell lung cancer is the most common malignancy associated with Lambert-Eaton syndrome. Okay. The next question is this. A 12-year-old boy, again Ranjit has addressed this, brought to the outpatient department with recurrent episodes of mild yellowish discoloration of the eyes, especially during fasting. So that's a very typical story. He has no abdominal pain, dark urine or weight loss. Physical examination is unremarkable except mild scleral icterus. Main thing is when you look at the laboratory tests, there was unconjugated hyperbilirubinemia while liver enzymes and hemoglobin are normal. So there are causes for altered LFT, but one of the way to approach LFT is, I think we have discussed this in the past as well. Whenever you have a question on jaundice, you have to see whether you have isolated hyperbilirubinemia or you have increased bilirubin as well as liver enzymes. So in this case, there was no increase in the liver enzymes. We only had isolated hyperbilirubinemia. So in that case, most likely you're dealing with congenital hyperbilirubinemia syndromes. In that case, we should see whether it is conjugated predominant or is it unconjugated. If it is unconjugated, we have two main differential diagnoses where you have indirect bilirubin being high. That is going to be Crigler-Najjar and Gilbert. Crigler-Najjar usually presents in the neonatal age group, while the Gilbert presents later, where you have only mild icterus. Other liver function tests will be normal. During fasting, the icterus worsens. That's a typical story. So story fits into the Gilbert. So we'll stick to our initial presumed diagnosis as Gilbert. Okay. Then I also got to know that there was a question on anion gap calculation. So can anybody share the STEM with me? Well, this is certainly an anticipated question, and we had questions on this anion gap calculation in the test and discussion. And we also did talk about the ABG approach and anion gap calculation in the FMGE predictor series as well. Okay, so you mean to say there was no hilar mass mentioned? Was it an image-based question, or was it just the STEM? Okay, I will reframe the STEM. I will collect the more details from you. I will reframe the STEM, and according to that, if the answer changes, I will share the changed answer. Okay, so there was a patient with diarrhea. Okay, so that mentioned that there was a patient with diarrhea. So can you mention the values mentioned on the ABG? Okay, I got it. Diarrhea was there. They were just asking whether was it a straight question or a calculation based question? Well, okay, I'll keep this question pending. I will compile the STEM. But anyway, this was certainly an anticipated question, and I hope all of you have got it right. Okay, I will compile the STEM and share the right answer. And there was also a question on cardiac tamponade. So can anybody share the STEM with me? Again, I had told you we will get a question on cardiac tamponade for sure, either cardiac tamponade or constrictive pericarditis. Almost always one question comes from this. So this was also an anticipated question. Okay, Shravan Kumar, I'm noting down the ABG parameters. Samir Soil, okay, I will note down the parameters and share the calculation. Now let me compile the cardiac tamponade question. So I guess there was a question with patient having typical Beck's triad. There was a question on typical Beck's triad. So do we mean we had two questions on ABG, one where we had the full calculation to be done, and one more, there was just about like one ABG where we have to make the acid-base abnormality diagnosis, and one more ABG where we had to just calculate the anion gap from the values mentioned. Sodium chloride, bicarbonate mentioned. Some students said that there was a question where patient had, let me read the STEM what I got from the student. So it's like the history given about low BP, muffled heart sound, and patient get tired on exertion. Chest X-ray was normal. What will be the next choice? Was the STEM like that? BP low, muffled sounds, patient get tired on exertion. Chest X-ray was normal, so there was no water bottle heart. And what will be the next choice? HRCT, angiography, tube drainage, and open surgery. These were the options given to me. Okay, so Anukul Kumar, can you tell me what was the X-ray finding? Okay, so there were two questions on ABG, one for the diagnosis and one for anion gap calculation, right? So I will compile both these questions and share it with you. Okay, so most of you are saying there were no questions on cardiac tamponade. If I get a proper STEM, I'll share it with you. So as of now, from medicine, I could only recall these many questions, but I'm very sure there were a lot more medicine questions which were kind of integrated with pharma and pathology. So they will be addressed subsequently. Finally, we will share a fully compiled recall STEM. I will pass on the baton to Dr. Rajesh sir. He will be taking you through the biochemistry question. Rajesh sir, welcome to the recall
Hi,
session.
sir.
Over to you, sir.
Hello, students. Let's discuss biochemistry questions. See, CBME based पूरा पेपर CBME based था, थोड़ा टफर साइड में था, थोड़ा नहीं बहुत ज़्यादा टफर साइड में था. बायोकेमिस्ट्री के जो क्वेश्चंस थे, इट इज़ बिटवीन द मॉडरेट टू मतलब मॉडरेट टू टफ लेवल में बिलोंग करते हैं मैक्सिमम क्वेश्चंस। और जैसे अभी संतोष सर कुछ क्वेश्चंस डिस्कस कर रहे थे, वेदर ऑन एबीजी एनालिसिस और वेदर ऑन द कंजेनाइटल हाइपरबिलिरुबिनेमिया दैट इज गिलबर्ट सिंड्रोम, और रंजीत सर ने भी गिलबर्ट सिंड्रोम का क्वेश्चन डिस्कस किया। तो आप ये समझो कि ये जो पैटर्न है इट इज सीबीएमई पैटर्न, पैटर्न इंटीग्रेटेड टॉपिक, मतलब सभी को लगेगा, सभी मतलब दो चार सब्जेक्ट वालों को लगेगा कि दिस क्वेश्चन बिलोंग टू मी, ऐसे टाइप में थोड़े से क्वेश्चंस थे। There were near about 10 to 12 questions on biochemistry, but it is completely integrated with pediatric, integrated with medicine, integrated with physiology. So as per मतलब सीबीएमई जो करिकुलम है उसके हिसाब से क्वेश्चंस पूछे गए थे, थोड़े से डिफिकल्ट साइड में थे। सो डोंट पैनिक, जस्ट रिलैक्स। See, the first question, I will discuss the first question. A 45-year-old man undergoes evaluation for kidney function test, KFT. His physician orders creatinine clearance instead of inulin clearance, and compared with the true GFR, the creatinine clearance is expected to be. This was the मतलब actual stem नहीं है but थोड़ा बहुत modified है। This question was there comparing the inulin and creatinine clearance। तो ये हमने हमेशा टेस्ट एंड डिस्कशन में भी, और जो बायोकेमिस्ट्री के वीडियोस है, टेस्ट एंड डिस्कशन के प्रेडिक्टर सीरीज है, मैराथन सीरीज है, इनुलिन एंड क्रिएटिनिन, यूरिया एंड क्रोमियम इडिट, ये हमेशा कंपेयर करते हैं हम जब जीएफआर कंपेयर करते हैं। तो फॉर कैलकुलेटिंग द जीएफआर, सी इनुलिन गिव द जीएफआर मींस वैल्यू इक्वल टू जीएफआर दैट इज अप्रोक्सीमेटली 125 ml per minute। The urea gives the value which is lower on the lower side क्योंकि the 40% near about 40% absorption for the urea, and creatinine gives, and this creatinine will give you slightly higher values than the GFR, that is approximately 135 ml per minute, because there is partial secretion of creatinine. That's why the values are higher as compared to the inulin and the GFR. So slightly higher than the GFR value when we take creatinine clearance into consideration because of the partial secretion of creatinine into the renal tubules. Okay, just wait. Hi Abhinav. Clearance difference from inulin. Inulin gives the exact GFR near about 125, and creatinine gives value higher than the inulin clearance. Just remember this. Okay. Vitamin deficiency associated with cystic fibrosis. Remember, cystic fibrosis, the fat soluble vitamins, vitamin A, D, E, K, absorption decreases. There is malabsorption because of the pancreatic insufficiency. There is viscous secretion and there is pancreatic secretion जो है वो intestine में आते नहीं, उसके वजह से malabsorption is there. So fat soluble vitamin A, D, E, K, these are affected in the cystic fibrosis because of the CFTR mutation. So here answer is vitamin A. Answer is vitamin A. Biotin, vitamin C, these are the water soluble vitamins. तो ये ऑप्शन में मतलब ये आंसर नहीं रहेंगे. Yes, inulin, creatine, and the urea. This is the sequence. Okay. So here answer is vitamin A. और फोर्थ ऑप्शन रिकलेक्ट नहीं कर पाए कोई, तो यहाँ पे फोर्थ ऑप्शन नहीं है. यहाँ पे वाटर सोलुबल विटामिन होने के चांसेस है कि फोर्थ डी ऑप्शन में वाटर सोलुबल विटामिन रहेगा. नाउ सी, दिस इज द टिपिकल क्वेश्चन ऑन द विटामिन सी. एग्जैक्ट ऐसा था या नहीं, लेकिन बच्चों ने ऐसा रिकॉल दिया. सी, 9-year-old boy from the low income family present with bleeding gums, recurrent bruising, poor wound healing, recurrent bruising, poor wound healing, and pain in both legs for the past 2 months. Examination reveals perifollicular. See, this is the characteristic feature: perifollicular hemorrhages, corkscrew hair, and the swollen spongy gum. So all of you know about the vitamin C deficiency manifestation, the manifestations of the scurvy. X-ray shows dense white line at the metaphysis. The underlying biochemical defect involves impaired hydroxylation. So there is impaired hydroxylation of proline, reduces during the collagen synthesis, deficiency of which vitamin is responsible for the defective activity of enzyme involved. So remember, prolyl hydroxylase and lysyl hydroxylase. These enzymes are important in the collagen, means hydroxylation of the proline and lysine in the collagen synthesis, which is important for the rigidity and strengthening of the collagen molecule. So hydroxylation process is involved, and these manifestations, these are the manifestations of the scurvy, that is vitamin C deficiency manifestation. So here answer is vitamin C. So vitamin C deficiency causes defect in the hydroxylation of proline and lysine. It affect the prolyl hydroxylase and lysyl hydroxylase. ये तो PYQ था, लेकिन ये ऐसे का ऐसा क्वेश्चन था या नहीं था एग्जैक्टली? हाँ, हाय हाय दीपक, question can be replicated but option were different. ब्लीडिंग गम था ऑप्शन में, विटामिन सी नहीं था। ओके, सो दो उस हिसाब से जैसे आप क्वेश्चन रिकॉल करोगे उस हिसाब से आंसर उसका चेंज होगा मतलब विटामिन सी से ही रिलेटेड रहेगा। सो दीज आर द क्लासिकल फाइंडिंग्स ऑफ विटामिन सी डेफिशिएंसी, दैट इज ब्लीडिंग गम्स एंड पुअर वुंड हीलिंग। ये क्वेश्चन ऑलरेडी विवेक सर ने भी डिस्कस किया फिजियोलॉजी में। द सीरम ग्लूकोज वाज नॉर्मल बट द सीएसएफ ग्लूकोज वेरी लो। The defect is most likely due to deficiency of which glucose transporter? हम जब भी प्रेडिक्टर सीरीज में या टेस्ट एंड डिस्कशन में हमने ग्लूकोज ट्रांसपोर्टर डिस्कस किए, हमने उसमें ग्लूट वन डिस्कस किया। ग्लूट वन में हमने इंपॉर्टेंट एक न्यूमोनिक डिस्कस किया था, दैट इज कोहली प्लेज फॉर RCB. So this is RBCs, this is colon, and this is blood-brain barrier. So this is blood-brain barrier. So it is GLUT1 which is affected here. GLUT1 is affected. Okay. So CSF value is approximately 60%. That is 2/3 of the glucose, means the plasma glucose value. Here the plasma glucose was normal, but CSF glucose it is very low. So GLUT1 is there. It is there in the blood-brain barrier. So which is affected here. Okay, GLUT1. See, this question was already discussed by the Ranjit sir, also by the Santosh sir. Increase unconjugated bilirubin, mild icterus, that shows the Gilbert syndrome. There is see, in the Gilbert syndrome, remember doctor, direct bilirubinemia. The direct bilirubin increases in the Dubin-Johnson and Rotor. And unconjugated bilirubin, it is increased in the Gilbert and the Krigler-Nair syndrome. So this Krigler-Nair, it is quite severe. Bilirubin goes, in the type 1, bilirubin goes beyond 20 up to 45 milligram per deciliter. While in the Krigler-Nair type 2, there is partial deficiency and bilirubin can go up to 20 milligram per deciliter. But the mild hyperbilirubinemia was mentioned there, and the age is somewhat means 10 to 12 years of age, something like that. So it is Gilbert syndrome, in which you will notice the unconjugated bilirubin increases. This is because of the defective uptake of bilirubin by the hepatocytes, and also there is decreased activity of UDP glucuronil transferase, that is near about 33% activity of UDP glucuronil transferase, which is retained in the Gilbert syndrome. So here answer is Gilbert syndrome, which causes the unconjugated bilirubin to rise. Okay, this question was already discussed by the Santosh sir and also by the Ranjit sir in the pathology. तो इसीलिए मैंने बोला था कि integrated type के questions थे। मेगलोब्लास्टिक एनीमिया विथ न्यूरोलॉजिकल सिम्टम्स, डेफिशिएंट विटामिन ई। तो थोड़ा सा लंबा हिस्ट्री दिया था। मेगलोब्लास्टिक एनीमिया विद द न्यूरोलॉजिकल सिम्टम्स वेर मेंशन देयर। सो इट इज बिकॉज ऑफ द विटामिन B12 deficiency. Remember, so only folic acid deficiency along with the figlu excretion अगर है तो it is folate means megaloblastic anemia with the figlu excretion अगर दिया हुआ है तो folic acid deficiency है। अगर मेगलोब्लास्टिक एनीमिया विथ न्यूरोलॉजिकल फीचर्स मेंशन है तो इट इज बिकॉज ऑफ द विटामिन B12 डेफिशिएंसी। इट इज बिकॉज ऑफ विटामिन B12 डेफिशिएंसी एंड न्यूरोलॉजिकल मैनिफेस्टेशंस बिकॉज ऑफ डिफेक्टिव माइलिन सिंथेसिस दैट कॉजेस द subacute combined degeneration of spinal cord, and there is increased methylmalonic acid level in the B12 deficiency. So megaloblastic anemia with neurological feature, these are the features of vitamin B12 deficiency. फिर कुछ बच्चों ने बोला कि न्यूक्लियोटाइड एक्सीजन रिपेयर पे कोई क्वेश्चन था। इस पे क्या क्वेश्चन था आप लोग यहाँ पे पोस्ट कर सकते हो। हाय सिद्धेश। हाँ, मेटाबॉलिक हाई एनायन गैप, मेटाबॉलिक एसिडोसिस, मिक्स एबीजी पैटर्न, ये मैंने दोनों क्वेश्चन मुझे पता है, लेकिन एग्जैक्ट क्वेश्चन किसी को रिकलेक्ट नहीं हुआ, उस वजह से ये इंक्लूड नहीं किया गया। और ये ऑल्सो मेडिसिन में भी आता है, बायोकेम में भी आता है। इससे रिलेटेड किसी को क्वेश्चन पता है, न्यूक्लियोटाइड एक्सीजन रिपेयर पे क्वेश्चन था या नहीं था? क्योंकि सिमिलर क्वेश्चन वाज देयर ऑन द एमएमआर एंड द दैट इज लीन सिंड्रोम, दैट इज एचएनपीसीसी पे भी थोड़ा बहुत क्वेश्चन था, लेकिन वो एचएनपीसीसी था या वो म्यूटेशन था, वो अलग क्वेश्चन हो गया। इस पे कोई क्वेश्चन था क्या, न्यूक्लियोटाइड एक्सीजन रिपेयर? एडेनिन और एडिनोसिन, जीरोडर्मा पिगमेंटोजम था, ओके, था या नहीं था? अंकित राज था, शगुन नो सर, प्रिया शर्मा यस इट वाज देयर, स्प्लाइसिंग था शायद। सी, हमने ये प्रेडिक्टर सीरीज में ये दोनों तीनों क्वेश्चन हम ज्यादातर फोकस करते हैं। हम वहां पे जब प्रेडिक्टर सीरीज या जब मैराथन लिया गया तब भी बोला था कि हार्पर का ये टेबल है, ऐसे का ऐसा, ये पूरा का पूरा टेबल इंपॉर्टेंट है। इसमें 3 डिसीजेस है जो बहुत टॉप रेटेड है, हाई प्रायोरिटी जिसको देनी चाहिए। फर्स्ट वन इज द दैट इज SCID, सीवियर कंबाइन इम्यूनोडेफिशिएंसी। इट इज बिकॉज ऑफ द फॉल्ट इन द न्यूक्लियो दैट इज नॉन होमोलॉगस एंड जॉइनिंग, if there is double strand break, if there is fault in the non-homologous end joining, that causes the severe combined immunodeficiency. Second most important is if there is cyclobutane ring, that is covalent crosslinks formation between the two adjacent thymine residue because of the UV light. So this is UV light induced thymine dimer formation is there, and if it is not repaired by the nucleotide excision repair, it causes xeroderma pigmentosum. This is xeroderma, matlab dryness of the skin. There is excessive pigmentation, multiple freckles on the sun exposed part of the body that turns into the blistering skin lesion in the xeroderma pigmentosum. Even small exposure to the sunlight, थोड़ा सा भी मतलब sleeves ऊपर गए, sun exposure हो गया, तो it can cause the blistering skin lesion, and there is 1000 time risk of getting the cancer, that is squamous cell carcinoma, basal cell carcinoma, and the melanoma is there in the xeroderma pigmentosum. And third most important is the HNPCC lean syndrome. It is due to the mutation in MSH, MLH, and PMS gene. And there is microsatellite instability, HNPCC, Lynch, hereditary non-polyposis colon cancer. At least 3 relative, at least miss 2 generation, 3 relative, 2 generation, and one should be below the age of 50 year with endometrial cancer, means colon mainly, colon rectum mainly, followed by the endometrial cancer. That suggests the lean syndrome, that is HNPCC, हेरिडिटरी नॉन पोलिपोसिस कोलन कैंसर। इट इज बिकॉज ऑफ द फॉल्ट इन द मिसमैच रिपेयर। तो ये टेबल इंपॉर्टेंट है, यहाँ से हर बार कुछ ना कुछ आता ही है। सो इफ इट इज द जीरोडर्मा पिगमेंटोजम, दैट इज न्यूक्लियोटाइड एक्सीजन रिपेयर। इट इज इफ इट इज लीन सिंड्रोम, दैट इज मिसमैच मिथिल डायरेक्टेड मिसमैच रिपेयर डिफेक्ट, दैट इज माइक्रोसैटेलाइट इंस्टेबिलिटी। HMG कोएंजाइम रिडक्टेज द कोलेस्ट्रॉल बायोसिंथेसिस पे क्या क्वेश्चन था? रेट लिमिटिंग एंजाइम पूछा था या स्टैटिन्स था? मतलब रेट लिमिटिंग एंजाइम पूछा था ये कोलेस्ट्रॉल बायोसिंथेसिस का, या तो स्टैटिन का रोल पूछा था, कॉम्पिटेटिव इनिबिशन, स्टैटिन या कॉम्पिटेटिव इनिबिशन, क्या क्वेश्चन था इस पे? ये रिकलेक्ट नहीं हो पाया। HMG कोएंजाइम रिडक्टेज, जस्ट वेट। हाँ, थोड़ा सा इंटीग्रेटेड था और डिफिकल्ट साइड में था, तो रिकलेक्ट करने में, जब तक रिकलेक्ट नहीं होगा प्रॉपरली तो आंसर भी प्रॉपर नहीं आएगा। तो आप इसको अपने आंसर से मैच मत करो, जब जो क्वेश्चन है प्रॉपर उस हिसाब से वो आंसर चेंज होगा। स्टैटिन पूछा था, स्टैटिन था ऑप्शन में। कॉम्पिटेटिव इनिबिशन का ग्राफ दिया हुआ था, कॉर्टिकोस्टेरॉइड भी था, ओके। See, this is a reaction in which hydroxymethyl glutaryl coenzyme A is converted into mevalonate. This is a biochemical reaction, and this is a rate limiting step catalyzed by the HMG coenzyme A reductase enzyme. This is catalyzed by HMG coenzyme reductase enzyme. This is a rate limiting step, and this is the statins, the lovastatin, simvastatin. This group of drug inhibit this HMG coenzyme reductase by the competitive inhibition. So in competitive inhibition, all of you know that Km increases and Vmax remains same. इसी लाइन पे इस पे हमने प्रेडिक्टर और मैराथन में डिस्कशन किया है. So this is a rate limiting enzyme of this pathway. Okay, statin inhibit this HMG coenzyme रिडक्टेस. बायोटिन पे क्या क्वेश्चन था? प्रॉपर बायोटिन पे कोई क्वेश्चन था क्या? बच्चों ने बोला कि बायोटिन पे क्वेश्चन था. कार्बोक्सिलेशन से रिलेटेड, रॉ एग कंजम्पशन से रिलेटेड, और सम सिम्टम्स आर देयर इन द बायोटिन डेफिशिएंसी. बायोटिन से रिलेटेड क्या क्वेश्चन था? See, biotin is related with the carboxylation process, and this is a carboxylation process. And this carboxylation, it is particularly important in the gluconeogenesis, that is pyruvate carboxylase reaction, then fatty acid synthesis, acetyl coenzyme carboxylase reaction, and also the propionyl coenzyme carboxylation reaction. So biotin is important for carboxylation reaction. Biotin, when we consume the raw egg, avidin causes the decrease in the biotin level, means it binds with the biotin and makes the biotin unavailable for the absorption, that causes the biotin deficiency. इससे रिलेटेड कुछ था बायोटिन से रिलेटेड? अगर नहीं था तो इसको छोड़ देते. ठीक है. Remember, it is related with the carboxylation reaction. Deficiency causes mild hemolysis, diarrhea, the mild rash is there, and also hallucination, depression like symptoms are there in the biotin deficiency. Somewhat like the niacin deficiency, that is 3Ds, and somewhat like the zinc deficiency, that is diarrhea, alopecia, delayed wound healing. ऐसे थोड़े से दोनों के मिक्स सिम्टम्स रहते बायोटिन डेफिशिएंसी में. छोड़ दो, नहीं है तो. स्प्लाइसिंग एडिटिंग, मतलब यही क्वेश्चन आप बोल रहे थे कि न्यूक्लियोटाइड एक्सीजन रिपेयर से रिलेटेड था, तो मतलब इसका सेपरेट क्वेश्चन भी नहीं था. ठीक है. सी, before starting isotretinoin therapy, which baseline investigation should be measured to monitor the important adverse effect? Important adverse effect. See, दो चीजें हैं विटामिन ए से रिलेटेड. First, it is a hepatotoxic. It is a hepatotoxic vitamin. Second, it causes hyperlipidemia. अभी यहाँ पे catch है. See, remember this. It affects the lysosome. It causes hyperlipidemia. It causes hyperlipidemia. Second important thing, vitamin A toxicity. It causes it is hepatotoxic. So दो investigation यहाँ पे important है. Hepatotoxic vitamin, hypervitaminosis A, when it is given for the treatment for the chronic duration of time. Okay, acute toxicity causes the pseudotumor cerebri, but chronic toxicity causes these two effects. So lipid should be measured, means lipid profile should be measured. लिपिड प्रोफाइल शुड बी मेजर्ड एंड एलएफटी शुड बी मेजर्ड. ये दोनों इन्वेस्टिगेशन इंपॉर्टेंट है. अभी ये दोनों ऑप्शन में थे क्या, या सिर्फ एलएफटी था तो एलएफटी आंसर है, अगर लिपिड प्रोफाइल था तो लिपिड प्रोफाइल आंसर है. रिमेंबर, विटामिन ए, इट कॉजेस हाइपरलिपिडेमिया, इट इज हिपैटोटॉक्सिक विटामिन. अभी इसमें से दो में से कौन से ऑप्शन थे? जस्ट वेट, इमेज दिया था सीरम क्रिएटिनिन. कौन सा रॉन्ग आंसर है भाई? स्टैटिन का ग्राफ था. So see, HMG coenzyme A reductase, it is inhibited by the statin group of drug. Statin, lovastatin is a competitive inhibitor of the HMG coenzyme A reductase. LFT and lipid profile एक ऑप्शन था. चलो ये तो भी ठीक है, मीन्स LFT एंड लिपिड प्रोफाइल इट इज इन द सेम ऑप्शन. अगर दोनों एक ही जगह पे थे तो ये तो एकदम सही हो गया. ठीक है. सो ये सेपरेट नहीं था. LFT was not there separately. Okay, lipid profile and LFT. So it is, remember, it is hepatotoxic and it increases the TG level and cholesterol level. So hyperlipidemia is the side effect of vitamin A toxicity. So जितने भी questions थे, maximum जो questions थे वो डिस्कस किए गए थे प्रेडिक्टर सीरीज में, मैराथन सीरीज में. लेकिन ये जो एग्जाम में पूछे गए कुछ क्वेश्चंस थोड़े से नहीं, बहुत ज्यादा टफर साइड्स में थे. जब तक प्रॉपर स्टेम नहीं आएगा तब तक हम इसका प्रॉपर आंसर दे नहीं पाएंगे. थोड़ा सा अप्रोक्सीमेट कुछ क्वेश्चंस में डायरेक्टली बता सकते कि ये आंसर रहेगा, लेकिन जैसे कि द म्यूटेशन वाला क्वेश्चन था, क्योंकि वो जेनेटिक म्यूटेशन वो सब सभी में दिखता है, तो एग्जैक्ट जब तक स्टेम नहीं आएगा तब तक उसका आंसर नहीं दे सकते। ऑल्सो देयर वाज क्वेश्चन ऑन द एसिड बेस बैलेंस, हाई एनायन गैप मेटाबॉलिक एसिडोसिस पे भी क्वेश्चन था, एनायन गैप कैलकुलेशन पे भी क्वेश्चन थे, तो वो जब तक पूरा स्टेम नहीं आएगा तब तक पूरा उसका आंसर नहीं दिया जा सकता। सो this was all from the biochemistry. I will hand over the mic to the Santosh sir. Santosh sir, please.
Hi, sir. That was an excellent recall.
Thank
So
you,
next
sir.
up, we have Dr. Prasanna sir joining with the OBG questions. So let's see what is the Prasanna sir's opinion on OBG questions, whether he counts those questions as difficult or fair and just. Prasanna sir, once you're ready, over to you. So guys, meanwhile, when Prasanna sir joins the recall, let me know, how do you feel the exam was? Was it as per your expectation? I know we have already discussed about it and we know the questions were kind of
Very much here.
tricky. Hi, sir. Sir,
Hi,
over to you.
hi, Santosh, and thanks, Rajesh. Thanks for taking a session which has proper recall. My questions are, I'm thinking that.
Sir, you can proceed.
I think we were overlapping.
You
Okay,
can
fine.
proceed, sir.
So, Dr. Santosh, I think the paper was a little, of course, the question number was the same, but people thought it was lengthy when I met them in the center in Noida. And they said that to interpret and understand the integrated questions, it took them a lot more effort this time. Because some of the students were doing a repeat attempt at this paper. They said it took but they said that the topics were all expected. There was nothing which was out of the ordinary. That's what they said, at least in gynae. The topics were very much expected, but the questions were twisted, or they were asking too much of integration with the other subjects. Like, medicine, I think they asked something to do with antiphospholipid antibody syndrome, which, yes, it is something which is difficult to understand. But like I told in the recent marathon, just 4 days back, I was telling them that antiphospholipid antibody syndrome, you must understand, because it can cause abortions, can cause a patient to have hypertension, but it can also cause the patient to have thrombosis in an adult man or adult woman, even otherwise, and that can cause, stroke and other problems in the body. So yes, fortunately, that question came, and I'm sure most of the students could do that. So yes, I'll just cut off the volume, just a minute. Yeah. So I can understand that a lot of you had some tense moments because the questions were a little difficult to understand, but the topics were obviously the ones which have come earlier in the exams. And a lot of you did say that, yes, the marathon sessions helped them, whatever the PW series we've been doing, and the marathon sessions helped, and a lot of questions came from that. A few subjects, they said it actually came exactly from the marathon series, and they're very happy that they attended. So yes, good and bad will happen. Not all exams will be totally expected and totally easy questions. Then what's the fun of writing an exam if it is going to be very easy and predictable for everybody? We try to help you guys, and if it is coming even 50%, we are happy. But yes, most of you said 90% or 80%. Some people said 100%, which is, I think, a little bit of exaggeration, because I think you want to be thankful. We are happy that you found it to be 100% useful. But even if we touch around 70-80% of what we taught you, and if it comes the exam, then we are happy. And always strive to give you more content. And yes, looking by the things, I will have to probably teach you even more harder next time when we are doing the preparation for your juniors, because all of you guys are going to pass, right? So chalo, let's see what came. Of course, once again, the problem is that the recall was a little iffy. Most people remembered one or two choices and vaguely the question. So let's see the topics which have come in the exam, which finished at 4:30. RH negative mother, father is RH positive. She is second time pregnant now at 8 weeks. She has not received any anti-D in the last pregnancy. What was told to me that she forgot to take the anti-D. I mean, I think she was not given, or she could have been in the village or something like that. Now she is second time pregnant. and she has not received anti-D in the last pregnancy. What should be done first? So yes, if she is Rh negative and the husband is positive, there's a theoretical chance that the baby is positive. And if the baby is positive last time, then the positive blood could have gone to the mother and the mother could have got sensitized. So how do we know that the mother is sensitized? We do the indirect Coombs test first thing when she comes to us in the pregnancy. Even if she's come to me for the first time in the first pregnancy, even then I would have done the indirect Coombs test. The reasons being that she could have been isoimmunized because of a mismatched transfusion when she was a small kid. So yes, any pregnant woman who is Rh negative, I'll do the indirect Coombs test. And if she is having this situation, I'll first do the indirect Coombs test and find out if she's already isoimmunized or not. She's not isoimmunized, then we can continue the pregnancy without a problem. But if she's isoimmunized, then we should see how many antibodies she's making. And if the antibodies are too many, we have to see how much hemolysis she's having. But if she's not isoimmunized, then we can continue the pregnancy and give a prophylactic anti-D at 28 weeks and then after delivery. So if she's not isoimmunized, we have to give the prophylactic anti-D at 28 weeks. Prophylactic anti-D is given at, yes, once at 28 weeks, we give something like 300 micrograms and then again at delivery. Of course, we can give 300 micrograms again at delivery, but the ideal we always keep telling you is how much blood from the baby is gone to the mother. Find out that by the clear higher Betke test and then give the exact amount of required anti-D. She forgot, she did not take. Okay, fine, means the same. Another question about TD booster before 5 years, something like that. Immunization, TD booster before. Yes, if a woman has had TD injection in this first pregnancy, then for the next pregnancy, if she's pregnant within the next 5 years, then she doesn't have to take. But yes, the PSM people keep saying 5 years, we gynae people keep saying 3 years. So I would ask you to confirm this by the PSM people, because if she's had one TD, we say if there's a 3 years gap after the previous pregnancy and now she's pregnant for the second time, I'll give both the shots again, but confirm with the PSM people once. Chalo, that's the question which came. Okay, this one is simple. And let's go ahead and see the next one. Embryo splits in a monozygotic pregnancy between 4th day to the 8th day of life. What kind of twin will form? So if that was a fairly straightforward question. I think this one all of you would know that if the embryo is splitting between the 4th day to the 8th day, what can happen? It can make a monochorionic diamniotic pregnancy. So yes, this picture, you've seen it many times in our discussions that if it splits less than 3 days, it is dichorionic diamniotic. 4 to 8 days, it is monochorionic diamniotic, and 8 to 12 days, it is monochorionic monoamniotic, and after 12 days, it is conjoined twins. So that's how it is. Chalo. Was there any other questions? You're also in very different app. The first subject had full. Okay, fine. Okay, fine. Thank you so much, my friend. In dichorionic diamniotic, when does the splitting happen? If that was the question, then you know if it is dichorionic diamniotic, when does the split happen? ठीक है, dichorionic and diamniotic के लिए split कब होता है? It is less than 3 days of the embryonic life. ठीक है, that is also fine. There was a lambda sign wala image also. That is coming later. That's another question. Yeah, we'll come to that. Chalo. How much leave do you give after tubectomy? I think there were choices like 7 days, 12 days, 14 days, 21 days, like that. So maximum leave we give is in a tubectomy is 2 weeks. Yes, because it's a small operation, and even in government institutes, and even like my hospital is, it's not a totally private institute. I work in a Christian missionary hospital. We also give not more than 2 weeks for a tubectomy. But yes, the rule which I thought I got it from the internet myself, that the Maternity Benefit Act 1961 says any eligible woman is entitled to 2 weeks. Of course, we know this, but I thought I'll get you the right section in the act. So that I got from the internet. We always give 2 weeks of leave. So additional 1 month can be given if she has got any complications which are arising directly from the tubectomy. So a lot of time my patients keep coming after tubectomy saying कि sir 2 हफ्ते की छुट्टी तो हो गई, and my child is small and I want to give some time. So can you write me some anemia leave? And you can say the anemia is because of the tubectomy. And I said, that is like insulting me, because if I do a tubectomy, you will not bleed so much that you have anemia. No, sir, I have anemia as it is. I said, I wouldn't have done your tubectomy. So I'm very bad at giving फालतू वाला leave. If you deserve a leave, I'll definitely give you a lot of leave. And if you want more leave, you have to be sick for that. Okay. So yes, unnecessary leave हम नहीं दे सकते यार. So yes, 2 weeks तक दे सकते हैं. But if there is some complication, of course, if we had to open up the abdomen and there was a vessel injury or there was a bladder injury, something like that happens. So any complication which happens because of tubectomy, we can give extra 1 month. Chalo, there was a US image with cogwheel appearance. Yeah, cogwheel appearance. Okay, fine. Now you're giving me the question. Okay, रुक जाओ. Mia Khan. Lambda sign. Okay, fine. We're coming to lambda sign. Yeah, all of that is coming. Let's stick to the question, guys. Let's not tell me the next questions because otherwise it'll take very long. The other teachers waiting. So, जो question चल रहा है इसके बारे में अगर आप कुछ बोलना चाहते हैं तो otherwise we'll just go to the next one. If I miss some questions, we'll discuss at the end of this session. Okay, active management third से labor. यार ये बता दो, इसके बारे में बता दो क्या है. Let me see, because what is done in active management आया था कि all what is done and what is not done ऐसे आया था, and सबने बताया यूट्राइन मसाज तो नहीं आया था, but क्या आया था वो बता दो यार. Yes. Yeah, can you tell me what were the choices? I'm just waiting. एक्टिव मैनेजमेंट थर्ड से अब मेरे को आंसर नहीं चाहिए यार, मेरे को चॉइसेस चाहिए कि क्या करते हैं कि क्या नहीं करते हैं. क्वेश्चन क्या था? देयर वाज वेयरएवर आई पार्ट ऑफ मल्टीपल फोरम्स एंड एवरीवेयर आई सेंट रिक्वेस्ट एंड इवन ऑन द पीडब्ल्यू फोरम आई वाज नॉट गेटिंग. तीनों थे ऑप्शन में. एंड क्या करते हैं? डिलेड कॉर्ड क्लैंपिंग, मिथाइलोग्लोमेटिन, मिसोप्रोस्टोल इज नॉट पार्ट ऑफ द एक्टिव मैनेजमेंट थर्ड से लेबर. यस, 10 यूनिट्स ऑक्सीटोसिन देते हैं. चलो ठीक है. इफ दैट व्हाट इज डन. ओके, व्हाट is done, which one of this is done in the active management third shift labor? Yes, 10 units of oxytocin which is given intramuscularly can be given IV also. Okay, slow IV, otherwise you can give intramuscularly at the delivery of anterior shoulder. Right. Unable to recall properly. यही चल रहा है यार तब से. अभी कुमसेस वाला छोड़ दो, ये हो गया क्वेश्चन. मेलोडी. Melody, I don't know how did you get that name. Melody Fun. Okay, fine. Did you make that hashtag or did you make that name recently? Melody Fun. Okay, fine. ऑक्सीजन के साथ some options में और दो थे. ठीक है यार, हो गया ना यार. ऑक्सीटोसिन देते हैं. बाकी डिलेड कॉर्ड क्लैंपिंग और अर्ली कॉर्ड क्लैंपिंग is not the most important part of the active management of third stage of labor. You can do early cord clamping, you can do delayed cord clamping. It does not have any bearing on the PPH. साफ लिखा हुआ विलियम्स ऑब्स्टेट्रिक्स में. और भी बहुत सारे अपडेट्स आते रहते हैं, बहुत सारे एसोसिएशन अपडेट देने वाले हैं. We are going to follow what is written in standard books and what is standard practice in the labor rooms of a hospital, medical colleges. Standard practice is you can do delayed cord clamping because it helps increase the hemoglobin of the baby by 1 gram%. But even if you do early cord clamping, it does not have any bearing on PPH. चलिए आगे बढ़ते हैं. हाइड्रोसैल्पिंग्स में cogwheel appearance होती है. Correct. Hydrosalpinx में cogwheel appearance क्यों होती है? Because if you see the tube, normally it is like this. The normal tube is like this. Okay, but इसमें क्या होता है? Tube becomes very big. It becomes something like this, like a tobacco pouch. अब tube की जो normal anatomy होती है, उसकी वजह से there are these incomplete septae. You'll see this incomplete septae in the hydrosalpinx. So when you see a hydrosalpinx on the ultrasound, you'll see a cogwheel appearance, that kind of a incomplete septae which you see. So hydrosalpinx में cogwheel appearance होती है. But good, at least hydrosalpinx में क्या होता है? Somebody said cogwheel. Sir, यही था. Yes, something like that. Okay. चलो ठीक है. If you know this, then it's more than enough. Let's move on. Sperm criteria. What was the motility question? So what is the motility which is there? देखो अब आपको सबको पता है that we have to use the 2021 values. We have to use the 2021 values. Now 2021 values का जो भी change है, whatever WHO is telling you, we have accepted the WHO semen analysis values because these are standard taken over all the hospitals in the world. And the values are saying ki at least it should be this much. It can be more than that, whatever. The upper values are not given anymore. Long back there was this much to this much kind of values. Now they say at least itna hona chahiye. So what was the question? 39, 32, 40 answer tha. which is the best? क्या क्वेश्चन था? Sure, short, basic, I cleared with your subject was helpful. Okay, fine. Thank you so much. अभी क्वेश्चन पे रहते हैं. Thank you for your comments. But yes, अभी हम लोग क्या बात कर रहे हैं कि मोटिलिटी कितनी होनी चाहिए. देखो, टोटल मोटिलिटी is now 42% and active motility is 30%. थोड़ा सा उल्टा था पहले. Remember, total motility was 40%. Now it has become 42%, and active motility was 32. Now it has become 30. So what it was before, don't read that, because now you have to read for your NEET PG, and when you're reading for your NEET PG, these are the basics. Based on this, they'll ask you some more difficult questions. So yes, the total volume is now 1.4, concentration 16 million, count is 39 million. This was one of the choices, I think. That is the count. And total motility is 42%, active motility is 30%, right? Vitality is also reduced to 54%, but morphology is still saying the same, 4%. So what is morphology? Is a single best criteria. Single best criteria for the assessment of semen is the morphology. And if morphology is 4%, that means the patient, this man can have a normal, we can say he's got a normal semen analysis, because that's a single best criteria. Why am I saying it is normal? Because I say कि सारे parameters अच्छे होने चाहिए. But even if morphology is 4%, then I can give him his own biological child with the 4% morphology. All right. So morphology is the single best criteria. Okay. मोटली नहीं था काउंट पे, शायद क्या था बता दो यार, क्या था फिर? इफ इट वाज नॉट मोटिलिटी, काउंट पूछा था, काउंट 39 मिलियन है. चलो ठीक है, काउंट भी आपको बता दिए. इसलिए ये थोड़ा सा रिकॉल बेस्ड ही था. आपने मुझसे, देखो कई बार क्या होना, इस बार जो क्वेश्चन थे बहुत लंबे नहीं थे, जैसे कि वो 12-12 लाइंस वाले क्वेश्चंस नहीं थे, बट लॉट ऑफ यू सेड दैट द क्वेश्चंस वेर अ लिटिल intricate. They were integrated with the other subjects, so that's why it was difficult to read and comprehend. So it took time. So it must be very difficult for all of you to recall. So something like that came in the exam. Let's move on. That's a fairly simple question on recall. A patient underwent a termination of pregnancy 8 weeks ago, at 8 weeks, and she present with fever, bleeding, and PV, foul smelling discharge, per vaginal foul smelling discharge after 3 days. After 3 days, some people said after 5 days, means the same. Within 3 days to 5 days, if she's coming foul smelling discharge, that means there is some infection. So what is your diagnosis? So yes, the patient has had an MTP and now she's having foul smelling discharge. So we always say pain, discharge, fever. That's how I've taught you in the classes. I've told you PDF, pain, discharge, and fever. If it is there, that means there is a septic abortion. All right. So that was also a fairly simple question. Question was minimum motility count था sir. ठीक है, count motility जो भी था दोनों का मैंने आपको आंसर दे दिया. चलो next question पे जा रहे हैं हम लोग. So that is a septic induced abortion. One of the dreadest complications, because of which we say that MTP should be done only by a specialist, a gynecologist. It should not be done by any other physician, any other specialty, because MTP can have a lot of complications. Hota kya hai, MTP is done by a lot of people who are not even doctors sometimes, and sometimes they're only MBBS doctors who are working as gynecologists because they feel that they are good in doing this MTP, but only if they're certified that they worked for 6 months under a gynecologist or they've done 25 MTPs, then they're good enough. And I'm telling you, those people who are trained in gynae, even for 6 months and not done an MD, they are good to do these MTPs, because they know that complications of MTP can happen if you don't do it properly, and they can manage complications. And then these untrained dyes and people who are just associated with the medical system, that they were as nurses or they were working as dyes, and they start doing MTPs, they cause this maximum septic induced abortion. So this is a big problem. When you get into internship, you'll remember me saying this in your recall, that every week, whichever medical college you are, there'll be 1 or 2 patients in the ICU, in the corner bed, having a septic induced abortion and having these symptoms, and you'll be pouring in inotropic drugs, but the BP won't come up because she's in septic shock. You've done a laparotomy, you've done a lavage, but still 50-60% patients, they just die because of septic induced abortions. Yes, that's not a theoretical answer. I'm saying what we have seen, bad septic abortions will die. Of course, if it is a sepsis which you can control, then you should not have any mortality. Why have any mortality? But most of the time when they come to government hospitals, they are so sick that nobody is willing to take the case, and then they come and die in the government hospitals. So yes, Septic abortion, major problem. चलो आगे बढ़ते हैं. A woman at 30 to 50 years of age has come for screening or CE service. What is the best way to do the screening? गार्डन भी था, एक्टोपिक प्रेगनेंसी का भी चॉइस था. नहीं भाई, अगर अबॉर्शन हो गया, फॉल स्वेलिंग डिस्चार्ज है तो एक्टोपिक का नहीं होता है. बॉगी स्वेलिंग थी, ओके. बॉगी स्वेलिंग, एमटीपी का भी क्वेश्चन था, यही था. चलो ठीक है. अनएथिकल अबॉर्शन मेंशन था 5 days ago. चलो ठीक है. अनएथिकल मतलब जो मैंने आपको बताया, डिस्कस हो गया. चलो आगे चलते हैं. वुमेन ऑफ 30 to 50 years of age with CA service, what is the best? Come guys. कोटेस था ना? कोटेस था. वेरी गुड, बिकॉज दैट्स द चॉइस विच नोबडी टोल्ड मी, बट आई जस्ट रोट इट. कोटेस के बिना तो ये चॉइस हो ही नहीं सकती, ये क्वेश्चन आ ही नहीं सकता. सो यस, पैप्स every 5 year is wrong. If you do only PAPs, then you should do every 3 years, not 5 years. If only PAP is done, so that is wrong. Via visual inspection under acetic acid is cost effective, but not the best. So visual inspection is now being used as a cost effective alternative to pap smear. I agree, but pap smear has reduced CA cervix incidence by 70%. Although it's not a very sensitive test, but it's a very good screening test. It's cheap. Visual inspection under acetic acid is also much cheaper. You have to just put acetic acid, 1 drop, 2 drops on the cervix, but to interpret a VIA, you need a good gynecologist, and to take a biopsy and send it to a pathologist, that will take some effort. So as and when it is accepted all over the country and as a viable option and a viable alternative to pap smear, when that happens, we'll teach you. But it is cost effective, that I agree. But even now, the best method is pap smear, and you should do it once in 3 years. If only PAPS is done, but if a co-test is done, which is the PAPS and the HPV DNA, then you should do once in every 5 years. अब आप लोग क्या पूछ रहे हो? co-test 100% था. चलो बस ठीक है, उसमें आंसर हो गया. चलिए, इस बार प्रिपरेशन में क्या चेंज करना पड़ेगा? आपको इसकी प्रिपरेशन तो करनी नहीं है ना, ये तो आप पास कर चुके हो. आपको तो NDPG की बात करनी है, वो अभी बात करेंगे जब आप लोग PW के जो फंक्शन में आओगे. आप लोग सब हमारे साथ विल बी फेलिसिटेटिंग यू एंड विल बी हैविंग लंच और डिनर टुगेदर, एंड दैट टाइम यू आस्क मी अबाउट द नीट PG प्रिपरेशन. ये प्रिपरेशन थोड़ा करनी है अब तुम्हें. ये खत्म हो गया, MCI खत्म हो गया. ये सबके लिए टफ था. अगर आपके लिए टफ है, सबके लिए टफ था. एक आदमी के अकेले के लिए टफ नहीं. ठीक है, PDF मिल जाएगा यार, कहीं पे भी आएगा, मेरे फ्रेंड्स दे देंगे आपको. चलिए, वीडियो क्वेश्चन ऑन अ प्रोलैप्स पेशेंट विद अ मेश एप्लीकेशन. देखो, प्रोलैप्स में हम लोग क्या करते हैं, वी डू अ पेल्विक फ्लोर रिपेयर. इफ अ वुमन, देखो प्रोलैप्स का यू शुड नो द मेन प्रोलैप्स patient is the old woman who is postmenopausal. So you take out the uterus. See, I told you that many times. See, the uterus is coming out from the pelvic floor. See, this is the pelvis, this is the floor, the muscles, and the uterus is coming out from here. So when the uterus is coming out from here, let me try and show you with this. See, the uterus is coming out from here. Yeah, see, if the uterus is coming out like this. So uterus is coming out like this. So what do? You do a hysterectomy. Uterus को निकाल दिया. But you have to close this vagina, do a pelvic floor repair. So what do you have to do? You have to repair the anterior vagina and the posterior vagina. So anterior vaginorrhaphy, which is known as anterior colporrhaphy, and posterior vaginorrhaphy, which is also called posterior colpoperineurrhaphy. So this pelvic floor repair, it has two components, anterior colporrhaphy, posterior colpoperineurrhaphy. Yes, together that is what is known as pelvic floor repair. So I would like to do it with sutures, cutting off the excess vagina and putting sutures and approximating the tissues. I generally do that. A lot of people like to do a mesh, but that mesh is basically to give a pelvic floor repair, to do a cystocele repair, the anterior vaginorrhaphy, and then a rectocele repair, which is known as the posterior colpoperineurrhaphy. So that is part of the prolapse management. ऐसे कुछ क्वेश्चन था. Vaginal mass prolapse, मुझे लग रहा था OBG के क्वेश्चन आपने ही बनाए. अरे वाह, थैंक यू सो मच. Yes, I wish we had such powers to predict everything, but आगे बढ़ते हैं. That was about prolapse. So prolapse and pelvic floor repair करते हैं. आगे बढ़ते हैं. Mode of action of Mac-Roberts maneuver. I'm very happy that we have taught you this always, and you must understand that when you do a Mac-Roberts maneuver, I have always told, I started teaching PG around 2004 beginning and started teaching MCA 2007. Sorry. I'm so sorry. Yeah, 2007, 2008. And ever since I started teaching MCI students, I've seen that Mac-Roberts will come once in a year, definitely. And for you guys, it has come in 2-3 exams in last year. And again, it has come now because there are 5 exams in a year. Mac-Roberts maneuver, flexion of the thigh more than 90 degrees. It straightens the the pelvic inclination, it is straightened. All right. So I'll just write that. So the procedure causes straightening of the sacrum related to the lumbar vertebra. So sacrum straight हो जाएगा. So baby और आराम से अंदर जाएगा. Rotational symphysis previous towards the metal head and decrease the angle of the pelvic inclination. So this straightening will help the baby come out better. So the procedure, flexion of the hip joint, is always asked, and you know it is more than 90 degrees. उससे होता क्या है? We've always given you in the notes, but now they've asked you this part. They've not asked you McRoberts पहले करते हैं बाद में. If you read your Williams obstetrics, it is given very straightforward that the first thing to do is the flexion of the hip joint more than 90 degrees. Yes, then suprapubic pressure and the Woods corkscrew, and then the the Gaskins and the Javanellis, all of that you guys know very well. चलिए, benefit पूछा था, urinary incontinence. Biophysical profile, calculate and say the management. I think some findings of biophysical profile was given. And this is this much, this is this much. So what is the biophysical profile and what is the interpretation of that? So I've told you a rough thing that I said that 10 by 10 is a perfect biophysical profile and 8 by 10 is okay, accepted, you can continue the pregnancy. By 6 by 10 is a 6 by 10 or lesser is a compromised fetus. It's a compromised fetus. So ये एक मैंने रफ गाइडलाइन दी थी आपको, इससे हमारा काम हो जाएगा एग्जाम्स में. बट मैंने कहा था कि अगर मोर डिटेल में पूछते हैं तो मैं ये आपको, आई टॉट यू दिस इन द मैराथन 4 days बैक, दैट आई एक्चुअली टोल्ड यू दैट दिस इज द इंटरप्रिटेशन of the complete biophysical profile, and they are not likely to ask you the complete interpretation, but they asked you anyway. We taught you also, so अच्छा है अगर आपको ये याद था तो it's very good. Otherwise, what is the question? 5 to 6 आंसर था. Okay, 5 to 6 आंसर था. So other options में 8 and 10 पूरा बाउंसर था. अरे नहीं यार, ये तो हमने बात करी हुई है ना यार. तो yes, अगर 8 by 10 है तो it is acceptable. We can continue the pregnancy provided that the liker is enough. 8 by 10 के साथ भी देखो ना, नॉर्मल A5 होना चाहिए. और अगर A5 कम है और 8 by 10 है तब उसको भी डिलीवर करना होगा. बट 6 by 10 है तो डेफिनेटली वी आर वरिड. विथ नॉर्मल A5 ऑल्सो वी आर वरिड. वी रिपीट इट. अब अगर 6 by 10 है और डिक्रीज एमनियोटिक फ्लूइड इंडेक्स है, सो इट इज फीटल हाइपोक्सिया. तो अगर 6 by 10 है तो इट इज हाइपोक्सिया, यू हैव टू डिलीवर. So yes, I did tell you that it may not come in exam. How I taught you. Yes, sometimes people concentrate more on what I say. It is not likely to come in exam. फिर भी पढ़ा देता हूँ, and it comes in the exam. So it's nice that at least we taught you that. AFI कम था. There was no AFI कम था और 6 by 10 था. Definitely we have to go and deliver. चलो अच्छा है. कॉम्प्रोमाइज पूछा था. ठीक है, ठीक है, आई गॉट योर आंसर. चलो ठीक है, ये क्वेश्चन डिसेंट रिकॉल हो गया. आगे बढ़ते हैं. एंटीफॉस्फोलिपिड एंटीबॉडी इन अबॉर्शन का क्वेश्चन था. व्हाट इज दैट क्वेश्चन? एनीबॉडी? एंटीफॉस्फोलिपिड एंटीबॉडी अगर है, so we know that anti-phospholipid antibody is the acquired thrombophilia. So thrombophilia, what I was talking to Dr. Santosh before starting the session, that thrombophilia, you should understand, is a tendency to make a thrombus, and if there's a thrombus in the placental blood vessels, the baby will have an abortion. If there's a thrombus formation later in pregnancy, then the blood doesn't go properly to the baby. Mother increases the blood pressure to send blood through those thrombus vessels. So the blood pressure can increase. They can be IUGR also. So antiphospholipid antibody is one of the thrombophilias, one of the types of thrombophilias, and these are the antibodies. And इसको पढ़ लेना. अब ये क्वेश्चन आने लग गया है, तो नीट पीजी के लिए read this even better. You have to know those antiphospholipid antibody का Sapporo's criteria, and then the thrombophilias के there are many criteria. So you must read this in detail. Your medicine people are teaching you way better than I can, but yes, this bothers us in pregnancies also. चलिए. अच्छा, management क्या है? Management was asked. Okay, fine. That is even अच्छा ठीक है, चलो. If there is a thrombus formation, what do? You give anticoagulants. So what we do in our patients, we give them low-dose aspirin and we give low molecular weight heparin. That's what we do. Low-dose aspirin in LMWH था. Antiplatelet. आ रहे हो बात? देखा ना यार? Thank you. Zameen Bhatt has exactly told. Zameen Bhatt, you're in Kashmir or you're here? I hope wherever you are, and thank you for writing the exact choice which I was hoping. So antiplatelets, we give the low-dose Ecosprin, and then we give the low molecular weight heparin also throughout the pregnancy. ठीक है, बढ़िया, बढ़िया, ये आंसर करेक्ट. Chali, I'm sure you could guess that at least if you had attended the marathon session with us. Chali. Sickle cell trait. Sickle trait, both parents को what is the diagnosis criteria? I'm sorry, sickle trait है both parents को what is the diagnosis criteria at 20? This is how the student recalled and I copied and pasted. So sorry for the English kind of a question, but yes, a sickle cell trait is there, and what is the diagnosis criteria at 24 weeks? So if both the parents have the trait, then we have the problem that the baby can be 50% positive. So how can you be very sure of the genetics of the baby? So you can do a chronic villus sampling, you can do amniocentesis, you can do cordocentesis to get the information of the baby. But at 24 weeks, we generally do the amniotic fluid amniocentesis. So amniotic fluid assessment is the best because it is lesser invasive than a cordocentesis. Cordocentesis, we get the blood, but that can have more complications. So amniocentesis is very decent and safe. Around 16 weeks onwards, we can do the amniocentesis. Chronic villus sampling is done earlier, 10 to 13 weeks. Okay, cordocentesis can theoretically done after 18 weeks, but we prefer doing a amniocentesis. It is lesser invasive than a cordocentesis. चलिए, non-invasive था आंसर में. Non-invasive. Non-invasive. तब तो फिर अरे non-invasive था तब तो फिर NIPT चॉइस नहीं था क्या? NIPT तो आप लोग मुझे बोल ही नो क्योंकि यही non-invasive टेस्ट है. This is 98% sensitive. 98% sensitive होता है. But not 100%. So if it is 98% sensitive, 16 weeks, okay, fine. ये तो है फिर NIPT is done at that time. So after 10 weeks, NIPT will assess the cell-free DNA of the baby. Cell-free fetal DNA can be assessed in the maternal circulation, and NIPT we do so much these days, but it is not 100%. 16 weeks NIPT था कि नहीं चॉइस में? NIPT था. Oh, thank you so much, अभिनय पांडे. आपने हमारा एक क्वेश्चन कंप्लीट कर दिया. तो रिकॉल में my PW team, I hope all of you will look in this and we'll make a proper MCQ now because we have all the choices. Very good. NIPT था. NIPT आंसर है भाई. हो गया. ये तो पढ़ा है आप लोगों को यार. I told you ना कि what do you do? एक पूरा चार्ट दिया था मैंने आपको. And I told you what all you can do. At 10 weeks to 12 weeks, we can do the, around 12 weeks, we can do the dual marker. And then we can also do an NTNB scan at around 12 weeks. Then at around 16 weeks, we can do the triple marker. We can do the quadruple marker. And after 10 weeks, we can also do NIPT. All the screen tests on one side. Then I told you the interpretation of those tests. And if at all they are high risk, then I told you also the diagnostic test. So yes, this was the easy one. आगे बढ़ते हैं. 6 centimeter dilatation from 3 hours. Patient is on oxytocin already. So what to do next? मतलब कह रहे थे कि 3 घंटे से 6 सेंटीमीटर पे है. तो अगर I don't know if the contractions were good or not. You didn't tell me. तो मैं थोड़ा wait कर लेता हूँ. If you have some suggestion about this question, I'll just wait a little bit. Amniocentesis invasive है यार, उसको छोड़ दो. Amniotic fluid था, but देखो 6 सेंटीमीटर है और मेरे को क्वेश्चन की लैंग्वेज नहीं पता. अगर ARM नहीं हुआ है तो we do ARM to augment the labor. If the question is saying that the contractions are not good and it is 6 centimeters for the last 3 hours, that's not enough progress because I want progress 1 centimeter dilatation and 1 centimeter descent every 1 hour. So 3 hours if there is no change, then I'm not happy. I want to augment the labor. So oxytocin से नहीं हो रहा तो ARM करेंगे. But choice क्या था? Oxytocin is everything was fine. सिजेरियन तो नहीं होगा आंसर. डिस्ट्रेस नहीं है तो 6 सेंटीमीटर से सिजेरियन नहीं होता है. अगर डिस्ट्रेस नहीं है और सीबीडी के अगर मोल्डिंग बताया था और मोल्डिंग के साथ देयर वाज की लाइक देयर इज नो डिसेंटिंग स्टेशन ऐसा कुछ, तो थोड़ा क्वेश्चन ज्यादा बताना पड़ेगा यार. अब मैं कुछ भी बोल दूंगा, बोलोगे कि सर आपने आंसर बनाया, आपके दूसरे फ्रेंड्स जो पढ़ा रहे हैं दूसरे फोरम में उन्होंने ये आंसर दिया, हम कंफ्यूज हैं. क्वेश्चन ठीक से बताओगे तो मैं बता सकता हूँ. कॉन्ट्रैक्शंस वे गुड. ARM हो चुका था, ग्राफ भी दिया था, एवरीथिंग वाज नॉर्मल. then ठीक है, then you can do conservative management, you can wait and watch. Yes, then you can wait for increase. ये 3-6 centimeters पे we will not say. अगर वो एक्शन पे जा रहा था, अगर एक्शन लाइन को टच कर रहा था, then we can think. But 3 hours में एक्शन लाइन को टच भी नहीं करेगा वो. 3 hours में एक्शन लाइन को टच ही नहीं करेगा, क्योंकि अलर्ट लाइन और एक्शन लाइन में 4 घंटे का फर्क होता है. तो 3 hours में एक्शन लाइन को टच ही नहीं करेगा. तो ये आराम हो चुका था, बस ठीक है. Then you can observe. Then you can observe. ये continue the progress. थोड़ी देर में हो जाता है. कई बार सर्विक्स को टाइम लगता है डायलेट होने में. हम लोग क्या करते हैं लेबर में, we generally go and stretch the cervix physically. ऐसा होता है ना, एआरएम हो चुका है, ऑक्सीटोसिन डाल चुका है, वी गो एंड स्ट्रेच द सर्विक्स. वी आर टीचिंग यू ऑब्जर्वेशन, बट गायनेकोलॉजिस्ट नेवर ऑब्जर्व. वी आर वेरी मच ऑन द एज. We are very impatient people. One of my PW friends was recently telling me that I'm impatient. Yeah, because we are gynecologists. We are always on the edge. We have a basal metabolic rate. Santosh, I hope you're not listening. And of course, my good friend Sandeep. So we have a BMR which is very high and the pulse rate is very high. Gynecology is always on the edge. So we are always, trying to do something to finish things fast. So हम इसको स्ट्रेच कर देते हैं जाके, और सर्विस को कि 6 को 8 तो बड़ी जल्दी बना देते हैं हम लोग, और 2 घंटे बाद अगर डिलीवरी नहीं होती तो 8 को 10 भी कर देते हैं. बट दैट्स नॉट इन द ऑप्शंस. यू कैन ऑब्जर्व दिस पेशेंट, दैट्स ऑलराइट. एनएससी का ग्राफ दिया था. चलो ठीक है. ट्विन डिलीवरी, first baby is cephalic, second baby is by breech. What do you do to deliver? If the first baby is cephalic, then we can do normal vaginal delivery and we can do a breech extraction. So when we can do a breech extraction and when we can do a breech assisted, any breech which is delivering, we can do normal vaginal delivery. But if it is a second of twin, and in a breech, it'll deliver. So we can do a assisted breech and breech extraction. But breech extraction is done only for the second of twin in transverse lie. If it is a second of twin in breech, I'll wait for the normal delivery. I don't have to do breech extraction. Breech is always assisted. Breech is always assisted breech vaginal delivery. Always, even in second of a twin, if it is in breech, I'll do assisted. Assisted का मतलब होता है don't touch the baby till the umbilicus is delivered. And then if it is required, legs are flexed, I'll pull the legs. If the legs are extended, I'll do pinards. But if the second baby is in transverse lie, if second was transverse lie, then I do internal podalic version, and that is followed by a breech extraction. Yes, breech extraction only indication is second or twin in transverse lie. So internal podalic version, बच्चे को पढ़ के ऐसे सीधा करते हैं and legs को पढ़ के हम बेबी को निकाल लेते हैं. That is IPV and a breech extraction, second or twin on transverse lie. But if it is only a breech without any other problem, I'll do assisted breech vaginal delivery. और क्या पूछा था? बर्न मार्शल वाला एक और डिफरेंट क्वेश्चन था. ये नहीं था क्वेश्चन, कोई कुछ और था. फर्स्ट सेफेलिक सेकंड ब्रीच था. यस, फर्स्ट सेफेलिक सेकंड ब्रीच में आप एसिड ब्रीच वेजाइनल डिलीवरी कर सकते हैं, और अगर ट्रांसफर लगेगा तो आईपीवी के साथ ब्रीच एक्सट्रैक्शन कर सकते हैं. बट अगर बर्न मार्शल था तब तो सिंपल है. बर्न मार्शल की पिक्चर तो पता ही है आपको. द हेड इज इनसाइड द बॉडी ऑफ द मदर and the baby is hanging outside. ऐसा होता है कुछ देखो ना, ये pelvis होता है, इसमें से बच्चे का सर अंदर होता है, and the baby is hanging like this. So what do? You hold the baby and turn the baby upwards like this, and the head pops out with flexion like that. You turn the baby upwards and the head pops out with flexion. तो बर्न मार्शल अगर दिया था तब तो सबसे सिंपल हो गया. That is so easy for you to answer. चलो, बर्न मार्शल था, ठीक है. बर्न मार्शल मैंने समझा दिया आपको. चलिए आगे बढ़ते हैं. डायबिटिक मदर, ट्विन प्रेगनेंसी, फर्स्ट बेबी, सेकंड बेबी इज इन ब्राउ प्रेजेंटिंग पार्ट. ये किसी ने मुझे वेरिएशन दिया कि ब्रीच नहीं था, ब्राउ था. यार, फर्स्ट सेफेलिक, सेकंड ब्रीच, सेकंड ट्रांसवर्स, कैन डिलीवर, सेकंड ब्राउ है. यार फिर तो सेकंड का सिजेरियन करना पड़ेगा, ब्राउ नहीं घुसेगा अंदर. ये था क्वेश्चन. मतलब ये बहुत, यार मेरी लाइफ में बहुत कम आया ये तो. सेकंड ब्राउ तो छोटा सा, में तो ट्विंस है ना, तो बच्चे छोटे होते हैं तो ब्राउ में नहीं फंसते हैं जनरली, हेड फ्लेक्स्ड ही आता है. तो ये तो मेरे मतलब बहुत ही थ्योरेटिकल क्वेश्चन आपने पूछ लिया. ये नहीं था ना, ये क्वेश्चन ही नहीं था. चलो ठीक है, क्वेश्चन नहीं था। अगर ये हाइपोथेटिकली आ जाए सेकंड इज ब्राउ, तो सेकंड का तो सिजेरियन करना ही पड़ेगा। अगर बाद में पता चलता है कि ब्राउ है, हम लोग सेफेलिक सोर्स की डिलीवरी कर रहे थे, दूसरा अगर ब्राउ हो गया तो पहला नॉर्मल होगा, सेकंड फिर सिजेरियन करना पड़ेगा। बट ये क्वेश्चन नहीं था, हाइपोथेटिकल चल रहा है, ये नहीं था, चल नहीं था, नहीं था, नहीं। अच्छा चलो भाई छोड़ देते हैं। ब्रैकीथेरेपी इमेज वाज देयर, व्हाट इज द एडवांटेज? ब्रैकीथेरेपी मतलब गिविंग, मैंने आपको आई थिंक आई टॉट यू इन द मैराथन or in the predictor, I think in the marathon I taught you that you can put these tubes inside, and in that the radioactive source is given, and then you put the ovoids here. So the tandem and ovoids I taught you. So the tandem and the ovoids which I taught you are the methods of giving internal radiation or brachytherapy. If you give radiation from outside, teletherapy. Yes, that's what we discussed. So what is the benefit of giving a brachytherapy? Yes, one of the answers which the student said, ki IMR reduces damage to the surrounding tissues. Yes, because when you give radiation, in addition to the part which is intended for radiation, there will be radiation other places also. So I think it was not CA cervix specifically, it was just about therapy for generalized radiotherapy discussion. So ट्विन टू ट्विन ट्रांसमिशन सिंड्रोम आते हैं। सो ट्विन टू ट्विन ट्रांसमिशन की बात बाद में करेंगे। क्लैरिफाई एस्टेट ब्रीच एंड ब्रीच एक्सट्रैक्शन। एस्टेट ब्रीच मींस दैट यू डू नॉट टच द बेबी टिल द umbilicus delivers. Let the breech come out and the back also come out at the level of umbilicus. Then only you touch the baby. That is known as assisted breech vaginal delivery. All breechs are delivered like that. Only exception is second or twin in transverse lie. If the second or twin is in transverse lie, let's see, if this is the head of the baby and this the legs are here and it's in transverse lie, you go inside, hold the legs, turn the baby like this. So head is here and this is the breech here, then you pull the baby out. So that is what is known as the breech extraction. Only indication is second or twin. कोई एक सिंगलटन बेबी अगर डिलीवरी हो रहा है या सेकंड इन ट्विन इन ब्रीच है तो उसको हम करते हैं एसिड ब्रीच वजाइनल डिलीवरी। ऑलराइट, invasive, non-invasive. See, brachytherapy is not invasive. You're placing it inside the, I mean, I hope they're talking about brachytherapy in CA cervix. So you're putting a rod inside the cervix. It's not very invasive. OPD basis में हम लोग जैसे एक छोटा सा instrument cervix में डालना है, patients will tolerate that easily. It's not invasive. You're not piercing somewhere. You're not doing a blood test or something like that. Exactly, option said reduce damage to the surrounding tissue, and that's what I told you. I have just got this one option from students. Maybe the radiology doctor would have also told you this answer also. Brachytherapy is not invasive. It's not like an invasive problem. It's just that you put the sources inside the body. So whether you call it invasive or not, then we keep giving radiation to so many CA cervix patients. I'm not actively doing that because it is done by the radiotherapist these days. So we don't say it is invasive. We say that you're placing it inside the body. All right. Hot flashes after menopause are due to what? I don't know what were the choices, but this is a fairly simple question. It is because of lack of estrogen and increase in the LH and the dopamine and the noradrenaline, because what happens that there is constantly high LH. And this LH comes out in a pulse once in 90 minutes. You know, the pulsatility, the GnRH is released pulsatile. So every 90 minutes, there is a pulse of LH and a pulse of dopamine that causes vasodilation, and a wave of heat goes down the back of the patient. So I always told you that HRT will come in your life or menopause will come in your life as questions wherever. So this question has come. It is because of increased LH, dopamine and the noradrenaline. Of course, reduce estrogen, reduce progesterone would have been a better choice, but it is not given there. So it's there. Okay, chalo. C endometrium. Now, which is the tumor marker which is specific for C endometrium? देखो सबसे common, more than 50% of solid tumors, all solid tumors in the humans, P53 तो एक mutation होता ही है. P53 जो suppressor एक gene होता है उसका mutation more than 50% solid tumors में देखा जाता है. तो this is not generalized. So P10 mutation in the P10 is direct relation to the type 1 C endometrium. Because 80% of C endometrium is type 1 or the endometrioid cancer of endometrium. So usme P10 mutation is more specific. Was that the question? P53 tha. Yes. P53 was a choice, but P53 is not specific. P10 is specific to say endometrium. P53 is there in a lot of tumors. You can see the most common mutation in tumors is the mutation of P53, and this suppression gene, if it is mutated, then there will be proliferation of cancer tissue. Most common hota hai ye. So it is not specific with this. All right. Next question. The most common, yeah, I've written that for you. Most common mutated tumor suppressor gene in human cancers. Human cancer, not in endometrial also. Human cancers is P53. And the majority of endometrioid tumors were identified as having a frequent mutation in P10. So I hope you can now correlate with the choices which came in the answer. P10 is the answer. Okay, fine. Reason of formation of biconate uterus, it's a lateral fusion defect of the Mullane system or a vertical fusion defect. It is basically a lateral fusion defect. I taught you somewhat very simply in the question earlier. Yeah, that if you see that there are two ducts, the two ducts will come and fuse like this, and then outpouchings come. See this, these outpouchings come from the uterus and they make the upper vagina. So the lateral fusion, if it is defective, it makes a biconate uterus and a septate uterus. So I hope that was a question. The question nahi tha. What was the question? If you want, you can tell me fast. Otherwise, we'll move on. Somebody said there were 35 questions in gynae. Somebody said there were 70 questions in gynae. Yeah, anatomy, physiology, pharmacology, if there were some related questions, the teachers will take that discussion with you. So if this was the question, then let's move on and see something else. Fusion defect tha, lateral or vertical nahi tha. No, it's a fusion defect. ठीक है, it is a fusion defect, fine. A wound with postcoital bleeding, yes. अब इसमें मेरे को लगा कि ये क्वेश्चन थोड़ा सा expected आ गया. A woman with postcoital bleeding and per vaginal examination, there are no local lesions. Most likely lesion क्या होगा? मतलब most likely cause. Most likely cause. So I'm just copying and pasting. Most likely cause. क्या होगा? So yes, postcoital bleeding. I think the woman was postmenopausal. I think 55 years किसने बोला, 60 years किसने बोला. So I think 50 to 55 years का question था, and the patient has a postcoital bleeding. So around that age, the cervix, ectropin and all ये तो सब settle हो जाता है. And CA cervix हो सकता है क्योंकि 35 to 55 is the age where CA cervix presents. So yes, gynae के अलावा कुछ नहीं आया. So it was diadelphys, not biconate. Yeah, diadelphys and biconate is also a fusion defect. Correct. That is also there. Endometrial hyperplasia. Endometrium hyperplasia was in the option. Okay, chalo, hyperplasia was in the option. वो भी लिख लेते हैं. So postcoital bleeding नहीं करेगा. ये तो आंसर हो ही नहीं सकता. Postcoital bleeding नहीं करता है. Cervical ectropin हो सकता है. CA cervix हो सकता है. CA vagina हो सकता है. All three can cause postcoital bleeding. But the most common cause of presentation of a woman at this age and postcoital bleeding, I'll think of CA cervix. So I will mark CA cervix for this question. Very common in our country. आप लोग क्या बोल रहे हो? 34 और 38. चलो ठीक है, 34 और 38 कर देते हैं क्योंकि स्टूडेंट्स ने जो बताया मैं वो बता रहा हूँ. 34 to 38 में still postcoital bleeding. Endometrial hyperplasia था. Endometrial hyperplasia will not cause postmenopausal bleeding. The bleeding will be irregular acyclic bleeding. 34, 35 में तो होती भी नहीं है endometrial hyperplasia इतनी. CA was not in the option. CA was not in the option. Okay, fine. Then I'll go with ectropion. If CA cervix, if no CA cervix, chaliye, those who are seeing this as a recording, guys, those who are seeing this in a recording, we are having a live session where I'm getting live feed of the choices. And if this was not in the choice CA cervix, if no CA cervix, then I'll say it's an ectropion. Because yes, earlier I thought the choice was 58. 58 में ectropion नहीं होता यार, उससे पहले सब खत्म हो जाता है ये सब. But अगर 30-35 years है और postcoital bleeding, ectropion हो सकता है, vaginitis भी हो सकता है, vulvitis भी हो सकता है. ऑप्शन ही नहीं था. Yes. Intermenstrual spotting भी कर सकता है. Yes, ectropion can be the answer. Correct. Then it can be the answer. 34-35 में ectropion present कर सकता है. CA cervix, very good. Postcoital bleeding can happen by many reasons. Vaginitis, vulvitis से भी हो सकता है. चलिए. IUCD thread loss. What is next? I would do an ultrasound. If IUCD thread is lost, and patient has not remembered passing IUCD out, I will always do an ultrasound. X-rays नहीं करते हैं पहले हम लोग. X-rays are supposed to be causing radiation to a young patient. We don't want to do the X-ray. But yes, जरूरत होगी तो कर भी सकते हैं. If it is lost, ultrasound से IUCD दिख गया uterus में, fine. Ultrasound में, if it is not seen in the uterus, then I will do a X-ray. I'll put a probe into the uterus. I'll put a Hagar dilator into the uterus and then do a X-ray from the front and from the lateral view to see whether it is a lost IUCDs inside the uterus or outside the uterus. So X-rays can be done. The first will be always an ultrasound. USG was not in the option. Okay, USG was not in the option. Then first I would do X-ray. Then I would do an X-ray. I will not put another IUCD inside. No यार, invasive होता है. Lost है, अगर perforation की वजह से lost है तो I'll put this more IUCD inside. No, that's not the best thing to do. USG was not in the option. So, Sukesh, we are here. We are still friends in so many other forums. Come. Histosalpingogram था. HSG, no, not HSG. I'll do an X-ray. HSG नहीं करते. HSG अगर था, तो I will not do that. Not at all. Beta SCG was lost IUCD था यार. CT was there, not X-ray. MRI कोई बोल रहा था. ऑप्शन लाइक निकालोगे उसे किसी प्रोब से, यस, अगर वो था तो सबसे बढ़िया है. IUCD hook अगर लिखा था, if it was given there, then the IUCD hook is the best thing to do. Yes, it's a curved instrument. You push it inside the uterus. If it is thread is lost, that's what we do in the OPD. First thing we do that. Yes, सबसे पहले अगर ये choice था तो सबसे बढ़िया है. It is like this, the thread. Now, if the thread is lost and it is only an IUCD inside, the thread is lost and just the IUCD is inside like this, then we have a hook. We just go inside and hook it and take it out in the OPD itself. So if the IUCD hook was there, that is the answer, guys. अब वो बोल रहा है IUCD hook नहीं था. तुम लोग डिसाइड कर लो यार, फिर कभी कुछ करते हैं. So if the IUCD hook was there, that's the answer. If X-ray was there, then that is the better. I mean, if ultrasound was there, that is a better answer. And if IUCD hook was there, then we could have done in the OPD itself. Dilate and remove with the probe. That's fine. Dilate and remove with the probe means the same. The probe is, you cannot take it out by sound. You have to take it with IUCD hook. So that probe is called IUCD hook. Yes. Dilate and take out. They're not visible. MRI was there. MRI नहीं करेंगे यार. MRI बहुत expensive है, बहुत time consuming भी है. MRI नहीं करेंगे. This is the last thing, if at all. It is definitely the best imaging, but we don't do for lost IUCD MRI. I don't know, even once in my life I've done that. So many times lost IUCDs, we just take out in the OPD with IUCD hook or with a long artery forceps. Or very badly stuck, then I do a hysteroscopic removal. Ultrasounds are always done for all these patients, but सबसे पहले अगर OPD में नहीं निकलता है, we do ultrasound. आपको बोल रहे हैं कि IUCD hook was there, there's a probe, then go ahead and take that. चलिए guys, probing was there, that's fine. चलिए. So guys, these were the questions which I have been given, and what I got as a review was that the predictor book which we gave you, and then all the marathons which we did, that helped all of you to get most of the questions, if not all. And if we are getting the feedback of most of the questions, I think that's job well done. If anybody says that I have taught you everything which has come, then that's a big lie, because medicine is so big. I'm saying medicine has all the 19 subjects put together. The human body is your course. And if somebody says that we have taught you exactly everything which came in the exam, then that would have been a whole lot of books you read, because that's like becoming an MD in all the 19 subjects. We are not making you that. We are making you pass this exam and then pass the NEET PG exam so that you can become MD in one of the subjects. So everything about everything, if we have to teach you, then that is MD in each 19 subject. Nobody can teach you. Nobody can read that much, isn't it? So yes, hoping that all of this discussion which we had in the predictor book and the predictor series and the marathons, hoping that is helping all of you guys. Keep stay connected with us. And one more question. So there was a question: low FS and low MH in athletic female. That is because of a hypothalamic suppression. Yes, that's a good question. Stress related hypothalamic suppression, hypothalamic amenorrhea because of chronic stress. Correct. Okay, you are the OGs. All right, thank you. Okay, steroids history can suppress. Steroid history in a man. There was some vague discussion about that in the forums which I was discussing. If you give steroids, it can suppress the spermatogenesis. A lot of these gym people take these anabolic steroids, and that can cause the suppression of the spermatogenesis. So yes, that can suppress. You're correct. Chali, theek hai. We have a lot of discussion still left, and it's getting late in the night. And we are always here on the PW forum to take your questions. Why don't you just, I think, hypothalamic hypogonadism, yes, correct, stress related. So you guys can write in this chat, or you can write in the the question sessions, in the comment session. We can always get back to an answer. All right, guys. So all the best, and handing over to Dr. Santosh and Dr. Sanchit, who is going to take over and teach you ENT now. Bye, guys.
Thank you, sir. Sanjit sir, over to you. Once you're ready. Guys, I think there were plenty of questions from ENT, plenty of image-based questions, and ENT turned out to be an extremely high-yield subject this time. Most of the things were on expected lines, at least as far as I interacted with students. Sanjay sir, once you're ready, you can take over the baton. Over to you, sir.
Hello, Santosh sir, and hello to all dear students who have joined today. Welcome to ENT Recall. And PW mein, obviously, we are going subject by subject. You had a very comprehensive recall as far as OBG was concerned from Prasan sir. And my job will be to cover up what exactly you need for ENT. ENT इस बार का बहुत scoring था. We got almost 14 questions as a recall from the students from ENT. And ENT के recall में what we saw was कि इस 14 में you must have got these questions somewhere, या तो आपके marathons में, या फिर in TND, or या फिर in the predictor series that we recently did. So I hope that you get all the 14 right, क्योंकि ENT is scoring this time और ये आपको pull up करेगा indefinitely your results, right? ENT was all the predictors. Thank you very much. Yay. This was all the game. So let's start the first and foremost question. ENT में सारे predictions आए हैं and the exact images were given. What so all जो हमारे marathons में थी. First question. 20-year-old male presented with ear discharge with severe itching as well as pain in for 7 days. On examination, wet newspaper appearance, जिसमें कुछ black and white दिख रहा है, ear discharge दिख रहा है. I told you whenever you see black and white, this is fungus, and the answer definitely becomes otomycosis. We call this particular condition as a wet newspaper appearance, where you get everything black and white. Straightforward, यही image मैंने आपको दिखाई थी over in your marathon as well, where we did the same image saying about Aspergillus fumigatus as well as Niger and Candida albicans being the most common organisms which cause this particular condition. So इस particular answer का straight away logic हो गया that this is otomycosis. Nobody should get this wrong. Everybody should get this right. Straightforward, right from the TND and the marathon. चलिए, question number 2. I told you, अगर palsy से related question आएगा and if you get the buzzword means cannot put the high-pitched notes after a thyroid surgery. Same question. 41-year-old underwent thyroid surgery for a colloid nodule, complains that they do not have complaints with normal voice. उसमें कोई problem नहीं है. But she has a difficulty in producing high-pitched notes. High-pitched notes कौन होता है? High-pitched notes is only because of cricothyroid muscle. The only muscle of the larynx which is not supplied by the recurrent laryngeal nerve is cricothyroid, which is a tensor of your vocal cord, and it is supplied by the external branch of superior laryngeal nerve. So the answer here becomes that during thyroidectomy, maybe that surgeon has cut off the external branch of superior laryngeal nerve, जिसकी वजह से cricothyroid injure हो गई, and that led the voice to get down. Direct question, straight again from the marathon, where I explained you the difference between RLN and SLN, and I gave you this buzzword of अगर आपको high pitch note आया, answer होगा cricothyroid supplied by external branch of superior laryngeal nerve, right? तो ये सबका right होना चाहिए. This should be right for everyone, for whatever I have got from the questions, right? चलिए, everyone is saying it right, बिल्कुल सही. Now let's move on to another important question. ये X-ray image थी, again straight from the predictor. हमने ये question predictor series में किया भी है, and same image भी करी थी. 7-year-old boy presented to the OPD with high-grade fever, drooling of saliva, severe odynophagia. On the X-ray soft tissue neck lateral view, you see something like this. What is this? जब कभी भी आपको lateral view में you see what? You see that there is an prevertebral shadow which has become widened. Second, there is straightening of cervical spine, right? Third, that you have got these kind of gases within this shadow. What does this signify? इसका मतलब है this is a retropharyngeal abscess X-ray. And this retropharyngeal abscess X-ray has a classical prevertebral shadow widening, right? ये क्या आंसर होगा? This will be retropharyngeal abscess. No other thing can produce this. Same question मैंने आपको बताया था. Somebody is saying, I saw your video in the last moment. Thank you. Great. So if you're getting it right, nothing makes me more happier. Because these all questions we have discussed, this is straight from the marathon. हमने straight forward यही X-ray discuss किया था. And we discussed about the whole flow chart about retropharyngeal abscess. कैसे होती है? And you see, there is a classical prevertebral shadow widening, same given today in your paper as well. ठीक है? तो I hope this is your first definite score. अभी तक आपके सारे scoring सही होंगे. And ENT would have been a piece of cake today if you have seen those predictors and marathons. चलिए अब आते हैं into the next. 6-year-old child underwent adenoidectomy for adenoid hypertrophy and post-surgery the child complained of hypernasal voice. ये बड़ा interesting question है. And occasional regurgitation of fluids from the nose. What is the likely cause for it? अब ये मैंने TND में आपको question कराया है. I told you adenoidectomy में सिर्फ एक ही चीज में adenoidectomy नहीं करते हैं. The only contraindication which is very prominent for not doing an adenoidectomy is a cleft palate. And cleft palate, why? Because जो adenoid होता है, this acts as a bridge over your cleft palate. जब hole होता है, it bridges this cleft palate. So the symptoms are not there of cleft, which should happen in a baby if he has adenoids. Now, what happens is if you remove the adenoid in a cleft child, what will happen? That opening will again, it will become more bigger. अब अगर वो opening खुल गई palate की, so all the food will come out of the nose, all the air will leak through the nose, which is called as rhinolalia aperta, also called as hypernasal voice. So isme, the answer would become that if you remove an adenoid over a contraindicated surgery, which is in cleft palate, the child's symptom will worsen, such as regurgitation of food and such as hypernasality of voice. So you should never do an adenoidectomy in a cleft child. Cleft palate unmasked after surgery is the most important answer over here. इसी में हम adenoidectomy नहीं करते हैं. In all the other cases, we do adenoidectomy and we don't have any other problem. Okay? So this is something which is absolutely contraindicated, and this is one of a TND question. But yes, this was one of the complicated questions that came in ENT. But I hope you got all of this right. ठीक है? चलिए, अब आगे आते हैं. Now we come to, again, see, straightforward, buzz question. जहां मिला diabetic man, black colored crust in the nasal cavity. What did I tell you? Uncontrolled diabetes, high glucose levels, having a black crust inside the nose with foul-smelling nasal discharge, nothing becomes other than mucormycosis. And mucormycosis में हम लोगों ने हमेशा क्या पढ़ा है? That always do a surgical debridement followed by amphotericin B. Straightforward. सीधा, you have to give a surgical debridement followed by amphotericin B. आपको सारे necrotic एशार निकालने होंगे so that you can send the drug to that place. So the answer will become straightforward A. Again, a straightforward marathon question. I told you, any patient who is diabetic coming with a black necrotic एशार and that patient has got foul-smelling discharge, that answer would be no doubt mucormycosis, nothing else. Right? और सबसे पहले उसमें क्या करते हैं? Surgical debridement followed by amphotericin B. And usually we give liposomal amphotericin B, and that would have been the best answer. ठीक है? चलो. Okay, so I think the options, the question that are given for today's recall from the student side is very, very appropriate. और मुझे ये लग रहा है that is, you know, that great, right? Management after you give liposomal amphotericin B, तब हम oral पे shift करते हैं, downgrade management करते हैं with posaconazole and ivasuconazole. ठीक है? That is downgrading of management, not the first drug of choice. चलिए, patient has to undergo a pre-operative assessment of vocal cord mobility before thyroid surgery. हर thyroid surgery के पहले हम लोग एक laryngoscopy करते हैं to see the vocal cord movements. Now, you are inserting an endoscope to visualize it. Where should you place the tip of the endoscope for best visualization of the cord? मैंने आपको हजारों बार axial section बना के दिखाया है larynx का, और मैंने आपको हमेशा ये बताया कि जब भी आप axial section काटते हैं, you have to go beyond the epiglottis in order to see the vocal cords. Epiglottis के beyond ही आपको vocal cords दिखेंगे. When you go beyond the epiglottis, you will be able to see the vocal cords. That's what we have discussed every time, and straightforward. अगर आपने थोड़ा सा भी इसमें एक logic लगाया, तो axial section of larynx में कुछ भी अंदर दिखेगा, वो epiglottis को cross करके दिखेगा. Right? Okay? So this was one of the questions that I got from The students, that is why I have placed it, and I hope this was there. Right? Somebody is saying B, somebody is saying it's not there, but I hope it was there. अगर ये है तो इसका आंसर है below the surface of the epiglottis. ठीक है? चलिए, अब आगे आते हैं. Now, ये आई एक और इमेज, ये स्ट्रेट फॉरवर्ड इमेज, अगेन मैराथन की एक स्ट्रेट फॉरवर्ड इमेज है. तभी मैंने कहा कि अगर आपने 3-4 चीजें लास्ट में करी हैं तो आपका ENT इस बार आराम से निकल जाएगा. This is about a 12-year-old child presented to the OPD with fever, pain and swelling over the mastoid with forward displacement of the pinna. So I told you this red hot appearance of the mastoid is called as ironed out appearance. And ironed out appearance की वजह से क्या होता है? This particular pinna bends forward and downwards. That's called as a forward displacement of pinna. So this happens in nothing else except for acute mastoiditis. Answer is straight and simple. Basal abscess sternocleidomastoid में होती है. Citylis digastric triangle में होती है. Lateral sinus thrombosis happens in the sigmoid sinus. So you don't have anything. अगर मैं आपको ये दिखाऊं, यही डायग्राम मैंने आपको मैराथन में स्ट्रेट पढ़ाया है. This is the same image that got. So almost 4 or 5 images came straight away. जो हमारी लास्ट की सिर्फ 4 या 5 घंटे की मैराथन हुई है out of full. So this becomes acute mastoiditis and the same question pops up again. That's why I say prediction is very, very important, especially in such papers like foreign medical graduation. क्योंकि इसमें बहुत चीजें prediction पे आ जाती हैं. चलिए आगे बढ़ते हैं. So मुझे लग रहा है कि आप लोगों ने ENT पूरी सही करी है. And I would be very happy if you get 14 on 14 in this particular question. चलिए. Okay. External laryngeal nerve वाला क्वेश्चन हमने कर लिया. ELN पे भी क्वेश्चन था, मैंने ऑलरेडी बता दिया वो. That was the second question. अब ये क्वेश्चन के बारे में मुझे डिस्कस करना है. 55-year-old male presented to the OPD with, आपको एक आया था epistaxis with unilateral nasal obstruction and you were given this kind of an image that was there. नाक में कोई मास था which had epistaxis and the patient has unilateral nasal obstruction. Now, if in that question you had mentioned painless cervical lymphadenopathy tha, then the answer would become nasopharyngeal carcinoma. If this particular option of painless cervical lymphadenopathy was not there, then the answer would become inverted papilloma. तो मैं आपसे पूछ रहा हूं इस पर्टिकुलर क्वेश्चन में was there painless cervical lymphadenopathy, epistaxis with unilateral nasal obstruction और इस टाइप का mass in the cavity? क्या यही क्वेश्चन था? Because what I've got a mixed opinion about this question. That's why I want to confirm it. So do you, because I've got this question very, very clearly. Right. Okay. So was the question about unilateral nasal obstruction with painless cervical lymphadenopathy and this patient had epistaxis? Yes. So this is a correct answer. The answer will become nasopharyngeal carcinoma without a doubt. I told you 75% of cases of nasopharyngeal carcinoma present as level 2 and level 5 cervical lymphadenopathy. And they get a unilateral nasal obstruction. And at that same time, they have got blood-stained nasal discharge. So without a doubt, this will become nasopharyngeal carcinoma. I've told you the whole spread of nasopharyngeal carcinoma. It produces epistaxis with blood-stained postnasal drip. And at the same time, they go into parapharyngeal nodes, which make almost 75% of the cases of nasopharyngeal carcinoma to have painless cervical lymphadenopathy. So the answer here will not be inverted papilloma. Many of the patients have been confused, right? Ringer's ke badle mein, they have, so if there is painless cervical lymphadenopathy, answer is NPC without a doubt. Okay, fine. इमेज भी था, ये भी प्रेडिक्टर से डायरेक्ट था. वेरी नाइस. सो यस, प्रेडिक्टर से बहुत सारे क्वेश्चंस हमारे ENT में इस बार आए हैं. अगेन कमिंग टू वन ऑफ द TND क्वेश्चंस. ये स्ट्रेट मैंने TND में आपको कराया है. 35-year-old male presented to the OPD with unilateral nasal obstruction. Now see the buzzword, peanut-like, paste-like discharge. I told you, जहां पे भी peanut-like है या फिर axial grease है, axial grease and peanut butter appearance is only seen in one disease, that is AFRS, allergic fungal rhinosinusitis. ठीक है. अब उसमें अगर आप इस टाइप का अगर एक कोई CT स्कैन दिया होगा ना, you see something gray and something white inside it. I always tell you that AFRS में you see gray and white. And what is that gray and white? The fungal mucin appears to be whitish, and this grayish is the chronic sinusitis fluid. So this is called as a double density sign. Double density sign together with anything which mentions peanut butter, peanut paste. The answer is allergic fungal rhinosinusitis. या फिर AFRS. Right? So here also the answer would straightforward become allergic fungal sinusitis. अब उन्होंने दूसरे ऑप्शन में क्या दिया था? Acute sinusitis, which nothing has, which has only got air fluid levels. Chronic sinusitis, you don't have a double density. You don't have juvenile angiofibroma with this kind of a picture. Right? So this is called as the AFRS का classical picture called as double density sign, which is seen in cases of AFRS. ठीक है? अब ये देखो, ये मैंने आपको TND में बताया भी है. And I had mentioned these kind of two things, which is peanut butter and axial grease. And I had shown you the same kind of a CT where the fungus grows inside within the gray, and that produces a gray and white appearance called as double density sign. तो इसीलिए इसमें बहुत लोगों ने गलती करी है, राइटिंग इट अबाउट एज क्रॉनिक साइनोसाइटिस और राइटिंग इट एज जुवेनाइल एंजियोफाइब्रोमा, बट एट द सेम टाइम इसका आंसर AFRS है विदाउट अ डाउट। जब भी कुछ दिखा आपको ग्रे एंड व्हाइट। ओके फाइन। सो दो फंगल साइनोसाइटिस के हिट क्वेश्चन से, वन वाज सेपरेट ऑन AFRS एंड वन वाज ऑन म्यूकरमाइकोसिस। दैट इज व्हाई फंगल साइनोसाइटिस बहुत इंपॉर्टेंट है, स्पेशली इन द पोस्ट कोविड एरा। अब आया एक और क्वेश्चन, इसके बारे में हमने बहुत बड़ी टेबल पढ़ी थी, वी हैड अ ह्यूज टेबल दैट वाज गिवन ओवर इन दिस क्वेश्चन व्हेन वी वर डूइंग आवर मैराथन्स, एंड दैट वाज अबाउट द ड्रेनेज ऑफ साइनसेस। नाउ what is the following structure marked shown in the sagittal section where sinus drainage occurs? Now see, this is your sphenoid sinus. Just in front of the sphenoid sinus, this area, this is your sphenoethmoidal recess. If they have marked this area, then this is your sphenoethmoidal recess. If they have marked below the superior turbinate, this is your superior meatus. If they have marked below the middle turbinate, this is your middle meatus. If they have marked below the inferior turbinate, this is your inferior meatus. But what I got from the students was that they had marked just in front of the sphenoid sinus, and this is the drainage where sphenoid sinus drains. So this is the area which is given the name as sphenoethmoidal recess. ठीक है, फाइन। हो सकता है इधर उधर के ऑप्शंस थोड़े ऊपर नीचे हो, राइट, बट what I got was the answer should be the important one, that sphenoethmoidal recess है if this particular point is given right in front of sphenoid, that is sphenoethmoidal recess, right? So the answer would become sphenoethmoidal recess. Again, this is where I've told you in your TND this time that this is your sphenoethmoidal recess, this is your sphenoid sinus, and if they have marked below your superior turbinate, that's your superior meatus, which is applied, which is basically given by posterior ethmoidal sinuses, right? Okay, no recess was given, then they had marked over the superior meatus. Okay, if no recess was given, then they might have marked over something else. Posterior और medial दिया था, option नहीं था। Posterior medial मतलब का क्या? In option only sinuses were given. अगर sinus दिए हैं and if they had marked superior meatus, then answer would have been posterior ethmoidal air sinuses. अगर उनका marks sphenoethmoidal recess में था, then the answer would have been sphenoid sinus. So either they would have asked the place where the sinuses are draining, और या फिर sinus का नाम की कौन सा इसमें drain करता है. But the answer would be the same. अगर यहाँ mark है sphenoid drains into this, superior meatus में posterior ethmoidal sinuses drain. ठीक है, fine, चलो. So this becomes your answer. Whatever has been asked, that becomes your answer. Okay, fine. चलिए. Now let me come to the next one. 45-year-old smoker male presented with features of hoarseness of voice since 2 months. On examination, ulcerative lesion was seen over the right vocal cord and the right vocal cord was fixed. What is the likely treatment strategy for this patient? Now I got a question from vocal cord carcinoma, right? Based on the staging, they had asked the management, right? और उसमें mention किया गया कि एक cord fix हो चुका है. Now I told you, the moment in your vocal cord carcinoma, they use the word fixed, automatically the staging becomes stage 3, that is T3. And T3 stage में, the primary choice of treatment is either a concurrent chemoradiation or you will give an open partial laryngectomy. But nowadays, open partial laryngectomy is not the first choice option. Total laryngectomy is only done when that gross disease has come out of the larynx. But here they have not mentioned anything about gross invasion of larynx, involvement of esophagus, involvement of trachea, involvement of strap muscles, involvement of this kind of the skin, right? So whatever they have given, 12-year-old child नहीं हो सकता, you cannot have a glottic malignancy in a 12-year-old child, right? So 12 साल के बच्चे में they might have given a papilloma question, वो आएगा, right? But answer was total thyroidectomy नहीं हो सकता, they must have given something about laryngectomy, right? So what I have gone over through the questions, I received an option कि right vocal cord fixation mentioned था, and अगर right vocal cord fixation mentioned है, the best option would become concurrent chemoradiation. अगर उन्होंने ये मेंशन किया है that malignancy is involving the thyroid cartilage, it is eroding the skin, it is coming into the strap muscles, it is coming into the esophagus, coming into the trachea, coming into the thyroid gland, then वो आंसर हो जाएगा T4A, जिसमें करेंगे total laryngectomy. So the answer for a stage 3 tumor would still become concurrent chemoradiation. ठीक है, fine. So we are discussing, ठीक है, आंसर पता होना is not the aim. Recalls में obviously up and down कुछ ना कुछ चीजें होती हैं, but the whole idea is that whenever you're answering, you should know at least these options, why they are correct and why they are not correct. That's the whole problem about, understanding things and then doing a recall. So if they have mentioned T3, the answer will become CCRT or concurrent chemoradiation. If the answer would have been T4A, that is gross invasion out of the larynx, the answer would have been a total laryngectomy followed by radiotherapy. That is how it is. Okay, fine. Chalo. Thyroid cartilage ka invasion. If they had mentioned thyroid cartilage was invaded, then the answer would become total laryngectomy followed by radiotherapy. This one, laryngectomy with radiotherapy. If it was T4A, that is grossly invaded. Bas, invasion likha tha. So answer is that becomes T4A and the answer would be laryngectomy followed by radiotherapy. Right? Yahi hum logon ne kara hai. T4A, the same thing I have told you, that if there is stage 3, we do an organ preservation protocol. That is, we always go for concurrent chemoradiation. But the moment it becomes T4A, we go for a total laryngectomy followed by radiotherapy. ठीक है? Fine? Invasion likha tha, that's what I've told you. Invasion likha tha, so that means it is a T4A tumor, and the answer would become total laryngectomy followed by radiotherapy. That's the answer. ठीक है? Fine? चलो, आगे बढ़े. Now we go on to the number 12. That is 27-year-old male presented to the ENT OPD for routine examination. He had no history of hearing loss. कोई hearing loss की history नहीं है. On examination आपको एक retraction pocket दिखती है in the tympanic membrane, but उसमें keratin debris नहीं दिखती. The TM is mobile on Valsalva maneuver. What is the likely management in this case? Now, I told you this over in Whitmack's theory. When I was teaching you Whitmack's theory of cholesteatoma ki Whitmack's theory, I mentioned about the retraction pocket theory. And inside the retraction pocket, I told you that is a primary acquired cholesteatoma ki site where it starts to build up. If they have mentioned that this is just a retraction and the keratin has not accumulated, that means this is not a case of cholesteatoma. So in such cases, what you will do is just wait and watch. Nothing else to do. If this retraction pocket contains keratin debris, it has got ossicular erosion, it has got some kind of, a foul smelling discharge which is coming out, then exactly what will happen is that in that particular case, you will want to do a kind of a tympanoplasty followed by a mastoid exploration because it is a cholesteatoma. So I told you that the Whitmack theory mein jahan pe we always get a retraction pocket. If there is a retraction pocket with no keratin debris, you have to just observe the patient and send him off. That's it. So you just have to do one thing, that is wait and watch or do a conservative management if no keratin is present. That's what is the catch point. And the patient's hearing is normal. Okay? So this will go for a conservative approach. That's the answer for this. Chaliye. Now we move on to the next question. Now, you must have been given about a 2-year-old child presented with a weak cry, hoarseness of voice, warty lesions in the larynx. Now, whenever warty lesions come in the larynx, this is a straightforward question that has come, right? So, if there are warty lesions in the larynx in a small child, this is something which is classical laryngeal papilloma. And we call this as JORP, juvenile onset recurrent respiratory papillomatosis, which have got vocal cords pe multiple polypoidal papillomatous growths. Now, that is the reason why they get a weak cry, and that is the reason why they have got hoarseness of voice. Now, what exactly is there? This particular child underwent an excision and a mass was having intralesional pseudofovir, which is the drug of choice. What is the most likely strain to cause malignancy? Now, this I have told you multiple times. अगर आपको कभी भी जॉब का क्वेश्चन आता है तो मैंने आपको दो चीजें बताई हैं that HPV 6 and 11 are the reason for JORP and the strain which become malignant are 16 and 18. HPV papilloma banata hai. If they mention 16 and 18, they are the malignant strains which can cause malignancy in a coexisting papilloma. But the primary reason for a papilloma to happen is HPV strain 6 and 11. So what is the most likely malignancy lesion कौन कर सकता है? It is HPV 16 and 18. Not CMV, not HIV, not EBV. ठीक है. अगर ये पूछते what is the likely strain to cause a papilloma, warty lesion, genital warts, papillomas, they are all related with HPV 6 and 11. ठीक है. Fine. Now, here management is asked. मुझे management बोला गया है that the management already came. But if the management was asked, then obviously I have already written it. Excision of the mass followed by pseudofovir. ठीक है. अगर आपसे ये पूछा गया है कि what is the likely lesion की वजह से, मतलब किसकी वजह से lesion हो रहा है, right? Then obviously it's the same question, right? हाँ, because I have asked this from multiple sources, and that is why I am confirming this. अब ये same जो lesion है, I had given you in your marathon as well. कि कोई भी अगर wart आया, that is nothing but papilloma. Papilloma, HPV, human papilloma virus. Answer ही उसमें HPV है. In simple words. ठीक है? Exact question. I'm happy that we are getting a good recall. चलो. Now I come to question number 14, which is your last question. And I suppose that this question was a video-based question. आपको एक video पूछा गया था. And in that video, a 44-year-old male presented to the ENT OPD with hoarseness of voice since 2 months on examination. The following was shown on the video, where your vocal cords में एक vocal cord completely mobile था और एक vocal cord stationary था. Now, there was not a complete closure of glottis that you observed, right? एक cord बिल्कुल दूर-दूर पास-पास जा रहा था और एक cord जो था बिल्कुल mobile नहीं था. Now, what will be the answer for this is a type 1 thyroplasty. The paralyzed cord is in the cadaveric position. And whenever a cadaveric position में cord होता है, आप उस cord को धक्का देंगे ताकि वो midline में आ जाए, ताकि you develop a good closure of the glottis. So the answer would be a medialization thyroplasty, right? Okay. So that is called as a medialization thyroplasty. Okay. So medialization thyroplasty is a type 1 thyroplasty. Okay. Fine. So what exactly do you understand by this? That it's okay. Even if it is type 4, the options, obviously, I have not made the paper, so there might be 1 or 2 options which are here and there because we cannot get the exact thing. But you should know the exact answer. You should focus on the answer rather than the options, right? Everybody focuses on everything, right? Female patient, male patient, farak nahi padta. Farak ye padta hai, unable to raise a voice, that is a separate question that I have already covered. ठीक है? That is external branch of superior laryngeal nerve. Now comes, this was, अगर एक cord cadaveric position पे है और दूसरा cord mobile है, so obviously the cadaveric position cord is away. You need to push that cord towards the center. Now in order to push that cord towards the center, you need to medialize that cord. So obviously that answer would become type 1 type of thyroplasty. That is medialization thyroplasty, not lateralization. If both the cords would have been in the center, patient would have been in stridor, tab aap karte lateralization thyroplasty, that was type 2. Right? Here it is medialization thyroplasty. Okay? Fine? So that's what you will do. Because the cord was away from it. तब आप उसको सेंटर में लेकर आएंगे. अगर कॉर्ड बिल्कुल सेंटर में था एंड द पेशेंट वाज इन स्ट्राइडर, अगर ऐसे कॉर्ड से दोनों के दोनों, तब आपको एक कॉर्ड दूर लेके जाना है. दैट इज द रीजन व्हिच इज कॉल्ड एज एब्डक्टर पैल्सी, एंड दैट वेयर यू डू टाइप 2 thyroplasty. Okay, fine. It's the same concept question. Okay, fine. So that's what you need to think. अगर दोनों साथ थे, पेशेंट में स्ट्राइडर मेंशन्ड है तो लैटरलाइजेशन करेंगे. अगर पेशेंट में एफोनिया मेंशन्ड है, एस्पिरेशन मेंशन्ड है तो मिडलाइजेशन करेंगे. Okay, fine. Yes, FMG exam is getting tougher, but हम लोग कर रहे हैं. We are working towards that. I told you in mnemonic that in cases of unilateral complete palsy, you will do M. That was medialization of cord. अगर सेंटर में cord आ जाते हैं, then you would have done lateralization of cord. That is only done in bilateral RLN palsy. But I don't think this was a bilateral RLN palsy case. This was a case of unilateral complete where medialization is, and that is what usually is asked. That's what I'm banking on the first option, not on lateralization thyroplasty, because that's not very commonly done. They would ask medialization, not lateralization. So anyways, what we get as a what we get out from this is that whenever and ever you are learning for any exam, see FMG is over, आपकी एक step of life खत्म हो गया. Now forget about things. Today, just go off, shed off your load, sleep off. Don't think what has happened in the exam. You have done a good recall. Recall means that you understood what you have done. It's an impression of your paper. Don't bother about how much marks you will get. Don't start calculating. कि अब जाके we will calculate what is wrong and what is right. The answer to whatever you are doing today is something that you're preparing for NEET PG as well. If you are a good candidate for FMG, your NEET PG is already 80% done. I always say that. So FMG papers are as much bigger than as NEET PG papers. अगर आप इसकी तैयारी में strong है ना, NEET PG will be easier for you in many of the points. If you see the ENT of NEET PG, it's much easier. So relax down, don't bother, don't worry, right? 14 on 14 strike rate. Okay, fine. I'll meet you in person. Umesh, very nice. Chalo, great. So I'm happy that you guys have enjoyed and I wish you all the very best. The crux is, please don't miss out. These are for the new candidates and definitely आप लोगों ने तो पढ़ा ही है that predictor is important. At the same time, marathons are equally important and last minute revision strategies इनसे आपकी जो निकल के आती हैं, that makes your result into a solid result. You know, you don't have to worry at all. So today, have a good night's sleep and see you all very soon on to the other side doing NEET PG recalls very soon. Thank you.
Hello, my dear friend. A very warm welcome to all of you. Let's do the PSM recall. Of course, please do keep suggesting whatever advice you have for the correct question recall. Do keep suggesting it. Okay, so let's move on with the first question. Do keep giving me your correct inputs that this is the question, that is the question. One question was that there was a dog bite and after dog bite, bleeding was there. Now, the dog, some students said was vaccinated, some was saying stray dog. But the point is, we do not care whether it's vaccinated or stray. The management of rabies remains same. And if you see even one drop of blood, it is category 3. And I hope you all know in category 3, along with washing, with rabies vaccine, we also give rabies immunoglobulin. We give human immunoglobulin, and the dose of human immunoglobulin is 20 international unit per kg. So remember, fourth thing comes under category 3, licking on mucosa. You might have seen some video like that, the smooch with dog, and that is licking on mucosa. Then scratch on any body part except face with even 1 drop. That is also category 3. Scratch on face even without blood, that is also category 3. And chamgadad kata, bat bite, is category 3. So what 4 thing are category 3? Scratch on face, scratch with any blood, licking on mucosa, bat bite. All these 4 get the same category 3 treatment. Okay. Now next question is, man is from industrial area with progressive bone pain in lower back and hips for several years. There is also fatigue and difficulty in walking, tenderness over long bone present. Investigation show evidence of proximal tubule dysfunction. So here, this is definitely cadmium toxicity. In cadmium toxicity, this proximal cannulated tubule of kidney do not absorb calcium and phosphates, and they get lost away. Therefore, bone pain start. And along with bone pain, there will be the tubular dysfunction, which is clearly written. Now, the confusion can be between mercury, lead poisoning, and fluorisis. But remember, with mercury, there will be tremors, irritability, gingivitis, and memory loss. And with lead poisoning, there will be Burtonian line, black line on upper gum, encephalopathy, wrist drop. That will be with lead poisoning. Fluorosis, if fluorine is more than 4, it start depositing on skeleton. More than 10, it can lead to fracture also, pathological fracture also. So answer was cadmium. Then the next question is, there is a farmer from hilly region, and he has history of 7-day fever, severe headache, myalgia. He has painless black crusted lesion and with an erythematous ring on his arm. So this painless black crusted lesion with erythematous ring is ISAR formation. This is punch out lesion also, sometimes they write with red color thing in it. So this ISAR formation is typical of scrub typhus. Therefore, answer is scrub typhus. Do remember, both scrub typhus and epidemic typhus, they have the same acute onset fever, chills. And epidemic typhus also have a macular rash around 5th day of illness. But how do you differentiate epidemic and scrub? By ISAR formation. And epidemic typhus can remain inside the patient for sometimes 6 to 12 months. And then it can cause Brill-Ginser disease also, which has been asked multiple times. Remember, ISAR, scrub typhus, it was a repeated question. Of course, in our TNDs also we have taken, and anemia Mukt Bharat is also one topic which we have discussed multiple times, because you cannot dare to miss this topic. Especially for 4 times they have asked what is the dose of adolescent tablet, and this time student we are saying the same adolescent dose tablet they have asked. So remember, in adolescent and in adult female pregnancy, lactation, in all these 4, we give 60 milligram elemental iron, 500 microgram folic acid once a week. Adolescent means 10 to 19 years. So anyone 10 to 19 years is the time when you watch blue film for the first time. So the tablet will also be blue. Remember, if they say the age 5 to 9 years, then for 5 to 9 years, I hope you all know 55 milligram iron and 400 microgram folic acid is given. And this is pink tablet, and this is also given weekly. Okay. So this is also weekly. And then if it is less than 5-year children, then there is 20 milligram iron and 100 microgram folic acid, which is twice a week in 1 ml IFA syrup. So don't forget the dosing and treatment in anemia Mukt Bharat. Now the treatment for multiple drug therapy of leprosy has came. And of course, if there is multibacillary leprosy, definitely we give treatment for 12 months. 6 months is the treatment for paucibacillary. But now in the new guideline, for paucibacillary and for multibacillary both, we are giving 3 medicine, rifampicin, dapsone, clofazimine. So correct answer is A, rifampicin, dapsone, clofazimine for 12 months. For paucibacillary, the same drug, but for 6 months. And the follow-up which we do for multibacillary, the follow-up is 5 years, because it has more than 6 or 6 lesions. And for paucibacillary, the follow-up is only 2 years. Okay. Next question was that this looked like a big question, but they were asking which type of a study is it? Because in the option, if you see, one option is saying it is cohort, then case control, then RCT, and cross-sectional. So basically, you just have to identify which study is this. Now, how to identify which study? Very simple. If there is two group, then ecological cross-sectional cannot be the answer. Answer will be either cohort, case control, or RCT. And here they have given two group. What are the two group? First group is lung cancer patient. Second group, so because he has taken 200 patients from lung cancer ward and 200 without lung cancer. So there is two group, lung cancer and no lung cancer. Two group means cross-sectional ecological gone. Now, in this two group, one group is lung cancer. Lung cancer means they are disease. And those who are disease, they are the case. And without lung cancer are those who are control. Control means who don't have the disease, don't have the lung cancer. So you have case and control taken. Now they will take the past history of exposure and they will calculate odds ratio. So this type of question is not tough at all. If it start with disease, non-disease, case control, if it start with risk factor present, absent, it's a cohort. So here they are disease, non-disease. So answer is case control. This is a case control study. Now, there was a question on calculation of crude birth rate. They have given that there is 100 live birth, 200 death, and 20K mid-year population. So if they are asking crude birth rate, this data of death is useless. Live birth is 100, and I hope you know this formula. Simple thing, crude birth rate means for per 1,000 people, how many live birth occur. So here live birth we write above, mid-year population which we measure on 1st of July, this mid-year population was given 20,000. And you have to multiply with 1,000. So you can do this calculation even under exam pressure. This 30 you will cancel, and here is 20 in the denominator, 100 here. So 100 by 20, 100 by 20 means 5. So the crude birth rate came 5. And if they ask to calculate crude death rate, in crude death rate here the total death is 200, population is 20,000 into 1,000. If you will solve it, this 3030 cancel, 20 will cancel 200, it will come 10. So crude death rate will be 10, but they have not asked it. They have asked the crude birth rate, which will be 5. Next question is the infant HIV treatment guidelines. Some question was there. If you can tell me what are the options, we will be more helpful. But in the HIV treatment guideline, first thing we look is whether the child is breastfeed or not. Because if the child is breastfeed, then there is higher chance of getting the HIV infection from the mother. If the child is breastfeed, then higher chance, so we give 12-week nevirapine, because now there is higher chance. And if not breastfeed, then we give only 6-week nevirapine, okay? And after giving this 12 or 6-week nevirapine, we stop nevirapine because nevirapine is hepatotoxic. And after this 6 or 12 week, after 6 or 12, we do give, of course, two drugs. One is lamivudine, other is zidovudine. So this lamivudine and zidovudine is added, and we continue these drugs till 1 year. Till 1 year, we give this. After 1 year, we go to dolutegravir, then lamivudine and abacavir. In children, we give LAD, lamivudine, abacavir, dolutegravir. And in adult, we give LTD, because if you develop HIV, you are a person of limited edition. So in adult, what we give in adult? Lamivudine, tenofovir, dolutegravir. Children, this tenofovir is replaced by abacavir, so it becomes LAD in children. And this is for infant, okay? Now, question on sperm count 2021 guideline came. It's not from PSM core part, but if asked, this is the lower reference, new lower reference volume, which you have to remember. I have arranged it. It can help you remember. Minimum volume should be, everything is minimum. Volume 1.4. Then this 4% is the normal morphology. Then in the normal morphology 4%, if you multiply 4 again, it is 4 into 4, 16 million is the sperm concentration per ml. Then progressive motility is 30%. Total motility is 42. We have to add 12, 30, 42. And vitality is 54. So if you see again here, 30 plus 12, 42. And 42 plus 12 is 54. So 30, 42, 54, you can remember together. How? Progressive mortality, PM, total mortality and vitality. Progressive mortality 30, then add 12, 42 is total mortality, then add 12, 54% is the vitality. So this lower part should be remembered together, 30, 42, 54. And upper 3, volume 1.4, normal morphology 4, and sperm count 4 into 4, 16 million per ml should be there. So this is sperm count lower thing. Now, for the purification of well water, so there was a question, but the accurate recall was not being obtained by me. So I have made this question that if they have asked this question, that which instrument measure the bleaching powder which is needed to kill all bacteria, then of course that is Horrocks apparatus, because Horrocks apparatus measure the chlorine demand. It tell how much bleaching powder or how much chlorine water is demanding to kill all bacteria. So it is telling how much bleaching powder we will put, which will kill all the bacteria. So that will be estimated by Horrocks apparatus. This was a new question that on 65-year-old pension scheme, there was some question. The complete question was something which I have not got. But on 65-year-old pension, it can be Atal pension, PM Vaya Vandana, Ayushman Vaya Vandana, 3 things from which they will ask. Of course, there was Indra old age pension scheme and all also, but they are old program. So in the new, if these three are there, let's know about these 3. First is, what is Ayushman Vaya Vandana? I hope you know, in Ayushman Bharat PMJ program, we give 5 lakh for economically weaker section, 5 lakh insurance for economically weaker section. In that same PMJ program, government had said that if your age is more than 70 years, you will also get 5 lakh health insurance, just like PMJ. So this is Ayushman Vaya Vandana, 5 lakh. Then there is PM Vaya Vandana. Vaya word means old age. So PM Vaya Vandana is LIC pension scheme for age more than 60 years. So in PM Vaya Vandana, they deposit some premium first and then they get the pension after 60 years of age. That is PM Vaya Vandana. So PM Vaya Vandana is normal thing, not Ayushman Vaya Vandana is 5 lakh insurance. But what is Atal Pension Yojana? Atal Pension Yojana is if you are a worker in the non-organized sector. Non-organized sector is 92% of India is non-organized in farmer, laborer, shopkeeper. They all are non-organized. Remaining 8% they get ESI Act and Factory Act. So for those 8% who are in ESI Act, this Atal Pension Yojana do not work. In Atal Pension Yojana, you have to be in an organized sector. Your age must be 18 to 40 years. You put some amount from your salary each month, and then after 60 years, you will minimum get 1,000 to 5,000 rupees per month after 60 years. So Atal Pension Yojana is from the labor, we will cut the money, and after 60 years, we will give them to that. So these are the 3 pension. Question was not clear. We will come with better recall after getting the clear question. Now there was a question on Bhore committee, and I'm very sure if they have put a question on Bhore committee, they have asked you that which committee, which term was given by Bhore committee. Bhore committee gave social physician. He said that we don't need MBBS doctors who are trained in city and just live and die in city. We need those doctors who go to the society, go to the village, eat with villager plate, participate in village meeting, and they are social physician. So social physician, they coined the who coined the term? Bhore committee coined the term, and under this there was 3-month rural posting in MBBS which was started. Due to this Bhore committee, 3-month rural posting in MBBS was started. Okay. Then this Bhore committee said we need 1 PHC at 40,000 population. Bhore committee said that we need to integrate preventive and diagnostic and curative, all services should be integrated. And there should be universal health care. That means whether you are rich or poor, government should support your health. And there should be 3-tier health system for proper referral system. So these points were under Bhore committee. If they ask about social physician, it was definitely Bhore committee recommendation. Chalo. Next question is that doctor during surgery left gauze cotton inside the vagina and the patient died. So this patient death, it doesn't matter. Patient died or patient survived. Answer is it is a sentinel event. Sentinel event is anything like wrong site surgery, wrong blood transfusion, left gauze. Some sentinel means in a way you are neglecting the patient care. That is sentinel. Then adverse and side event, what are that? Adverse event means suppose patient came to hospital for some surgery and developed some infection in the hospital. That is adverse event. Side effect is like side event, is like side effect of medicine. Like some drug is causing nausea, pantoprazole and all, they can cause gynecomastia. So these can be the side effects. Okay. Sure. Next question is, there was a question on proportional mortality rate. There was a numerical on proportional mortality rate, and I didn't get the exact data. So do remember, if they ask question on case fatality rate or proportional mortality rate, in both of them, the numerator remains same, number of death due to specific disease. Only thing is the denominator will change. In proportional mortality rate, denominator is total death. In case fatality rate, denominator is total case. Let me explain this. For example, when I say rabies, for rabies, case fatality rate is 100%. 100% means if there is 100 case of rabies, out of those 100, all 100 will die. So how many died? This is case fatality. So it tells the killing power or virulence. But PMR is telling that how many death out of total is due to this disease. For example, WHO say that 58% of all Indians die due to cardiovascular disease. So if total death is, let's say, 100 in a village, then out of 100 in India, how many will die due to cardiovascular? 58 die due to cardiovascular. So it is telling us that the burden of cardiovascular disease is maximum in India. So PMR tell burden of disease out of total death. Now let's do a numerical on this topic. Suppose they create this question that there is a village of 5,000 population, 100 cases of TB, total death is 20. And TB death is 5. Find proportional mortality rate. If this is the question, what is the formula on proportional mortality rate I have written? Proportional mortality rate, denominator is death, total death, multiplied by 100. And numerator is death due to specific disease. So which disease we are talking about? We are talking about TB here. What is the death due to TB? 5. So death due to TB is 5. What is the total death in the village? Total death is 20. Only this information is useful. 20. So we just have to solve like this. 5 by 20 into 100. And 20 will cut 100 by 5. So it will be 5 into 5, 25. So this is the way to find proportional mortality rate. Now let me revise this part to you. There is 3 formula: case fatality, proportional mortality, specific mortality rate. In all the 3 formula, the good news is numerator is same, death due to specific disease, death due to specific disease, same numerator. So we will put 5 everywhere because 5 was the death due to TB. Now when we multiply, it's multiplied by same 100 and 100, but in specific mortality rate, because denominator is population, we multiply by 1000. So if they ask case fatality rate of our question, what was the case due to TB? Case of TB was 100. So 5 by 100 into 100, case fatality rate will come 5%. Now what was the total death in the village? Death in the village is 20. So it has came 5 into 5, 25%. And if they ask a specific population was 5,000, so a specific will come 1 per 1,000. Okay. Main thing you have to remember is in case fatality rate, denominator is case. In proportional mortality rate, denominator is total death. So if you remember this part, you can do such question well. Now, one question was, which of the following is best indicator for measuring burden of disease? Burden means morbidity. कितने लोगों ने खटिया पकड़ ली या बीमारी के चलते सफर किया? तो burden or morbidity, this is best indicated by DALY. In DALY, we use 2 things. First thing we measure is how many years of life you lost due to early death. Okay. Because Indians are expected to live till 70 years. So if someone die at 62 years, he have lost 8 years of life. But along with that, we also write how many years of life lived with disability. Okay. For example, in my father's story, he had 10 years of hemiparesis. And my father died at 62 years. So if someone is dying at 62 years, he is dying 8 years early than expected. So if you add 8 plus 18, total 18 years was the DALY. So DALY has 2 things: how many years you lost, how many years you suffered. That's why DALY is the best indicator. Okay. Now, one question was on finding PPV. They had given sensitivity, specificity, and prevalence of disease. So the formula of PPV we all know. It is true positive by true positive plus false positive into 100. So to get the answer, we have to know true positive and false positive both. Now, to do such question, the first step is, it is not given, but we have to take population as 1000. and it is given that prevalence of disease is 10%. 10% have the disease. So if 10% have disease, it means 100 are disease, and out of 1000, if 100 are disease, it means 900 are without disease. Okay, so with prevalence, you will get how many are disease, how many are non-disease. Now, in the formula of sensitivity, it is true positive by disease. How many are disease? 100. How many disease is 100? So 100 will get cancelled, and true positive will come how much? 80%. True positive will become 80 because 100 will cancel out. True positive will become 80%. Simple. Now, true negative. How much are non-disease? 900. And specificity given in this question was how much? Specificity was 90%. So if you write 90% here, 90 is equal to x by 9, because this 20 will cancel this 20. So x by 9 is this. So what is the x? Is true negative. True negative came out to be 9 into 90, 810. देखो, main thing is whenever we talk about non-disease, जो लोग बीमार नहीं होते हैं, in non-disease we do two type of people. One who we correctly remove, true negative, and one who we wrongly include, false positive. देखो, जो नहीं बीमार हैं उसमें से हम कुछ लोगों को तो निकाल देते हैं, वो ट्रू नेगेटिव है, और कुछ लोगों को गलती से पॉजिटिव बोल देते हैं, जो एक्चुअली में नहीं बीमार थे. तो ये दोनों को मिलाते हैं, ट्रू नेगेटिव फॉल्स पॉजिटिव, तो नॉन डिजीज बनता है. तो यहाँ ट्रू नेगेटिव 810 है, ट्रू नेगेटिव इज 110, नॉन डिजीज इज 900. So how much will be the x? How much will be the false positive? The false positive will all be 90. So we got here three things here. What are the information we got? We got true positive is 80, false positive is 90. So if you put it in the formula, true positive was 80 and false positive was 90. So 80 by 80 plus 90 into 100, this will be the PPV. And if you solve it, it will be 80 by 170 into 100. So solving it is not so easy, but still 8 by 17. 8 by 17, 8 by 16 is 50%. So it will be a less than 50%. It will be around 48%, I can say, because 8 will cut 16 by 2 point something. So it will come around 48%. So in this way, you can calculate, but this calculation was really tough. And of course, this time the paper was tough. Next question was that if there is water, suppose in a disaster flood area you are there and people have 20 liter of water vessels, then which is the best method to do chlorination, or which method can be used in such area? We can use chlorine tablet. But when I was working in Chhattisgarh tribal areas during cholera time, no one had 20 liter of utensil. So we converted this tablet into drop, and you put 2 drops in 1 liter and it will kill all the bacteria. So chlorine tablet is better. Allium and then lime. These two things we put in Nalgonda technique for defluoridation. So when we want to remove excess fluorine, for removing excess fluorine, remember we first put allium, then put lime. Okay, Al. Then female earning 20,000, it means she is under ESI, because for being in ESI, your salary should be more than 15,000. Here it is 20,000. Second thing is, she will get how much of leave? So the leave for tubectomy come under enhanced sickness benefit. And in enhanced sickness benefit, she get 14-day leave for tubectomy, 7-day for vasectomy. And how much salary? 400% salary. Of course, you can understand vasectomy is easy because anyway the testicle is hanging down, it's a small surgery. But tubectomy is long time taking, so tubectomy will have 14-day leave. Okay. Now, that's where the question, but one more question was, if there is unvaccinated mother who came for vaccination, then in the antenatal checkup, which vaccine you give? Now we are not giving tetanus, we are giving DT. We give 2 DT at 4-week gap. And this DT, can you give in the first trimester? Answer is yes. If a female came at labor pain, can you give it? Yes, you still give it any time during pregnancy, but at a gap of 4 weeks. But if you have taken 2 DT in 3 years, then you need to give only 1 booster TT. But in last 3 years, if no DT has been given, then you give 2 TT. Are you understanding it? So we give 2 DT at 4-week gap, but if 2 DT taken in last 3 years, then only 1 booster TT we give. Okay. So this is the thing which came from PSM. Of course, my recall is incomplete without your feedback. That's why I am giving my number already. I have given it in the front page. I am giving it again. That's my number. If you will message me about the correct question option and all, definitely I will use that. I will take your name and I will tell it in the next session that these were the question which came. And you can also connect with me at PW Medit Telegram group.
The front page, I am giving it again.
So thank you so much. Over to my next friend who is already there.
The correct question
So thank you
option
so
and
much.
all. Definitely, I will use that. I will take your name and I will tell it in the next session that is the question which came. And you can also connect with me at PW Medit Telegram. The front page.
Yes, good evening, everyone. The dead body is a silent witness who never lies. लाश एक मुंह गवाह है जो कभी झूठ नहीं बोलती. Yes, am I audible, guys? Am I audible? Garvit Batra, Ayushi. I think most of the forensic questions were, quite predictable. Like example, mercury poison, MTP Act, and other questions. Not that difficult. Okay, let's discuss all the questions and the answers and maximum 5 minutes. Chalo. The manner of injury given below. So the question was about a right-handed person, a right-handed victim with the multiple parallel cuts. You can see here the multiple incise wound, a large wound with the parallel superficial cuts. We discussed many times in our classes and also in FMGE predictor classes, it is basically hesitation cuts. So the answer is very simple. It is suicide. So the answer is suicide. In homicide, the classical feature is defense wound. The defense wound can be active defense wound or passive defense wound that is asked in last FMG exam. It is not accidental. Defense wound classically seen in case of homicide. Chalo. The second question, a video-based question, that is hydrostatic test or Regot test. The hydrostatic test shows sinking of lung pieces. Sinking. Whenever word sinking, your answer must be stillbirth. If the explanation given are video showing the floating of the lung pieces, then it is live birth. So better answer here, it is the A is the correct answer. Now look at this. This is one video we discussed many times in our classes. A case of dead-born infant. The lungs, you can see here the fetal lungs. So the fetal lungs are placed in the water. So if they immerse, if they sink, then it is stillbirth, because the specific gravity of stillbirth lung is around 1040. The live birth lung, that is usually 940, that floats. Again, it has true positive and true negative values, false positive values also. So the answer is basically stillbirth. Okay. If decomposition is there, then it can give you some false positive results as well because of the decomposition gases. Okay. Yeah. Fine. Okay. Smooth specialist. Okay, fine. Then the third question, as usual from the MTP Act. Every year there will be one question in FMG exam from MTP Amendment Act 2021. We discussed many times in FMG Predictor series. 21-year-old, anything more than 18, married female. So married, unmarried doesn't matter. With the 10 weeks of gestation came for MTP. MTP can be done with a written informed consent from. The answer is very simple. only mother. So no need of consent from the husband or the parents. But remember, when age is less than 18, you need to inform police as per the section 19 and 21 of POCSO Act. So the answer is A, very simple. Then one more question from impotency, the selective impotency. A man is potent in general, the capable of sexual intercourse with other women, but impotent with respect to a particular woman, usually the wife or girlfriend, with many reasons basically. What it is known as? The answer is code hunk. The frigidity is basically in females. That is impotency in females. We call it as impotency, basically limited to the males. Vaginismus is a cause for frigidity. That syndrome is basically common in case of young adults. So code hunk we discussed many times in sexual offenses. Okay. Then, as usual, EDH very commonly asked. The bleeding artery, middle meningeal artery, biconvex appearance, lemon appearance on CT scan, lucid interval, a period of consciousness between the two periods of unconsciousness. So it is commonly associated with what type of skull fracture? So the answer is linear fracture. Depressed fracture is common with the heavy weapon with a small striking surface, like example hammer. Hinge fracture is a fracture of base of the skull. It is also known as motorcyclist fracture. Ring fracture is a fracture seen around the foramen magnum, commonly seen in fall from height, the fall on feet. So all these questions I got it from the students, and also other questions like Arjumona mexicana, epidemic dropsy, the question was there. You just correct me if I am wrong in the chat box. Then choking, that is occlusion of internal air passages. Himmlish maneuver was the question, related question. Then as usual, mercury poison, the mercury poison discussed by Ashwani sir in the previous lecture. So thallium cadmium asked in the previous exam. This year mercury was asked. So Durandar movie, you know, dimethyl mercury was the poison used. Durandar part 2 basically. Then EDH as usual question. And then delusion of persecution. So most of the forensic questions are basically very, very predictable and from the FMGE predictor series. So the real Durandar, as per my knowledge, is basically this kit. Okay. Thank you all. Wish you all the best. Let's come up with all the authenticated questions with explanation in 1 or 2 weeks. Thank you all.
Start हो गया? All right, hi
No,
guys,
sir,
I'm
you can
Dr.
start.
Siraj Ahmed. Sir, I think I'm audible and visible. We can start.
Yes, sir, you are very much audible. You can start.
Okay, thank you very much. So pharmacology में roughly I was able to get around 24-25 question as expected. Usually इतने question रहते ही हैं and most of the question are something that we have discussed in our usual classes and काफी सारे question जो शुरुआत में मैंने रखे हुए हैं वो जानबूझ के इसलिए because in our rapid revision on YouTube also we discuss those question. But once again I am not telling you that rapid revision is going to be a replenishment of a replacement, not replenishment, a replacement of the main notes. Always remember, because the type of question that was asked, I think each one of you have already witnessed that what kind of question has been asked, and we have already discussed the type of question pattern of examination in the very beginning of the discussion. Let's directly jump on to the question that was asked in the pharmacology. So the first question that we had was a patient about migraine and he was started on sumatriptan. Straightforward question. Migraine ke liye sumatriptan 5:1 B diagonist. But I never focus mainly on what is asked. I focus on what could be the next potential MCQ, which has been also a NEET PG question. So they can give you migraine ke liye sumatriptan was given, and this drug can actually increase the risk of what? So remember 5:1 B diagonist. They have two important things. One is they are going to inhibit the CGRP release, and second thing that you should know, that it is also going to cause vasoconstriction. The 5-HT1B component, B stand for blood vessel, it can cause vasoconstriction, and this vasoconstriction can actually precipitate MI or cardiac condition, right? So they can precipitate MI. So अगर पूछता है कि in a migraine patient a drug was given, MI was precipitated, which drug was possibly there? So remember that will be again 5-HT1B by D agonist. Correct answer for this one was A. Next question, a patient overdoses on aspirin. Again, something that we discussed. Aspirin के लिए we don't have any antidote, so we'll be doing forced alkaline diuresis using soda bicarbonate, or we can also use carbonic anhydrase inhibitor like acetazolamide. Correct answer for this one is this. N-acetylcysteine is a repeatedly asked question that we are mainly going to utilize in the paracetamol poisoning. This is the next potential MCQ 2024 question, that what is paracetamol going to do? So they are going to replenish the glutathione store. They will replenish what? The glutathione store. They are going to replenish the glutathione store. All right. Forced acidic diuresis in basic drug poisoning and forced diuresis in any other condition. We can also utilize loop diuretics, but since the question is asking which of the following drug is preferred, we are going to utilize forced alkaline diuresis using soda bicarbonate. Aspirin poisoning. At any given point, if you guys feel that options were little up and down, please feel free to give me, because I spend a lot of hours talking to the students and discussing what is the actual language of the question, and this is the best version of the question that we could come up with. A patient was given an immunomodulator drug which inhibits activation of interleukin 2. Now, many students said, sir, interleukin 2 inhibitor aata, interleukin 2 inhibitor, but only few students were actually able to recall that there were words of interleukin 2 and calcineurin in the same line of the question, right? In fact, I was just having a call discussion also about the same, that inhibit the interleukin 2 activation by inhibiting calcineurin. So simply they are asking calcineurin inhibitor, that is going to be a drug like your cyclosporine. Daclizumab, daclizumab and basiliximab, remember we have also covered in our recent immunomodulator. पहले ही पेज पे है हमारे, जो हमने इम्यूनोमोडुलेटर डिस्कस किया रैपिड रिवीजन में, उसमें भी है. दे आर गोइंग टू इनहिबिट द इंटरल्यूकिन. सो वंस द इंटरल्यूकिन दैट इज फॉर्म्ड, एक्टिवेटेड इंटरल्यूकिन को इनहिबिट करने के लिए है. एनाकिंड्रा, they are going to be interleukin 1 inhibitor. Please do remember that option may vary a little up and down. Correct answer is going to be cyclosporine. Sirolimus, everolimus, they are going to be mTOR inhibitor. They are going to be mTOR inhibitor. So everything that I have discussed about other options are the next potential MCQ. Rapid revision में ये सारी बातें हमने डिस्कस किया था, और रिकॉल का मेन पर्पस क्या होता है, that you should know what is the correct answer of this, whether the language of the question you read was the same or not, and second thing, what is the next potential future MCQ from the same. Next question is about which of the following the proteasome inhibitors. Again, there was a question of, let's say, multiple myeloma. So some students said, sir, there was a history of multiple myeloma. So again, multiple myeloma का drug of choice, मल्टीपल माइलोमा. अगर आपने मेरी स्टोरी पढ़ी है तो मैंने बताया था ज़ॉम्बी मल्टीपल नंबर्स में आते हैं. ज़ॉम्बीज ऑलवेज कम इन मल्टीपल नंबर, एंड ऑल द ज़ॉम्बी प्रोटियाज़ोम, एंड दे ईट द प्रोटीन, है ना, हेड खाते हैं ज़ॉम्बी आके, प्रोटीन विच इज रिच इन प्रोटीन. तो दे आर गोइंग टू बी बोर्टेज़ोमिब, ज़ॉम्बी वाले ड्रग है ना. अगर आपने कभी भी सुना होगा तो आपको पता ही है. इमाटिनिब, निब्बा निब्बी वाले हैं, है ना, निब्बा निब्बी जो टायरोसिन काइनेज इनहिबिटर है. साइक्लोसिमिन कैल्सिनुरिन इनहिबिटर दैट आई टोल्ड यू ऑलरेडी. दिस इज पैल्बोसाइक्लिब, इट इज वन ऑफ द साइक्लिन डिपेंडेंट काइनेज इनहिबिटर. सो इम्यूनोमॉड्यूलेटर से ये 2 क्वेश्चन थे. आई होप कि एवरीथिंग इज गोइंग वेल. अगर कोई भी क्वेश्चन आपको लगता है तो यू कैन पुट योर कमेंट्स इन द कमेंट सेक्शन ऑफ द चैट दैट इज ऑनगोइंग. तो प्रोटियाज़ोम इनहिबिटर, रिमेंबर ज़ॉम्बी, बोर्टेज़ोमिब. Then there was a question that was discussed, I think, in medicine as well, that there is a patient with the recurrent episode of severe pain. Now remember, the language of the question is very, very important. If it is asking acute gout के लिए immediate क्या देंगे, तो we can utilize NSAIDs, we can utilize steroids. But the question was like this, कि they found, aspiration of the joint fluid, needle shape, negatively birefringent crystal under the polarized microscopy. Which of the following drug is used for the long term management? तो ये last वाली जो line है, what is utilized in the long term management, then in that case scenario the answer will be your allopurinol, that is going to be one of the xanthine oxidase inhibitor. अगर क्वेश्चन रहता what is used for the acute setup, then we could go for indomethacin. In the previous examination they have already asked the question on gout. तो मैं बार बार अपने हर सेशन में बोला है कि gout के बिना इनका पेपर पूरा होता नहीं है, है ना. फास्टेस्ट एक्टिंग वाला वाज अ डिफरेंट क्वेश्चन, वो भी एक क्वेश्चन था ट्यूमर लाइसिस वाला जो इसके बाद आएगा। तो फास्टेस्ट एक्टिंग एक अलग क्वेश्चन था, स्टूडेंट्स है बोले कि ये लॉन्ग टर्म रिलीफ के लिए एक अलग क्वेश्चन था। इंडोमेथासिन फॉर द एक्यूट गाउट वी कैन यूटिलाइज, फॉर द एक्यूट गाउट we can utilize colchicine. The question that was asked on colchicine, they are going to be chemotaxis inhibitors. C for colchicine, C for chemotaxis. Aspirin, it is always and always going to be contraindicated in gout. Chemotaxis inhibitor colchicine, aspirin को तो gout में देते ही नहीं है, right? So again the answer to this question allopurinol. I think fastest acting अंकित बोल रहे हैं, तो there was another question, please correct me if there was another question on a patient, है ना, that is diagnosed with acute lymphoblastic leukemia and started on induction chemotherapy, and few hours later he developed nausea, vomiting, muscle cramps, arrhythmia, serum uric acid level is high. So number 12 था, 12.8 था, 12.2 था, ये वेरी कर सकता है, 11 था, ये वेरी कर सकता है। बच्चे ने बोला कि सर नंबर 10-12 से ऊपर था, राइट, एंड ही इज डायग्नोस्ड विद ट्यूमर लाइसिस सिंड्रोम। तो ये बहुत ही अच्छी बात है कि डायग्नोसिस आपके एग्जाम के पेपर में और कीवर्ड दिया हुआ था। तो इट्स डायग्नोस केस ऑफ ट्यूमर लाइसिस सिंड्रोम, व्हिच ऑफ द फॉलोइंग द ड्रग ऑफ चॉइस दैट रैपिडली रिड्यूस द सीरम यूरिक एसिड लेवल। तो रास ब्यूरिकेज, पी ग्लूटिकेज, अगर पी ग्लूटिकेज था तो उसका जवाब भी यही होगा, दोनों ऑप्शन में नहीं होगा, पी ग्लूटिकेज और रास ब्यूरिकेज। सो दीज आर द वन, they are going to be the recombinant uricase, and this recombinant uricase, they are very fast acting. They are actually going to do what? The next potential MCQ for the examination, that they are going to convert your uric acid to water soluble metabolite that is called allantoin, right? And a similar question was asked in 2024 NEET PG as well. All right, so ras buricase, p gluticase, ras buricase नहीं था, p gluticase था, तो p gluticase ले लेते हैं। अगर ये है तो यही सही है, ठीक है, इसको मैं आपके सामने कट कर दे रहा हूं, कोई ऑफेंस नहीं है दोनों ही सेम है, सेम ग्रुप के ड्रग हैं। फेबिक्सोस्टाट अगेन इज अ ड्रग फ्रॉम सेम ग्रुप, xanthine oxidase inhibitor, प्रोबेनेसिड, है ना, दिस इज यूरिक एजेंट। सो रैपिडली रिडक्शन, दे आर वेरी फास्ट एक्टिंग ड्रग, एंड बिकॉज ऑफ द वेरी फास्ट एक्टिंग ड्रग, दे कैन बी यूटिलाइज इन क्रोनिक गाउट, प्लस दे कैन ऑल्सो बी यूटिलाइज इन ट्यूमर लाइसिस सिंड्रोम, है ना। तो ट्यूमर लाइसिस सिंड्रोम में भी ऑल्सो हम इसको यूटिलाइज कर सकते हैं। तो दो क्वेश्चन थे ये। Then there is a patient of multiple hypopigmented aesthetic patches. So this was actually a case of multibacillary leprosy. Diagnosis was also given multibacillary leprosy. So examiner has been very kind on you this time, especially with the clinical cases. As per WHO, what is the most appropriate? तो word WHO दिया हुआ है साफ साफ, and in fact India में also भी same follow होता है. So what has been asked previously, पहले क्या दिया था, रिफाम्पिसिन के डोज पे ऑल्टरेशन हुआ था, है ना। नाउ रिमेंबर रिफाम्पिसिन वी आर गोइंग टू गिव 600 milligram once per month, dapsone 100 milligram on the daily basis, and clofazimine initially we will be giving 300, then 50 milligram, 300 इसको मंथली बेसिस देंगे, and 50 milligram on the daily basis. So for 12 month we will be giving paucibacillary, and remember the same therapy, this for multibacillary, for the paucibacillary leprosy the same therapy will be given for 6 months. So 3 drugs will be utilized for 6 months in paucibacillary, and remember 3 drugs for 12 months in a case of multibacillary leprosy. So this was again a very easy peasy question, and we have covered it also, that malaria, TB और leprosy के बिना पेपर पूरा नहीं होता usually. Dose of zinc in a 2-year-old child. एज 2 year था, 5 year था, 1 year था, क्या था? If the age of the child is more than 6 months, then therapeutic dose will be 20 milligram on the daily basis for a total duration of 14 days. However, if the dose age is less than 6 months, then we'll be giving 10 milligram on the daily basis, again for a total duration of 14 days. So the number of days is going to be 14 itself. So zinc वाला question आया था कि नहीं? I think each one of you can easily comment here. 2 year अगर दिया था, ठीक है, तो that is well and good. So we'll be giving 20 milligram for 14 days. ये क्वेश्चन आया था, आपने देखा भी होगा. लीजन्स वेर लेस देन 3, तो मैंने आपको बता दिया, अगर लीजन लेस देन 3 थे तो आंसर आप अपने आप से देख लीजिए, लीजन लेस देन 3 तो पॉसिबेसिलिटी की बात हो रही है, एंड पॉसिबेसिलिटी की बात हो रही है, तो उसमें विल बी गिविंग सेम 3 ड्रग्स फॉर 6 मंथ, सेम 3 ड्रग फॉर 6 मंथ, ठीक है। नेक्स्ट, young female who has been receiving anti-epileptic drug therapy. So this was a question student just a while ago, just prior to me entering into the studio, student sent sir ये question था और मुझे इसलिए याद आ गया because आपने बोला था कि एक anti-epileptic drug है जो gender specific side effect करता है, polycystic ovarian syndrome. So because of that we got it corrected, right? So there was a patient on anti-epileptic drug and she developed all the feature of polycystic ovarian syndrome like irregular menses, acne, excessive facial hair, है ना, BMI भी बढ़ा हुआ है, pelvic ultrasonography revealing multiple peripheral ovarian follicle consistent with the PCOS. Again, diagnosis PCOS का दिया हुआ है. Which of the following anti-epileptic drug is most likely responsible? So remember, valproate, sodium valproate, right? The gender specific side effect for this drug, the gender specific side effect for this drug is going to be polycystic ovarian syndrome. अगर आपने मेरा अभी रैपिड रिवीजन जो हमने यूट्यूब पे कराया था रिसेंटली एंड ऑल्सो इन प्रिडिक्टर सीरीज ऑल्सो अगर अटेंड किया था तो उसमें भी मैंने ये बात बोला था कि 3-4 एंटी एपिलेप्टिक के साइड इफेक्ट डेफिनेटली आते हैं. लेमोट्रिजीन एक बोला था, फेनिटोइन बोला था, कार्बामाजिपिन बोला था और वेलप्रिड बोला था. वेलप्रिड का साइड इफेक्ट आ गया, राइट? अगर ऑप्शन में फेनिटोइन भी है दैट डजंट मैटर. फेनिटोइन नहीं, अगर फेनिटोइन ऑप्शन में था तो भी करेक्ट आंसर नहीं होगा. चलिए ऑप्शन में मान लीजिए मैंने कार्बामाजिपिन को हटा के फेनिटोइन कर दिया तो भी आंसर हमारा क्या होगा? आंसर विल बी योर sodium valproate, right? Other than that, it's a hepatotoxic drug, bone marrow suppression, right? Lithium was another question, है ना? Lithium was there. Lithium was another question. वो lithium वाला question मैं दिखा रहा हूँ आपको कैसा था. Now this one 35-year-old patient, please comment immediately कि ये क्वेश्चन था कि नहीं. फियोक्रोमोसाइटोमा बार बार हम लोग बोलते हैं, पहले क्या देंगे? पहले अल्फा देंगे, पहले बीटा देंगे. अब्बा अल्फा बीटा मैं बार बार बताता हूँ. फियोक्रोमोसाइटोमा. Now if you want to treat this, how will you treat? Always do remember you will be giving alpha blocker and this will be followed by beta blocker. It should never be other way around, है ना? It should always be well instructed to the patient. So you are going to administer alpha blocker then beta blocker. Do not administer दोनों को एक साथ नहीं देना है, राइट? या बीटा ब्लॉकर को पहले नहीं देना है, अदरवाइज द बीपी में फर्दर rise and they can lead to hypertensive other emergencies as well. So this was also one of the question. Alpha blocker followed by beta blocker. Again, what is the drug of choice here? So we can utilize phenoxybenzamine. फेनॉक्सीबेंजामीन, सच बिग नेम, फेनॉक्सीबेंजामीन. आज नाम शुरू करो कल तक जाके खत्म होगा, है ना? एंड बीटा ब्लॉकर वी कैन यूटिलाइज द कार्डियो सेलेक्टिव बीटा ब्लॉकर, राइट? वी कैन यूटिलाइज कार्डियो सेलेक्टिव बीटा ब्लॉकर लाइक एटेनोलॉल, मेटोप्रोलॉल, right? So this was another question. A patient on anti-leprosy treatment developed the sin reaction. क्या होता है? Skin reaction. Sin reaction तो नहीं होगा ना? Preferred again. So leprosy, this is one of the PYQ question of NEET PG as well. So if there is any lepra reaction, remember you have to continue the multi-drug therapy and start the patient on oral steroids. So continue the drug and start the patient on steroids. So this question was also there if you remember. Lithium वाला question जो आप बोल रहे हैं वो अलग था. Lithium वाला is a different question. Maybe this question must have been discussed in your dermatology as well. Next question, I think something that has been discussed maybe by micro, maybe by ENT वाले सर ने भी डिस्कस किया होगा, बट फार्मा में भी सिंस लाइपोसोमल एम्फोटेरिसिन बी अगर हम जो ब्लैक फंगस वाली थी, है ना, म्यूकोरमाइकोसिस, तो उसका पूरा हिस्ट्री दिया हुआ है. एंड देन दे हैव गिवन द सीटी इमेज एज वेल, है ना, कॉन्ट्रास्ट सीटी इमेज दिया हुआ है. पूछा व्हाट इज द ड्रग, व्हाट इज द ट्रीटमेंट दैट इज यूटिलाइज? लाइपोसोमल एम्फोटेरिसिन बी इज द ड्रग एंड द डायग्नोसिस हियर इज गोइंग टू बी ऑफ म्यूकोरमाइकोसिस. तो मैं पूरे क्लिनिकल हिस्ट्री को पढ़ नहीं रहा हूं, मैं आपको पूरा जिस्ट बता दे रहा हूं कि भाई ये था और ईएनटी में भी डेफिनेटली ये पढ़ाया गया होगा, है ना, म्यूकोरमाइकोसिस. ठीक है. All right, there was a question also on syphilis according to some student कि he has a history of unprotected sex. The lesion was clean base with indurated margins and is non-tender. There is bilateral and non-tender inguinal lymphadenopathy. All the feature of syphilis was given and they asked what is the drug that is utilized. Image, बच्चे बोले थे गंदा सा इमेज था, तो मुझे जो गंदा सा इमेज लिखा मैंने वो गंदा सा इमेज देख के लगा दिया ताकि एग्जामिनेशन को थोड़ा रेप्लिकेट कर सकें. तो द बेस्ट इज गोइंग टू बी बेंजाथीन पेनिसिलिन जी. पेशेंट को बाइपोलर था 100%. अच्छा, बाइपोलर वाले एक और क्वेश्चन है, एक बार देख लेते हैं, फिर उसके बाद से विल कम अप विद वन सॉल्यूशन, है ना. वो जो पॉलीयूरिया वो था, वो वाला क्वेश्चन भी हम देखते हैं अभी, है ना. बाइपोलर वाला क्वेश्चन भी देखते हैं. दिस वाज अ केस ऑफ सिफिलिस जिसके लिए द प्रिफर्ड ड्रग इज गोइंग टू बी बेंजाथीन पेनिसिलिन जी. A schizophrenia patient was started on a drug and he developed symptoms which of the following is possibly responsible for this? So was there a question something like this, schizophrenia patient और उसको symptom, ये अच्छा ये देखिए लिखा हुआ वीडियो बेस, तो उसमें स्टूडेंट्स बोले थे सर एक वीडियो वाला क्वेश्चन आया था जिसमें दे वर शोइंग डिस्टोनिया और एकैथीसिया या ऑक्यूलोगायरिक क्राइसिस, है ना, जिसमें पेशेंट को ये वाले सिम्टम ऑक्यूलोगायरिक क्राइसिस वाले आ रहे थे, जो मैंने आपको क्लास में भी करके दिखाया होगा, है ना, डिस्टोनिया, एकैथीसिया। तो अगेन उसके लिए जो D2 ब्लॉकर होते हैं, D2 ब्लॉकर एक्स्ट्रा पिरामिडल सिम्टम पे तो रिसेंटली हमने एक रील भी डाला था किसके पाथवे की वजह से होता है, राइट? सो दे आर एक्चुअली एसोसिएटेड विद एक्स्ट्रा पिरामिडल सिम्टम। सो द नेक्स्ट पोटेंशियल MCQ ऑन दिस टॉपिक, they are associated with extrapyramidal symptom, and this is mainly occurring due to nigrostriatal pathway. This is the next potential MCQ, nigrostriatal pathway, नाइग्रोस्टेरल पाथवे। तो ये सारी बातें हम लोग रेगुलरली कई बार अपना ऑलमोस्ट सारे क्लास में डिस्कस करते हैं, और ये तो एक्स्ट्रा पिरामिडल सिम्टम CNS का तो ब्रेड एंड बटर है एक तरह से देखा जाता है, ठीक है। तो टिपिकल एंटीसाइकोटिक्स विल बी द मेनली वन एसोसिएटेड विद द वीडियो बेस्ड क्वेश्चन जो था, उसमें दे विल बी कॉजिंग एक्स्ट्रा पिरामिडल सिम्टम्स। कुछ छूटा तो नहीं? Okay, next question. A patient with a history of bipolar. Now, ये है bipolar वाला question. A patient with bipolar disorder has been receiving lithium carbonate for the past 3 years, and she complains of vomiting, excessive thirst, polyuria. है ना, ये bipolar disorder वाला, bipolar affective disorder, cold tremor. तो basically this was a history of lithium. Laboratory investigation shows lithium concentration on the higher side, तो lithium concentration काफी high side में है, ठीक है। और which of the following is the most appropriate definitive treatment? तो was it question like this? क्या वो क्वेश्चन लिथियम का पूछा था कि कैसे ट्रीट करेंगे, या पूछा था which of the following drug could cause this one, है ना? बिकॉज इसमें अगर लिथियम क्वेश्चन में दिया था, दैट मीन्स तो ये सवाल नहीं पूछेगा, या तो ये देगा कि बाइपोलर डिसऑर्डर का पेशेंट है और उसको दवा देने के बाद ये सिम्टम होना शुरू हो गया, विच ड्रग इज एक्चुअली कॉजिंग। सो इन दैट केस सिनेरियो इट विल बी लिथियम। लेकिन अगर क्वेश्चन में लिथियम दिया हुआ, पूछा कैसे ट्रीट करेंगे, सो रिमेंबर द बेस्ट थेरेपी फॉर दैट विल बी हीमोडायलिसिस। सो प्लीज कंफर्म कि क्या था दोनों में, वॉज इट दिस, या जो आप बोल रहे हैं, या आप में से कई लोग कमेंट में बोल रहे हैं कि यस एस्पिरिन टॉक्सिटी वो मैंने ऑलरेडी करवा दिया, फोर्स्ड अल्कलाइन डाययूरेसिस वो मैंने ऑलरेडी करा दिया, वाज इट दिस, या देयर वाज अ केस ऑफ बाइपोलर अफेक्टिव डिसऑर्डर विथ टॉक्सिसिटी सिम्टम। बिकॉज अभी क्या है, मोस्ट क्वेश्चन की हमें ऑल 4 ऑप्शंस लेकर आए हैं आफ्टर डिस्कसिंग विद द स्टूडेंट्स ओनली। केस ऑफ बाइपोलर अफेक्टिव डिसऑर्डर विद टॉक्सिसिटी सिम्टम, एंड यू हैव टू आइडेंटिफाई द ड्रग। अगर ये क्वेश्चन ऐसे था तो ये भी बता दीजिए, आइडेंटिफाई द ड्रग। तो उस कंडीशन में अगर पॉलीयूरिया वगैरह आ रहा है, अगर उसमें ये ऐसे सेलेक्ट करना था लिथियम, है ना, राइट। लिथियम विल बी कॉजिंग ल्यूकोसाइटोसिस, डायबिटीज इंसिपिडस, ट्रेमर्स, टेराटोजेनिसिटी, है ना, दे कैन आल्सो लीड टू हाइपोथायरॉयडिज्म। तो इन दोनों में से कौन सा वेरिएंट था, आप बस इतना बता दो कि सर वेरिएंट ए था या वेरिएंट बी था, which variant was there, and then we can actually refine it and we can send you the PDF। कौन सा वेरिएंट था, मैं एक बार इधर हो जा रहा हूँ, है ना, बैठ के पढ़ाने का हम लोग को आदत है, इसमें थोड़ा सा अगर ओरिएंटेशन नहीं हो पा रहा, बताइए कौन सा वेरिएंट था, वेरिएंट ए, वेरिएंट बी? लिथियम पीकॉस वाले में था सर। पीकॉस लिथियम का नहीं है ना साइड इफेक्ट, वो कई स्टूडेंट से डिस्कस किया गया था। अगर आप क्वेश्चन मिक्स हो रहा है तो एक बार और एसेस कर लिया जाएगा, अगर आप श्योर हैं तो आई कैन डेफिनेटली रीअसेस दिस क्वेश्चन ऑल ओवर अगेन। लेकिन पीकॉस तो लिथियम का साइड इफेक्ट नहीं है ना, ठीक है। तो अगर लिथियम का ओवरडोज पूछा था देन इट विल बी हीमोडायलिसिस। ए और बी, स्टूडेंट बोल रहे हैं ए, चलिए अगर ए है तो विल प्रोसीड विद द हीमोडायलिसिस हियर। बाकी आपका जो भी कमेंट है प्लीज लेट अस नो। नाउ देयर वाज अ क्वेश्चन समथिंग लाइक दिस, दैट व्हिच ऑफ द फॉलोइंग ग्राफ इज रिप्रेजेंटेटिव ऑफ कॉम्पिटिटिव इनहिबिटर। तो आपको आइडेंटिफाई करना है इनमें कॉम्पिटिटिव इनहिबिटर कौन है। तो एग्जाम से बस एक दिन पहले ही हमने डिस्कस किया था नीट पीजी 2024, और उसमें ये भी आया था, मैंने बताया था कि नीट पीजी क्वेश्चन आए थे, ठीक है। सो इन दैट केस सिनारियो कंपटीशन मैंने बताया था कि वाई एक्सिस पे अगर आप देखेंगे तो अगर यहाँ पे क्रॉस हो रहा है, कंपटीशन हो रहा है, सो दिस विल बी द कंपिटिटिव इनहिबिटर, राइट, कंपिटिटिव इनहिबिटर। नॉन कंपिटिटिव मैं बोलता हूं कि ये देखिए 2 लाइन तो दिख रहे हैं, अगर एक डॉटेड लाइन यहाँ पे आपने लगा दिया तो दिस विल बी एन, सो दिस विल बी नॉन कंपिटिटिव, राइट। दीज आर ऑल लीन वीवर बर्क प्लॉटिंग वाला ग्राफ, और ये 2 लाइन आ रहे हैं, इनको धीरे से आप अगर नीचे से एक इमेजिनरी लाइन से कनेक्ट कर देंगे दिस विल बिकम यू, तो दिस विल बी अनकंपिटिटिव इनहिबिटर। दिस इज नॉट अ लीन वीवर, ये यूजुअली डिफरेंट ग्राफ है, जो हम लोग डोज रेस्पॉन्स कर्व वाला ग्राफ देखते हैं वो है लॉग डीआरसी वाला ग्राफ है. दिस इज ऑल्सो लॉग डीआरसी. दिस इज वन ऑफ द डीआरसी वाला ग्राफ, डोज रेस्पॉन्स कर्व है ना, ग्रेडेड डीआरसी. और इसमें दिस इज गोइंग टू बी अ नॉन कॉम्पिटिटिव. नीचे आ गया ना, नीचे आ गया नॉन कॉम्पिटिटिव. सो अ क्वेश्चन वाज दिस लाइक दिस. सो दिस वाज कॉम्पिटिटिव इनहिबिशन. हीमोडायलिसिस वाज नॉट इन द ऑप्शन. तो आप बता सकते हैं हीमोडायलिसिस वाले में क्या ऑप्शन था. अगर आपको पता चल रहा है कि एक पर्टिकुलर क्वेश्चन है तो उसका स्क्रीनशॉट ले लीजिए एंड प्लीज सेंड अस अ नियर बाय क्वेश्चन. उसके आसपास का कॉन्सेप्ट भी अगर आप हमें सोशल मीडिया पे भेज देते हैं तो विल बी मोर देन हैप्पी टू कंपाइल इट एंड मेक इट सिमिलर साउंडिंग क्वेश्चंस, बिकॉज वो सिर्फ आप ही हो जो एग्जाम देकर आए हो एंड आप ही बता सकते हो कि व्हाट वाज द एक्चुअल क्वेश्चन. कई बार क्या हो रहा है, स्टूडेंट दो क्वेश्चन को एक साथ मर्ज कर दे रहे हैं, जैसे कि गाउट वाले में हुआ था. ठीक है, तो अगर कुछ और था तो प्लीज आप भेज दीजिए, विल डेफिनेटली लुक ओवर इट. ये क्वेश्चन तो डेफिनेटली आई थिंक सब लोग एग्री करेंगे कि पेशेंट विद हिस्ट्री ऑफ वाल्वुलर हार्ट डिजीज स्टार्टेड ऑन वारफरिन, ही शेड्यूल फॉर सम सर्जरी, व्हिच ऑफ द फॉलोइंग द नेक्स्ट स्टेप. तो वारफरिन इज अ वेरी स्ट्रॉन्गर एंटीकोआगुलेंट एंड रिस्क ऑफ ब्लीडिंग विल बी वेरी हाई. तो इन दैट केस सिनेरियो वारफरिन यू हैव टू शिफ्ट स्टॉप वारफरिन एंड शिफ्ट द पेशेंट टू लो molecular weight heparin, specifically someone which is a shorter acting one, which will be stopped at least a day prior to surgery. Remember that you do not stop anticoagulant. You can stop, you do not anticoagulant a day prior to surgery, 5 days prior to surgery, and shift the patient to low molecular weight heparin and stop anticoagulant immediately. और उसके आगे कुछ नहीं बोल रहा है तो अगेन दैट इज नॉट अ करेक्ट वन. एड हेपरिन, एडिशन ऑफ हेपरिन विल फर्दर एड ऑन टू द रिस्क ऑफ ब्लीडिंग. सो इन दैट केस सिनेरियो स्टॉप वारफरिन एंड यू आर सपोज टू शिफ्ट द पेशेंट टू लो molecular weight heparin. A 26-year-old woman presented with the antenatal clinic with burning micturition. A similar question कि patient है, pregnancy में है, UTI वाले symptom आ रहे हैं. पूछा कि which of the following drug is the safest antibiotic. So was there a question? Pregnancy में UTI का history था and safest antibiotic पूछा कि उनमें से कौन सा safest है. So remember ciprofloxacin, ये पहले भी आया था फुटबॉलर में, फुट वाला problem. So they will be associated with tendinitis and arthropathy, tendon rupture, tendinitis, arthropathy, and they will be associated also with the tendon rupture. तो ये तो नहीं देंगे. डॉक्सीसाइक्लिन, दांत वाला प्रॉब्लम, राइट. सो दे कैन बी एसोसिएटेड विद टीथ स्टेनिंग एंड बोन ग्रोथ एबनॉर्मेलिटी. The one that is safe is always going to be your penicillin. Safer one is going to be what? Penicillin, cephalosporin and macrolide. PCM mnemonic हम पढ़ते हैं, macrolides, right? So among them cefixime is one of the third gen cephalosporin, right? Cotrimoxazole is a sulfa drug भी नहीं देंगे. अगर nitrofurantoin था तो वो हो जाएगा. Nitrofurantoin is also preferred in pregnancy, remember. तो nitrofurantoin ऑप्शन में था तो we'll proceed with that. Nitrofurantoin अगर ऑप्शन में था, है ना, और आपके कल्चर में ई कोलाई भी आ रहा है, राइट. सो ई कोलाई के लिए बेस्ट ड्रग माना जाता है एंड दे आर आल्सो सेफर इन द प्रेगनेंसी, राइट. सेफिक्सिम नहीं था ऑप्शन में, मैंने करेक्ट कर दिया. नाइट्रोफुरेंटोइन था तो नाइट्रोफुरेंटोइन करेक्ट आंसर हो जाएगा. आई हैव ऑलरेडी करेक्टेड इट. ठीक है, रिमेंबर दैट. कोट्राइमोक्सोजोल नहीं देंगे. दे आर द सेम ड्रग दैट इज एसोसिएटेड विद येलो बेबी सिंड्रोम. येलो बेबी सिंड्रोम के साथ दे विल बी एसोसिएटेड, येलो बेबी सिंड्रोम. All right, next question. Old patient presenting the severe burning pain followed by grouped fluid filled vesicle and again he was diagnosed with herpes zoster. तो herpes zoster का अगर केस दिया है, मैं ये अच्छा लग रहा है देख के कि एग्जामिनर ने कई जगह पे डायग्नोसिस दे दिया है, आपको गेस करने के लिए नहीं बोला है. डायग्नोसिस दे दिया विच ऑफ द फॉलोइंग द प्रिफर्ड एंटीवायरल. तो हर्पेटिक इन्फेक्शन के लिए वी आर हैविंग एसाइक्लोविर. अगर सीएमवी होता तो गैनसाइक्लोविर. सीएमवी के लिए गैनसाइक्लोविर, है ना. राइबावायरिन इज द अदर नॉन स्पेसिफिक एंटीवायरल ड्रग. ओसेल्टामिविर हम टैमीफ्लू हम लोग बर्ड फ्लू वगैरह में यूज कर सकते हैं. Which of the following preferred drug for narcolepsy? Was there a question like this, right? There was a recurrent UTI, why not doxycycline, and was not history of pregnancy. Recurrent UTI ऑप्शन, अगर रिकरेंट यूटीआई भी है, अगर ऑप्शन में नाइट्रोफ्यूरेंटोइन है तो विल बी प्रेफरिंग मोर विद द नाइट्रोफ्यूरेंटोइन, है ना, मोर विद द नाइट्रोफ्यूरेंटोइन. विच ऑफ द फॉलोइंग इज प्रिफर्ड ड्रग फॉर नार्कोलेप्सी. नार्कोलेप्सी के लिए मोडाफिनिल. आई थिंक ये भी आप सबने देखा होगा, इजी क्वेश्चन था, इजी पीजी क्वेश्चन. ठीक है. Then a patient with hypertension prescribe a drug that follows first order kinetics. So basically the question का stem ये था कि first order kinetics का drug है. Which of the following is true regarding the first order kinetics? So drug that is following first order kinetics, remember that drug following first order kinetics, rate of elimination directly proportional to plasma concentration. So that is correct also. Rate of elimination is directly proportional to plasma concentration. Clearance is going to be constant. And T half life is also going to be constant. ये फर्स्ट ऑर्डर का है. रेट ऑफ एलिमिनेशन डायरेक्टली प्रोपोर्शनल टू प्लाज्मा कंसंट्रेशन. जितना ज्यादा प्लाज्मा कंसंट्रेशन होगा उतना ज्यादा अमाउंट ड्रग निकलेगा. दैट इज गोइंग टू बी द फर्स्ट ऑर्डर काइनेटिक्स. सो आई थिंक फर्स्ट ऑर्डर काइनेटिक्स वाला क्वेश्चन था. फर्स्ट ऑर्डर काइनेटिक्स था भाई. और वो कई स्टूडेंट कंफर्म भी कर रहे हैं कि ये सर प्रेगनेंसी था. तो कई बार क्या होता है कि क्वेश्चन में प्रेगनेंसी से, अब कोई स्टूडेंट बोल रहा है प्रेगनेंसी था, तो बहुत सारे बच्चों ने बोला कि प्रेगनेंसी था. अब कोई स्टूडेंट बोले नहीं प्रेगनेंसी नहीं था. तो प्रेगनेंसी अगर है तो इन दैट केस सिनारियो विल अगेन प्रोसीड विद द सेफर ऑप्शन, नॉट विद द डॉक्सी और सिप्रो. ठीक है, ये क्वेश्चन था भाई फर्स्ट ऑर्डर काइनेटिक्स वाला. ये ऑप्शन के लिए मैंने काफी मगजमारी की. मैंने अपने नोट्स भेजे, क्या ये नोट्स में से आया था, क्या ये नोट्स का ऑप्शन था क्या, राइट? तो ये क्वेश्चन था, है ना. एस्पिरिन क्वेश्चन, हाँ एस्पिरिन क्वेश्चन करा दिया ना ऑलरेडी. पोस्ट अल्कलाइन डायरेसिस वाला करा दिया था एस्पिरिन टॉक्सिसिटी में, जिसमें पेशेंट को हाइपरवेंटिलेशन होगा ना, तो रेस्पिरेटरी अल्कलोसिस एंड मेटाबॉलिक एसिडोसिस होगा. ठीक है, वो मैंने करा दिया एस्पिरिन वाला. A 58-year-old man with history of poorly controlled hypertension presenting with a headache, blurring of vision, confusion, blood pressure is high. Again ये थोड़ा सा मुझे चैलेंजिंग लगा. ये मेरा आई थिंक सेकंड लास्ट क्वेश्चन है. ये मुझे चैलेंजिंग इसलिए लगा बिकॉज लेबेटालॉल वाला जो ऑप्शन था ना, वो सबके सारे स्टूडेंट अलग अलग बता रहे थे, है ना. तो उसमें थोड़ा सा दिक्कत हुआ. फंडस एग्जामिनेशन रिवील पेपिलिडेमा. सो दिस इज एक्चुअली गोइंग टू बी अ केस ऑफ हाइपरटेंसिव इमरजेंसी केस, है ना. And you have to give labetalol. Which of the following is the correct initial regimen for labetalol? तो labetalol वाला क्वेश्चन अगर ऐसा है, so remember labetalol 20 mg IV administered over 2 minutes. Immediately अगर acute management करना है तो 20 mg labetalol will be given over 2 minutes immediately. Oral तो emergency में prefer नहीं करते हैं. Not over 60 minutes और 4 mg वो भी नहीं है. ठीक है, सो द प्रिफर्ड वन इज गोइंग टू बी 20 मिलीग्राम ओवर 2 मिनट्स. 2 and 2 यू हैव टू रिमेंबर. लेबेटालॉल, इसके पहले क्या पूछा था, लेबेटालॉल का मैकेनिज्म ऑफ एक्शन क्या है. सो रिमेंबर लेबेटालॉल, द ड्रग दैट वी हैव is going to be लेबेटालॉल. लेबेटालॉल is a third generation beta blocker. लेबेटालॉल इज अ थर्ड जनरेशन बीटा ब्लॉकर. इसके पहले एक बार क्या पूछा था, कैसे काम करता है, तो मैं बोलता हूँ अल्फा बीटा. सो दे आर गोइंग टू बी अल्फा ब्लॉकर प्लस दे आर गोइंग टू बी बीटा ब्लॉकर, है ना. तो दे आर द ड्रग. कई स्टूडेंट बोले सर लेबेटालॉल पे 2 क्वेश्चन था. ठीक है, 20 मिलीग्राम बट इट वाज रिटन बोलस. हाँ तो वही बात होगा ना, एडमिनिस्टर्ड ओवर 2 मिनट. 2 मिनट में दे रहे हैं ना तो बोलस ही हो गया ना. 2 मिनट में दे रहे हैं ना तो बोलस ही हो गया ना. लेबेटालॉल प्री एक्लेम्शिया पे आया था कि नहीं, ये बहुत सारे बच्चे बोले. तो अब आया था, तो अगर आप इसको फॉर्मुलेट कर सकते हैं तो यू कैन लेट मी नो कि लेबेटालॉल अगर आया था प्री एक्लेम्शिया में तो क्वेश्चन क्या था उसका लैंग्वेज. एंड बायोअवेलेबिलिटी को कोई क्वेश्चन था कि नहीं, ये कई सारे स्टूडेंट बोला सर ऐसा तो कोई क्वेश्चन हमने नहीं देखा. कई स्टूडेंट बोले नहीं आया था. ठीक है, सो रिमेंबर ये क्वेश्चन नहीं था एंड ये भी नहीं था मोस्ट लाइकली. प्रिडिक्टर सीरीज के बारे में आई थिंक सबने बताया कि प्रिडिक्टर में हमने काफी मेहनत किया था आप सभी के लिए. और इन दैट के सिनारियो रिमेंबर प्रिडिक्टर से काफी सारी जो हमने सीरीज यूट्यूब पे कराए हैं, आप एक बार क्विकली जाके देख सकते हैं. इन लास्ट के 60 सेकंड में मैं इमीडिएटली आपको सारे क्वेश्चन को एक बार रिकैप कर रहा हूं, आप देख लेना. 60 सेकंड में सारे क्वेश्चन रिकैप होंगे. सो देयर वाज अ क्वेश्चन आल्सो ऑन लेबेटालॉल वेयर वी आर गोइंग टू गिव 20 मिलीग्राम ओवर 2 minute bolus. Then there was a question on first order kinetics where the rate of elimination directly proportional to plasma concentration. And ये भी सही है rate of elimination first order के लिए. And they are also T half life is also constant for the first order kinetic. बाकी सारे या तो जीरो ऑर्डर कर रहे हैं या किसी ऑर्डर को डिफाइन नहीं कर रहे हैं. नेक्स्ट इज गोइंग टू बी विच ऑफ द फॉलोइंग इन नार्कोलेप्सी. मोडाफिनिल अगर ये क्वेश्चन आया था तो. देन हर्पीज जोस्टर के लिए वी आर गोइंग टू प्रिफर एसाइक्लोविर एज अ ड्रग. नाइट्रोफिरेंटोइन, रिकरेंट यूटीआई हो रहा है प्रेगनेंसी में, सो वी आर गोइंग टू यूटिलाइज नाइट्रोफिरेंटोइन. नेक्स्ट, इफ देर इज अ पेशेंट ऑन वारफरीन एंड यू आर प्लानिंग अ सर्जरी, तो वारफरीन को इमीडिएटली क्या करोगे, वारफरीन को आप स्विच डाउन करोगे लो मोलिकुलर वेट हेपरिन पे। वारफरीन हेपरिन बार बार आता है, क्रॉस कर रहा है वाई एक्सिस पे, तो रिमेंबर दिस गोइंग टू बी कम्पिटिटिव इनहिबिटर ग्राफ। एंड दिस वाज अ क्वेश्चन आल्सो ऑन लिथियम ओवरडोज, हीमोडायलिसिस उसके लिए ट्रीटमेंट है। इस क्वेश्चन में अगर कुछ बच्चे बोल रहे थे कि सर हीमोडायलिसिस ऑप्शन में नहीं था, तो ऑप्शन में क्या था अगर आप बताएंगे तो वी कैन एक्चुअली टॉक। बाकी एक्टिवेटेड चारकोल ये सब हम नहीं यूज करते हैं। तो given the option that we have, hemodialysis अगर option था तो this will be the correct one. Next one is going to be about typical antipsychotic that is causing your extrapyramidal symptom. वीडियो बेस्ड क्वेश्चन था। ये जो डर्टी वाला इमेज था सिफिलिस के लिए, we will be giving benzathine penicillin G. Then liposomal amphotericin B for mucormycosis. That was one question. And in a patient with a lepra reaction, you will continue the multi-drug therapy and you are going to add steroids. Next, there was a question on pheochromocytoma, alpha blocker के बाद बीटा blocker, A, B, अब्बा याद करिएगा। Sodium valproate or gender specific side effect is associated that is called polycystic ovarian syndrome, and zinc का dose 20 milligram for 14 days in any age। अगर एज 6 महीने से ज्यादा है तो 6 महीने से कम है तो 10 मिलीग्राम। देन इन पेशेंट विद द लेप्रोसी ध्यान रखिएगा, अगर 3 लीजन थे दैट इज पॉसिबिलिटी 6 मंथ के लिए 3 ड्रग देंगे, रिफाम्पिसिन, क्लोफाजिमिन, डाप्सोन। अगर मल्टीबैसिलरी है तो 12 मंथ के लिए देंगे, राइट। Then pegloticase is one of the rapid acting drug that will be utilized in tumor lysis syndrome. Allopurinol is a xanthine oxidase inhibitor. They are the long term relief के लिए utilized in the gout patient. Bortezomib, zombie proteasome inhibitor, multiple myeloma में यूज करते हैं, इन हिस्ट्री ऑफ मल्टीपल माइलोमा दिया हुआ था। Calcineurin inhibitor and that is inhibiting the interleukin 2 activation. Correct answer cyclosporin. Other drug is also there tacrolimus, लेकिन इसमें ऑप्शन में cyclosporin था। अगला इसका पोटेंशियल एमसीक्यू मैं आपको बता दे रहा हूँ, इसका साइड इफेक्ट पूछेगा वो ध्यान रखिएगा। इसका साइड इफेक्ट एक आएगा दैट इज गोइंग टू बी गम हाइपरट्रॉफी, इमेज देगा। इसका पोटेंशियल एमसीक्यू अगला है। तो अगर मैं एग्जामिनर होऊंगा तो इस टॉपिक से नया क्वेश्चन बनाना होगा तो मैं ये बनाऊंगा, राइट। दिस इज जस्ट माई व्यू। नेक्स्ट इज फोर्स्ड अल्कलाइन डायरोसिस इन पेशेंट विद एस्पिरिन, और वहां पे देखिए मेटाबॉलिक एसिडोसिस, रेस्पिरेटरी अल्कलोसिस, एस्पिरिन ओवरडोज में ये आउटकम आता ही आता है, ठीक है। देन माइग्रेन का mechanism of action 5-HT1B by D agonist. So this was everything from my side in pharmacology. I hope all of you guys have enjoyed pharmacology and enjoyed the other subject as well. And जैसा कि हमारे सारे टीचर्स ने बताया कि हमारे प्रिडिक्टर बुक से काफ़ी सारे सीरीज जो हमने यूट्यूब पे चला उससे काफ़ी सारे क्वेश्चन आप सभी के लिए आए थे। सो आई होप ऑल ऑफ यू गाइस आर गोइंग टू हैव अ वंडरफुल डिस्कशन विद मैम इन साइकेट्री। मैम, ओवर टू यू। You guys can message any question that you feel like कि ये क्वेश्चन को थोड़ा सा और रिफाइन करना है। You can take a screenshot and send me across. You can easily find me on social media. I'm readily available. Thank you very much to all of you. Ma'am, over to you.
Thank you, sir. Thank you very much. Guys, I know आप लोग बहुत tired हो, but thank you for sticking around. I am going to do a very quick recall of psychiatry. As we always say कि हम details में बाद में ज़रूर चले जाएंगे। आपको obviously आज रात को चैन की नींद आ जाए उतना recall कर लेते हैं, ठीक है। So chat में मिलते हैं। कुछ questions मैं दिखा रही हूँ, मुझे बताना थे कि नहीं थे। Let's start with this one. According to me, all the topics that were primarily covered were, as usual, child psychiatry, जो उनकी फेवरेट है, बेसिक्स जो कि डिल्यूजन हैलुसिनेशन से रिलेटेड टॉपिक्स होते हैं, साइकोफार्माकोलॉजी जैसे सर ने भी पढ़ाई वैसे बहुत इनकी फेवरेट है, एंड साइड इफेक्ट्स ऑफ सर्टेन मेडिकेशन। सो क्या ये क्वेश्चन था गाइस? अ मैन इज ब्रॉट बाय हिज फैमिली बिकॉज ऑफ सस्पिशियस बिहेवियर। ही बिलीव्स ही इज बीइंग सीक्रेटली वॉच्ड थ्रू हिडन कैमरास एंड हैज फिक्स्ड persecutory delusion without any reason. What is the appropriate management? So सबसे पहले diagnosis is most likely schizophrenia. क्या ये question था? First and foremost, अगर question था, so automatically he's psychotic. So the person has psychosis and hence the management is going to be antipsychotic management. Guys, मैं आगे जा रही हूँ. You can always pull me back and tell me कि मैम ये वाला फिर से repeat कर दो. I'm just for the sake of also convenience of you and the other teachers going as fast as I can. It wasn't there? Okay, thank you. Thank you for mentioning it wasn't there. Thanks. A 4-year-old boy does not respond to his name, avoids eye contact, prefers to play alone, has delayed speech with echolalia, repetition behind other person, hand flapping, and is upset when routine changes. Okay? What is the diagnosis? ADHD, childhood schizophrenia, autism spectrum disorder, or intellectual disability. पहले बताइए था कि नहीं था, सबसे बड़ी बात था कि नहीं था, दैट्स द फर्स्ट पार्ट। यस, टीचर वाला क्वेश्चन है मेरे पास दो ऑप्शन है, उसमें मेरे को पता नहीं है कौन सा वाला करेक्ट है। ये क्वेश्चन में नहीं था। A lot of students have given a recall for this. If this question was there, then the correct answer is autism spectrum disorder. ठीक है, अगर था तो ASD आंसर है, नहीं था तो आई कैन अंडरस्टैंड, मेरे को बहुत स्टूडेंट्स ने कंकर किया कि ये था। ठीक है, thanks guys. A man develops an intense fear of having cancer after his uncle dies from it, and he repetitively visits doctors, undergoes investigations. Despite repetitive reassurance that all is well, all his reports are normal, he remains convinced कि मुझे कोई problem है. What is the diagnosis? Somatic symptom disorder, illness anxiety disorder, aka hypochondriasis, कौन सा word use किया था वहाँ पे पता नहीं, delusional disorder, somatic type, और generalized anxiety disorder. ये question था. He said he is okay with studies but problem making with friends. अच्छा, ये वाले में था okay with studies but problem in making friends, तब भी आंसर ASD था। ठीक है, ओके। He is normal, could not understand sarcasm. अच्छा, सब बड़े डिफरेंट वर्जन दे रहे हैं गाइस, बट आंसर ASD था उस वाले का। ठीक है, अच्छा, सो कमिंग बैक टू दिस वन, ये वाला क्वेश्चन था क्या गाइस, बीमारी वाला? Yes, hypochondriasis option was there. That is the correct answer. This is the correct answer. लगना की बीमारी है, even तो बीमारी नहीं है, तब भी लगना की बीमारी है। ये क्वेश्चन था। ठीक है, ये वाला डायरेक्ट श्योरली था। इसका पिछले वाले का आप लोगों ने कोई वर्जन था, ये वाला आप लोगों ने बोला कि नहीं था। नोटेड। ओके, लेट्स गो टू द नेक्स्ट वन गाइस। हाइपोकॉन्ड्रियासिस वाज एन ऑप्शन। ठीक है, क्या ये क्वेश्चन था? मैं दो ऑप्शन दिखाऊंगी, बताना कौन सा वाला था। स्कूल टीचर हैज बीन एक्सपीरियंसिंग persistent guilt that she is not teaching her students well. She's been socially withdrawn and has shown symptoms of depression. What is the most appropriate first line treatment? Word is first line, बहुत important है। Antidepressant, psychotherapy, do nothing और antipsychotic. ऑप्शन शायद ये नहीं होंगे, पर क्या ये क्वेश्चन था या ये क्वेश्चन था? मैं एक और क्वेश्चन दिखा रही हूँ। ठीक है, kindergarten teacher believes that all her students are failing because of her. She also reports hearing voices commenting on her action, voices commenting. What is the best treatment? Psychotherapy, antidepressant, antidepressant plus antipsychotic or mood stabilizer. दोनों में से कौन सा क्वेश्चन था? हाँ, तो पहला था। अगर पहला था सिर्फ गिल्ट थी एंड सिर्फ डिप्रेशन के सिम्टम्स थे, तो फर्स्ट लाइन होगा साइकोथेरेपी। 2 months का हिस्ट्री था। अच्छा, both was an option. ओके गाइस, पहले तो मेरे को बताओ कि क्वेश्चन फॉर्मेट ए ऑप्शन था या क्वेश्चन फॉर्मेट बी ऑप्शन था? अच्छा, अगर ये पहला वाला था जिसमें सिर्फ गिल्ट है, डिप्रेशन के सिम्टम्स है, 1 या 2 महीने से उसको हो रहा है और फर्स्ट लाइन ट्रीटमेंट की बात है, साइकोथेरेपी इज द करेक्ट आंसर। बट अगर ये क्वेश्चन था बी वाला फॉर्मेट जो मैंने बताया है, जिसमें वॉइसेस भी सुनाई दे रही हैं, डिप्रेशन के सिम्टम्स भी हैं, और आप 2 months का सिम्टम कह रहे हो, तो इट इज स्किज़ो अफेक्टिव डिसऑर्डर, एंड देन द करेक्ट आंसर इज एंटी डिप्रेसेंट प्लस एंटी साइकोटिक। Cool, everybody got this. I think ये वाला वर्जन था, पिछला वर्जन नहीं था। Correct? Awesome, awesome. A patient with schizophrenia develops involuntary abnormal movement of the hands after long-term treatment, लंबे treatment. Which class of drugs is most likely? Benzodiazepine, SSRI, typical antipsychotics, most available. बहुत common, बहुत easy, बहुत बारी पढ़ा है मैंने आप लोगों को। ठीक है, वो वाला था गाइस। ये क्वेश्चन था क्या? ये वाला क्वेश्चन था क्या? ये वाला क्वेश्चन था? ठीक है, बी फॉर्मेट था, वोट फ्रीज कर लिया मैंने। ये वाला क्वेश्चन था, ऑसम, ये वाला क्वेश्चन भी था। तो ऑब्वियसली उसको अगर एक्स्ट्रा पिरामिडल रिएक्शन हो रहे हैं तो उसको टिपिकल एंटीसाइकोटिक चल रहे हैं। आई थिंक ये वाला इतना PIQ इतना पढ़ा है मैंने आपको कि आप लोगों ने सबने सही किया। अच्छा, ये वाला था क्या? Young woman with bipolar disorder has been receiving treatment with lithium and haloperidol and now presents with hyperactivity and hyperreflexia. Important. Which of the following is the most likely cause of her current symptom? NMS, neuroleptic malignant syndrome, lithium toxicity, serotonin syndrome, या acute dystonia? क्या ये क्वेश्चन था? अभी तक आप लोगों ने जितनों को हाँ बोला है, मैं वो एक बार डबल चेक कर रही हूँ. ओके, क्या ये क्वेश्चन था? ये वाला गाइस. Was this question there? Hyperactivity plus hyperreflexia. We will show the Q bank. बाद में करेंगे guys. डिस्कशन लॉन्ग वाली हम आपको फिर से दिखाएंगे पक्का. ऑप्शन चेंज थे. क्या ऑप्शन थे? अगर ये क्वेश्चन था तो आंसर लिथियम टॉक्सिसिटी है. उसमें हाइपर एक्टिविटी हाइपर रिफ्लेक्सिया होगा. बाइपोलर डिसऑर्डर इज अनदर. ये शायद था, शायद नहीं था. 50-50. ठीक है, आई एम राइटिंग 50-50 गाइस. थैंक यू. नेक्स्ट क्वेश्चन. Patient with bipolar disorder on treatment develops excessive thirst and polyuria. Which drug is the most likely? Valproate, carbamazepine, lithium, lamotrigine. ये क्वेश्चन था क्या? Was this question there? No. 50-50. देखो लिथियम से रिलेटेड एक क्वेश्चन तो था ही. ये था बट ऑप्शन अलग थे. पर ऑप्शन अलग हो सकते हैं पर इसका आंसर लिथियम है क्योंकि उसको पॉलीयूरिया एंड पॉलीडिप्सिया हो रहा है. तो डायबिटीज इंसिपिडिस के भी फीचर्स आ रहे हैं. तो लिथियम यहाँ आंसर है. लिथियम टॉक्सिसिटी वाला क्वेश्चन था कि लिथियम वाला क्वेश्चन था? क्या ये था? Was this there? Give me a thumbs up. था. I believe ये था. Cool. Awesome. With that, I just want to quickly reiterate कि आपने कौन से क्वेश्चंस बोले हैं थे. एक बारी मुझे प्लीज फिर से कंफर्म कर दो. ये क्वेश्चन नहीं था. मैन इज सस्पिशियस वाला क्वेश्चन नहीं था. ऐसा कोई क्वेश्चन नहीं था. सबने कहा है कि ये एक क्वेश्चन था कि बॉय डजंट रिस्पॉन्ड. ऑप्शंस की सबको गड़बड़ हो रही है कि कैसे फॉर्मेट था बट आंसर ASD था. राइट, ऑटिज्म स्पेक्ट्रम. ठीक है. उसके बाद सबने बोला है कि हाँ ये क्वेश्चन तो पक्का था जिसमें हाइपोकॉन्ड्रियासिस आंसर था. तीसरा सबने कहा है कि ये वाला क्वेश्चन नहीं था मैम, ये वाला क्वेश्चन था. क्वेश्चन नंबर 3 बोला गया मैंने इसको कि एंटी डिप्रेशन एंटी साइकोटिक देना पड़ेगा क्योंकि स्किज़ोअफेक्टिव पिक्चर है. ठीक है. अब ये वाला क्वेश्चन सबने कहा है कि जरूर था मैम. टिपिकल एंटी साइकोटिक आंसर था. ठीक है. और ये क्वेश्चन सबको श्योर नहीं है. तो ये क्वेश्चन सबको श्योर है कि लिथियम आंसर वाला. 5 मेरे को पक्का हो गए हैं. अगर लग रहा है छठा सातवां है तो प्लीज डेफिनेटली ड्रॉप इट इन द चैट बॉक्स. आई विल टेक योर लीव गाइस. वी विल डू अ फुल प्रॉपर रिकॉल. आई प्रॉमिस. मैं अभी बाकी टीचर्स को देना चाहती हूँ चांस. एंड जस्ट गेट रेडी फॉर माइक्रोबायोलॉजी नाउ. थैंक यू.
Thank you, ma'am. So, hi guys. Of course, it's very, very late in the night. So, of course, I'm not going to take too much of your time. There were around 20 odd questions in microbiology this time. Surprisingly, there were not much overlaps. ठीक है, overlap mostly with dermatology. Dermatology काफी ज़्यादा microbiology overlap था. बाकी straight away microbiology questions were asked. मुझे लगता है कर ही लिए होंगे. And they were not extremely difficult questions, but what I would like is, so there was some difficulty in the recall. So I have come up with the most probable options which were asked from you. अगर लग रहा है कोई भी ऑप्शन नहीं था और देयर वर सम डिफरेंट ऑप्शंस, प्लीज लेट मी नो इन द chat box in the comment box. I will change it right there and then. There were a few questions जिसमें confusion है कि whether this was asked or that was asked. So we will keep doing that. So there were 20 odd questions and we will very quickly run through each one of them. So a lot of students have told that a CMV का question was there. There was some comment on the CD4 count. ठीक है, and biopsy of the affected tissue was attached. एक जो चीज पता लग रही है कि देयर वाज अ सिंगल आई गिवन है ना ऑफ द आउल्स आई. देन प्लीज लेट मी नो whether a single eye of the owl's eye was given in the question and its image was attached. So the good news is that all the questions, 100% questions, were covered in the June marathon of microbiology, and many questions were also covered in the FMG predictor series. So I have attached the screenshots of those lectures and those series right here. So of course CMV was the answer. So please let me know ki, which image was given. Was it that the single eye inclusion body image or the classical double eye inclusion body image was given? That is what I want to know from from you right now. Okay, so let me know. I will move ahead up till then. अगर इस पे कोई consensus है तो then same image as first one. ठीक है, okay, all right. So of course this was discussed in marathon as well. And if you find that the options were any different, then please let me know that as well. If you feel that these were not the options, then you can let me know that as well. Single eye tha, single eye question was image was there. Chalo. 42-year-old dairy farmer presents with prolonged remittent fever, drenching night sweats. They're of course talking about Malta fever. Blood culture is ordered. So blood culture उन्होंने order किया था and they showed this image of the biphasic bottle, right? So the answer was of course brucella, right? Brucella. So if you have any trouble in the options of this question or you feel that the history was not given and straight away it was asked as Castaneda, please tell me if history was given. History was given. And they had asked that blood culture they were trying to do, है ना? ऐसा ही question था. This is what I have come to know. Toxicity wala will come on the question. Chalo, so please let me know as and when you feel like telling. Acha, only straight away bottle was asked. So history was not there, you're saying. No history. No history, straight away bottle. Yes, Castaneda. So they had mentioned. Okay, so they had mentioned Castaneda. Okay, fine. Got it. So now the third question, single bottle with solid and liquid also, and then you had to identify the organism. Okay. Only Castaneda bottle image. Right. Okay, fine. So we will remove the history from the question. Okay, so then the third question is there were some Mumbai bottle में options अलग थे. So it was not Salmonella brucella. Now you're saying history with fever, night sweats, arthralgia. Okay. Okay, fine. So you're saying that one of the options was Castaneda. Options was Castaneda. All right, guys. So if you have any more differing opinions, then you can please let me know. So up till now, this is what I've received, that the Castaneda bottle was given to you and you had to mark brucella. ठीक है. Okay, fine. Option was, yes, Dr. Ankul, if you can tell me, Anukul. अच्छा, okay. क्या है ये? What is the specimen? So you had, the option was supposed to be Castaneda. अच्छा, Castaneda, LJ medium, LSS, ऐसे options थे. All right, so we'll correct it. Done. Thank you so much. Got your point. So simple image of the bottle and we had to identify. All right, that makes it very, very simple. Okay, 100% bottle was given and option was Castaneda. Got it. All right. So then I heard that there was some Mumbai floods related question and the person had presented with calf muscle tenderness, conjunctival suffusion. So please help me whether this conjunctival suffusion buzzword was there or not. And then I received that there was a dark field microscopy image of the tightly coiled spiral bacteria. So the answer was Leptospira here, of course. Right? Got it, guys. Got your point. Can we move on to the next question? So we will discuss this. Yeah. All right. Thank you. Yes, was given buzzword. ठीक है, excellent. So you had the conjunctival suffusion buzzword in it and
Hi guys, give us a little bit of time. I think there were some technical snags. Dr. Anusha is offline. She'll be back soon and we'll continue with the micro questions. So, how have you done? So, let me know how was the exam for you guys. I know the things were a bit complex, but you have gone through the recalls. So, how do you feel? How do you rate the exam? Like, have you done well? You're expecting to get a decent mark, or it seems difficult? I know I personally judge this exam as an unfair exam because time management was quite complex or difficult for a lot of students. Videos were lengthy, there were also lengthy stems and extremely integrated questions, making it difficult to actually say this was medicine or this was pharmacology. And many people found it like I was literally arguing with my other faculty members saying that, okay, I will take this in medicine. They're like, no, no, we'll take it in pathology, we'll take it in pharmacology, we'll take it in medicine, we'll take it in surgery. Okay, so give us a little bit of time before we fix the issues, and Dr. Anusha will be back covering the micro questions. I think micro was not a very tough paper today compared to the other subjects where things were a bit complex, like forensic medicine or even for that matter, video-based medicine questions. Micro seems to be relatively easier. Dr. Anusha is back. Dr. Anusha, over
Hi,
to
sir.
you.
I'm back.
Kids are waiting for
Thank you.
the
Thank you. Sorry
answers.
for that glitch. So let's get back on the wagon and let's try to finish and let's pick up our pace again. So I think the recall has also gone through what has happened in exam today. So many natural calamities have happened in the exam center. I'm getting so many messages about the heat and everything. Chalo, let's get back on track, guys. Let's finish it off. You're saying option में culture का name था dark field. Okay. Okay. Whatever question discussing came in exam daily basis seeing OPD words. Yes, that is very true. But very true. Exam. All right. Chalo. So let's get back with microbiology. So you had been given some image of an S-char and it was also explained ki wo black center and extensive edema and redness surrounding, right? So what is the virulence factor responsible for this condition? That is what they had asked. I did not get the other two options in this. I've only gotten that you were to differentiate between the capsule and toxin of Bacillus anthracis, right? Two toxins are there in each option in this question. Okay. Two toxins. Two toxins in each option. So was it like toxin A, toxin B, or like that, or because the thing that I have gotten is that you were to differentiate between Bacillus anthracis का capsule or Bacillus anthracis का toxin. Yes, answer is C. That's true, but were these the options? So if you can just help me with these options are not there, definitely. So what, okay, can you tell me what was it that you have marked? Even if you can't remember the question, do you remember the answer that you have marked? आंसर आप टॉक्सिन मार्क करके आए हो या टॉक्सिन के स्पेसिफिक नेम्स वर आस्क्ड? If anybody can help me with this. Yes. Okay, that's fine. That's all right. That's completely all right. So as of now, we are going with Bacillus anthracis toxin as the answer. If you can recall at a later stage, please reach out to me and let me know. Then we can definitely update it and correct it because I'm getting that yes, it was there. I'm getting some yeses, and this, of course, is also based on the recall of a. Okay, you're saying toxins ka specific name. So of course, it should have been Bacillus anthrax toxin. Okay. Okay, this is one feedback that I've gotten. All right, no problem. Then this was a direct straight away question. I'm guessing that you were directly asked hand, foot, mouth diseases caused by, and you were to differentiate, yes, something edema toxin and lethal toxin. Got it. Right. Edema toxin, lethal toxin. So all the toxins of Bacillus anthracis. Okay. Enterotoxin. Okay, got it. All right. Chalo, ठीक है. Awesome. All right. So capsule was definitely not there. So you were not to differentiate between capsule as a virulence factor or toxin as a virulence factor. So the question might have been straightforward. What is the toxin responsible for this condition? What is the toxin responsible for this condition, right? ठीक है. Okay, got it. Excellent. So hand, foot, mouth disease, you were to differentiate between Coxsackie A and Coxsackie B, or there was specifically Coxsackie A16 given in the option. You tell me that. So hand, foot, mouth disease, of course, you know it is Coxsackie A16, Coxsackie A6, and enterovirus 71. We have done it so many times. Predictor may covered, marathon may covered. ठीक है, got it. हाँ जी. Yeah, edema toxin, lethal toxin. So of course they wanted you to know the specific anthrax toxin. Got it. Excellent. So if you can help me with this question. If you can help me with this question. Of course, if it was simply between Coxsackie A and B, so you would have easily marked Coxsackie A. This was of course an overlap with both pediatrics and dermatology. I'm hearing there were two questions on Coxsackie, one in part 1 and one in part 2 of the paper, but one was purely dermatology and this was the closest to microbiology. A16 was given. All right. So A16 was given in the option and you had to, of course, mark that. Can anybody remember whether the other options was like varicella, HSV? All right, chal. Let me know if you can find out. So, of course, you know that Coxsackie virus has been a favorite this year, so it is getting asked a lot. Next is a 25-year-old sexually active male, this and that, everything lost. You had to just look at this buzzword, groove sign, है ना? And we have always studied in the genital ulcers, always a groove sign is a feature of your, lymphogranuloma venereum, है ना? Right? LGV caused by chlamydia trachomatis. We always say LGV is 3 letters. So L1, L2, L3 is your answer. So of course here chlamydia is your answer. Right? So if you find any discrepancy, please let me know. I'm going to rush through it for your sake because it's very, very late in the night and you also want to sleep off without any anxiety. Coxsackie A was given. Excellent. Chalo. 34-year-old man from rural area presents with sudden onset of high fever chills, painful, tender groin buboes. Now, I want you to know whether this question was there or not because I got a question saying that, okay, there was, instead of this groove sign question, there was the buboes wala sign question with the rat fleas. So you tell me. This question there? Was there any question with bubo and rat flea in it? Painless ulcer, painless lymphadenopathy. हाँ तो वो LGV ही बनता है तब भी and groove sign. ठीक है. So we have included that, है ना? So we can add painless ulcer plus painless lymphadenopathy. हमेशा ऐसे ही पढ़ते हैं हम, whenever ऐसे painless, then yeah. Not there. Louse option. Louse ka question seems like a new question. So the rodents question has been included in the leptospira, है ना? Leptospira में हमने Mumbai floods and rodents वाली सारी चीज add कर दी थी. Rodent excreta. So you tell me this question was there or not? Rats was mentioned. Answer was rat flea. Oh, disappearance of rats. All right, all right, all right, all right. So it was not bubo. It was disappearance of rats, like rats dying in an area. Okay. Dead rats were found. Option, it was plague, flea, something like it. Rats were mentioned and option was flea. Okay. So either it was bubonic plague here or rat flea you had to mark here. ठीक है. एक ब्लैक एक्स्ट्रा देके ठीक है, गॉट योर पॉइंट. ब्लैक एक्स्ट्रा देके वो हो गया क्वेश्चन हमारा. All right. ठीक है. Okay. 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 Right. So of course answer is bubonic plague here and the history was not there. Outbreak of die-off. हाँ ठीक है. तो ये जो हमने point लिखा है, history of outbreak of die-off among local field rodents. Okay. ठीक है. So this much was there. चलो. Excellent. Then you tell me there is a division. Was rhinosporidiosis culture, just a second, guys. Was rhinosporidiosis culture medium asked or was swimming in stagnant waters culture media was asked? two things I've gotten. So culture medium was asked for rhinosporidiosis or swimming in stagnant water. Because if it's swimming in stagnant water, they must be talking about free-living amoeba. So either Naegleria or Acanthamoeba. Most likely Naegleria here. Okay, flea was there as a question. Got it. Sahi baat. Swimming was there. Acha. Now swimming could have also been as a rhinosporidiosis question. तो क्या ये डायरेक्ट वन लाइनर था? राइनोस्पोरिडियोसिस का कल्चर मीडियम क्या है? या फिर ये था स्ट्रॉबेरी लाइक पॉलीपॉइड मास्क आफ्टर स्विमिंग इन स्टैग्नेंट वाटर्स, या फिर इट वाज सिंपली अ क्वेश्चन ऑफ स्विमिंग इन स्टैग्नेंट फ्रेश वाटर पॉन्ड्स, और फिर सीएसएफ से हमने लिया है. सो फर्स्ट ऑफ ऑल, ओके, बोथ क्वेश्चंस वर आस्क्ड. So if both questions were asked, then for rhinosporidiosis, you tell me whether it was a single one-line question. Single one-line question, or they had given all this strawberry-like polypoidal mask. Because I think what I have received feedback so far is it was a straight question. Might flee and something that I've gotten. I will change that question. So of course, question had said that the rodents were dying off. So rat flea was one of the options in the question. Got it. तो बाकी उन्होंने might और ये सब दिया होगा. Freshwater swimming and CSF culture question was there. ठीक है, excellent. हाँ, so first can you first clarify about the rhinosporidiosis question, please? ठीक है, नॉन न्यूट्रेंट अगार विद ई कोलाई, ये आपका ऑप्शन था. So this is correct. So more or less, this we have achieved the consensus that question was like this, and there was CSF mentioned. And okay, Manipur. Probably Manipur question was in schistosomiasis for you. Diamond agar, diamond agar, acha, diamond agar was one of the options. Chalo, we will make one of the options as diamond agar or diamonds medium. So rhinosporidiosis was a straight away question then I'm taking from here, right? I'm taking that this was a straight question and you had to say that there was no culture medium and it cannot be cultivated in vitro. ठीक है. All right. So now this question on onchocerciasis, onchocerca volvulus leading to river blindness, I want to ask whether there was a full history given or it was a straight one-liner again which said river blindness is caused by. Right? So can you please help me here? Because of course, we have been able to pinpoint the topics very clearly, but we are having difficulty in recalling whether it was a full history type question or single line question. So I have come up with the history. Looking at this history, is it ringing a bell? Is it ringing a bell that there was history or not, or was it a straight one-liner? जो भी था, हिस्ट्री थी भी, उसमें रिवर ब्लाइंडनेस लिख दिया था या स्ट्रेट अवे क्वेश्चन था रिवर ब्लाइंडनेस था, डज नॉट मैटर. वी ऑलवेज से वी ऑलवेज मेक अ राउंड एंड वी मेक द स्क्वायर एंड वी कैन इजीली रिमेंबर रिवर ब्लाइंडनेस फ्रॉम देयर, है ना. सो आंसर वी मस्ट हैव गॉटन इट करेक्ट. Okay, rhinosporidiosis question was different. All right. So please let me know if you can think of the question, Dr. Sahil. Yes, please get back to me if you can think of the question. Otherwise, it's okay. We know the broad topic which was asked. Broad topic as was rhinosporidiosis. They wanted you to know that this is uncultivable, right? And that swimming in fresh water, they wanted you to know that you had to do the non-nutrient agar with the E. coli and seeing the track sign on these non-nutrient agar. है ना? The track sign you had to look for. ठीक है, no problem. No problem. We can at least, get to the topic. Larva in the eye, I'm coming to that question, Dr. Nani. Okay, I'm coming to that question, the larva in the eye question. So both questions I've gotten, onchocerciasis as well as loiasis. ठीक है, चलो नेक्स्ट ये देख लेते हैं. ये तो क्लियर कट था, HIV पॉजिटिव था, देयर वाज अ लो CD4 काउंट हिस्ट्री, और बोला था बायोप्सी में क्या दिख रहा है हमारे ओवल इंट्रासेल्युलर yeast clustered inside the macrophages. Some people have said that spine-like projection, tuberculate wala image was also given in the question. So let me know whether this image was given or not. ठीक है. And histoplasma. कुछ बच्चे बोल रहे थे कि bird droppings, bat droppings की भी बात पूछी गई थी. Right? Was this question asked? Bird dropping, bat dropping, spread from bird dropping, bat dropping. Let me know if the bird dropping word was present in the question. And of course, you have to mark histoplasma. I'm coming to the lower question. Paragonymous westermani. All right. So probably we can add, are you sure? Are you sure that this question was there, that there was Manipur ka history and there was ingestion and then Paragonymous Westermanni or lung fluke was asked? Okay, then I will add it for sure. ठीक है, ये मुझे बताओ. Okay, image was given. ठीक है. So you had to mark histoplasma over here. Options were different. All right, so we can revisit the options always, but likely you have said histoplasma correct. All right, how many intermediate hosts are required to complete the life cycle of this pathogen? Hannah, you had been given the image of Schistosoma mansonite, TD mansi with the lateral spine, and we always read schistosomes. All the exceptions of the schistosomes are present in the name schistosome. So we always say SO, snail, only single host. So you could have marked this very, very easily. Yes. So there was also this was one question wherein there was no confusion. You have all very clearly said that this image was given. So 35-year-old male presents with acute profuse painless diarrhea resembles right water. तुमने कहा था history में lice water stool था and mechanism of action of the toxin पूछा था, right? Mechanism of action of toxin. So we have multiple times revised all of the mechanisms of action. You know it is increased camp by acting on the GM1 ganglioside receptor. चलो. Okay. Dr. Zameen, but this is the spine, no spine, no spine. Acha. But was it a schistosoma egg at least? Was it a schistosoma egg at least? The image, if you're saying that there was no spine in the egg, in the image? No spine in the image, 100%. Then how come the question becomes schistosome? If you're saying there was no spine in the image, then the question does not become schistosoma itself. So had they written schistosoma mansoni? Bird dropping is there. I will add it to the question. Thank you, Dr. Maria. Then how did you identify the schistosoma egg if spine was not there? Okay. So you are saying that in this question, they had given the history of ingestion of, and they had given lung symptoms, and this was paragonymous egg. So was it an operculated egg like this? Manipur patient. In this question, you are saying it was like this. Manipur patient with the operculated egg. And in that case, they had asked you. Okay, okay. All right. Now somebody is saying Mansonia was there. Okay. Okay. Yeah, so in that case, it becomes 3. The answer becomes 3 in that case. Yeah? All right. No lid also. Okay, so now we are all very late into the night and we are all very, very confused, it seems. So, all right, best of both worlds. We'll include both the questions. ठीक है? जिसको spine दिखी थी, उनको याद है कि वो शिस्टोसोमा का egg था, तो 1 was the answer. किसी ने बोला कि मणिपुर वाला क्वेश्चन था, operculated egg दिया हुआ था, तो 3 was the answer. ठीक है? Okay, got it. All right. तो ये तो क्लियर कट था. इंक्रीज्ड कैंप, इसमें तो कोई डाउट नहीं आया होगा. दिस वाज क्लियर कट, नो डाउट क्वेश्चन गिवन. अब यहाँ पे एक हिस्ट्री दी थी आपको वर्म इन दी आई की, और जिसमें लिखा हुआ था, स्टूडेंट्स हैड क्लियरली टोल्ड दैट देयर वाज नो इमेज ऑफ द माइक्रोफाइलेरियल वर्म गिवन. उसमें लिखा था कि माइक्रोफाइलेरिया शीथ्ड है एंड द न्यूक्लियर एक्सटेंडिंग ऑल द वे अप टू द टिप ऑफ द टेल. ऐसे क्लियर कट लिखा हुआ था. सो वी हैव ऑलवेज रेड लाइन से न्यूक्लियाई इज लोअर लोअर, राइट? सो द आंसर वाज लोअर लोअर हियर. सो okay, got it. Spine nahi tha, because I got confused as well. Okay, great. So if Dr. Zameen, if you can share the image with me on my social media, if you can find the image on Google, take your time, sleep off tonight. Tomorrow, try to share what if it was definitely a schistosoma egg, but without a spine. So can you find such an image on the internet, or you are saying paragonymous question without operculation, है ना? All right. लोअर लोअर ठीक है. loa का 2 options था, meaning they had mentioned loa twice in the options. अगर 2 बार 2 option में भी description था, so they wanted you to say something specific about loa as well. Okay. Okay, so you let me know because that is very unlikely. आप बोल रहे हो लोआ 2 बार था and they wanted you to answer something specific about it. अच्छा. So okay. ठीक है. So we can get back to it. And then there was this photo of autoclave, right? और ऑटोक्लेव में हमने क्या बोला था, उन्होंने पूछा था बायोलॉजिकल इंडिकेटर इसका क्या है. स्ट्रेट अवे आंसर था जियोबैसिलस टेरोथर्मोफिलस. दिस वाज आल्सो रिकॉल्ड बाय मोस्ट ऑफ यू विदाउट एनी प्रॉब्लम्स. देन कैन यू हेल्प मी विद दिस टॉक्सिक शॉक सिंड्रोम का आंसर क्वेश्चन था. दे हैड शोन दिस स्किन अपीयरेंस. वाज एनी हिस्ट्री गिवन एसोसिएटेड? बिकॉज आई डिड नॉट रिसीव एनी हिस्ट्री. वेक्टर से ट्रांसफर, लोआ का टेल वाला ट्रू नहीं था. टेल टिप की कुछ फाइंडिंग थी. स्पाइनलेस इज जेपोनिकम 2, राइट, बट दैट वाज नॉट गिवन इन द आंसर. तो टेल टिप की फाइंडिंग हमने लिख दी ना, न्यूक्लियस एक्सटेंडिंग ऑल द वे अप टू द टेल टिप. It's all right. It's late in the night. That's why they were getting so confused in the recall. क्लोनोर्किस का एग था विद फ्रेश वाटर हिस्ट्री. सो दिस इज कंप्लीटली डिफरेंट नाउ. जो भी हो ऑपरक्यूलेटेड तो होना पड़ेगा. ट्रेमाटोड की जब तक बात हो रही है ढक्कन आएगा. ठीक है. सुपर एंटीजन भी मेंशन था. सो टीएसएस वाले क्वेश्चन में super antigen was mentioned in the question. Okay, fine. We will add it in the question. So that is how you could get to the toxic shock syndrome. ठीक है. Retain tampon use वाला ऐसा कुछ नहीं था ना, लेकिन स्काल्डेड था. फीमेल की हिस्ट्री नहीं. अच्छा, फीमेल का नहीं था. ओके, वी विल रिमूव फीमेल. Yes, question options are not correct because we have tried very hard to recall. So at any point you feel options are not correct, let me know and we will nuclei in tail. लोआ रटा था. अच्छा. टॉक्सिक शॉक सिंड्रोम ही नहीं था ऑप्शन में. चलो, सो देन लेट मी नो कि क्या क्वेश्चन था. बट ये क्वेश्चन आया तो डेफिनेटली था, है ना? ऑल राइट. Okay, let's take the next one. Step ladder pattern fever था. They wanted you to know बासु, right? So they had asked कि इस point पे early point पे आप लोग कौन सा investigation कराओगे, right? ऐसा question था. विडाल में they had asked about Vidal. Guys, it's okay. Even if, there is some discrepancy in हाँ ठीक है, got it, Dr. Akash. Even if there is some discrepancy in the recall, at least we know mota this is the topic and these were the options. No question about typhoid. Okay, so there is a big question mark on this question. ये question ही नहीं था. Many of you are saying, so we can definitely remove this question. ठीक है, no problem. Okay. ये 65-year-old female underwent elective surgery. Was the C difficile question there? Elective surgery, clindamycin, and diarrhea. Okay, got it. I've removed. So the typhoid question has been removed. Most of you are saying it was not there. So there was some confusion, true. There is some confusion with the C difficile clindamycin question also. Was this there? Just let me know, okay? Until then, we can look at this. Underlying hypersensitivity for lupus nephritis, you know, we are talking about type 3 hypersensitivity, but उन्होंने directly नहीं पूछा था. They had asked circulating antigen antibody complexes deposited in the kidneys. Okay. 5 days history of antibiotic. 5 days. आई थिंक अगर देवर स्पेसिफिकली, हाँ, एंथ्रैक्स वाले में ना स्पेसिफिकली उन्होंने मेंशन किया था ना malignant pustule with the edema, तो edema factor would be the correct answer. Quelling reaction कहाँ से आ गया? अब now there's a full imagination happening, it seems. Now this is an overlap with PSM. So I think PSM sir has already taken it. The dog bite tha, category 3 tha, where you had to administer the rabies immunoglobulin as well. So I think it is settled. This Manipur wala thing we have settled in that question. So as you can see from the entire recall, even if those questions which you have vaguely recalled were covered in the FMG predictor series, also the ones which you have correctly, clearly recalled, they were also covered in the marathon. 100% was covered. So you are saying leptospirosis, one more question was there. 2 questions on leptospirosis. Now this is new news. So I will need to confirm that once if there were 2 questions on leptospirosis. ठीक है, कोई बात नहीं. We will confirm it and we will get back to it whether there were 2 questions on leptospirosis and one with the diagnostic test of MAT. ठीक है, all right. Thank you so much for your feedback. Got it. Excellent. So 20 odd questions from microbiology. That much we have been able to come to, and we have been able to come to the conclusion that mota these were the topics which were asked, and this is the question. So the only discrepancy was the Vidal question was not there. ठीक है. All right. All right. Thank you so much, guys. So more or less it was easy only, है ना? Directly तो था ही. ठीक है. Recall might be a little bit difficult, but answer catch हो रहा था. So that was what was required from us. All right, ठीक है. All right. Very doable. Yes, Dr. Zamin. I also feel that micro was very doable, even despite all the controversy. So चाहे one liner थे, चाहे history based questions थे, doesn't matter, क्योंकि answer same था. And answer was very doable. तो answer was very much मतलब eliminate करके आराम से आ रहा था answer, और overlap नहीं था. Clear cut micro थी. Micro की तरह ही micro पूछी थी. तो दैट वाज अ गुड न्यूज. आई थिंक आज के पेपर में एक माइक्रोबायोलॉजी ही सेविंग ग्रेस रहा है हम सबका, राइट? ऑल राइट. सो थैंक यू सो मच गाइज. आई वुड लाइक टू हैंड ओवर टू द नेक्स्ट फैकल्टी. और भी कुछ भी मन में, इफ यू आर गेटिंग एनी क्वेश्चंस और यू आर रिकॉलिंग एंड यू फील दैट देयर आर मोर options that we need to add, let me know on my social media. All right. Thank you, guys. Thank you. Good night. So can we have the next faculty? All right. Over to you, Dr. Divya. Thank you.
Okay, so let's start with pediatrics without further ado, right? It's very late in the night and we'll just wrap up. Pediatrics this time was very easy to moderate questions. The concepts stay the same. And all the topics that were asked this time were from our predictor series and also from the marathon session that we had. Some questions were just direct lines from the predictor book. So if you attended that predictor series or you have that predictor book, it would have been a cakewalk. So without further ado, let's start. We have close to 13 questions. So one by one, we will go. First, a 4-year-old boy who came with the complaints of rashes over hands, foot, and mouth. Whenever you see this, you just think about hand, foot, and mouth disease, right? And we all know what is the most common organism over here. It's Coxsackie A16, right? It's Coxsackie A16. So you all know that Coxsackie A16 and enterovirus 71, both are the causative agents of hand, foot, and mouth disease. So this was the correct option over here. right? Then the second question was regarding the nutrient deficiencies. We have iodine deficiency. So they asked that iodine deficiency in children is tested by which of these methods? Do we check the serum iodine concentration, urine iodine concentration, TSH levels, or serum thyroglobulin? So very easy, urine iodine concentration, right? Now moving to the next question, normal parents have first child with rickets. During preconception counseling, they ask what are the chances of getting a second child getting it, right? So if they're saying normal parents, that means most likely this rickets is nutritional rickets, right? And if it is nutritional rickets, it's not genetic. So there will be 0% chance of getting it. But if the question said that the parents also had some history or there was a consanguinity history there, then you can think about autosomal recessive variants of vitamin D dependent rickets. And in that case, the answer would be 25. So let me know what was that? Right? So if it was nutritional rickets, then the answer would be 0. But if it was question was aiming towards vitamin D dependent type of rickets, pointing towards autosomal recessive inheritance pattern, then the answer would be 25%, right? So if both the parents were normal, assume that it was nutritional rickets and the answer would be 0%. Then moving to the next question, we had a SAM child with diarrhea and they give danger signs, right? So it must be like severe dehydration. And by danger signs, I'm referring, were they asking about shock? If they were asking about shock, then you all know that in a child with SAM, we assume severe dehydration. It could be with shock or without shock. If without shock, then you give oral Risomal. And if with the shock, which I am assuming is the case over here because they are giving some danger signs, then you would give RL with D5 or half DNS, right? That is 5% dextrose with half normal saline. So the correct answer here would be 5% dextrose with normal saline, right? Right. If it was RLD5, that would have been the correct answer. If RLD5 was not there, then half DNS would be correct answer, right? That's the fluid of choice. Moving to the next question, myoclonic epilepsy and acute tonic-clonic seizures in a neonate. This was a video type question. So remember, any type of seizure in newborns, what is the first choice? Obviously, after aborting the seizure, we move to the first line anti-epileptics, that is phenobarbital. Remember, the drug of choice for neonatal seizures is phenobarbital. So the correct answer straightforward here would be phenobarb. B. Moving to the next question, failure to pass meconium for 48 hours, and they asked about the gold standard investigation. So whenever straight cut, when a buzzword a failure to pass meconium for 48 hours, this is nothing but Hirschsprung disease. And what is the gold standard investigation? It is rectal biopsy, right? On rectal biopsy, you see, what do we see? We see there is absence of ganglion cells and hypertrophic nerve bundles. This is the correct answer. Moving to the next question, this is an overlap question with the community medicine. They ask about pediatric iron folic acid supplementation, and they ask about the dosage of a child 5 to 9 years of age. We had options like daily dose of 20 mg iron plus 100 microgram folic acid, weekly dose of 45 mg iron, 400 microgram folic acid, weekly dose of 30 mg iron, 250 microgram folic acid, and daily dose of 60 mg iron and 500 mg folic acid. So let's move and revisit the guidelines. So if you look at the guidelines, the correct answer would have been weekly dose of 45 mg of iron with 400 microgram of folic acid. Moving to the next question, SCN1A gene mutation. This is associated with very classical. This gene is very classically seen with Dravet syndrome. What happens in Dravet syndrome? Initially, you have febrile seizure-like presentation. Then the child has seizures at lower fever, then without fever, and thereafter, after 1 year, multiple different types of seizures are there. SCN1A gene mutation, right? Okay, so moving to next question, rhizomal composition. Rhizomal we have studied throughout. So remember, SAM child, malnourished children, they cannot handle sodium well, right? So they cannot handle the sodium that is their normal WHO ORS. So that's why this rhizomal has less sodium. And what about potassium? Potassium depletion is very common in malnourished children. So we need higher potassium. So the correct answer is lower sodium, higher potassium. Right? Lower sodium, higher potassium. Okay, moving to most common electrolyte imbalance in the refeeding syndromes. So very age-old question. This time in INICT, they also asked this. So what happens in refeeding syndrome? Refeeding syndrome usually happens in the rehabilitation phase. When you initially start, whenever you shift to a high-calorie diet, there will be a spike in insulin, and insulin will cause influx of potassium, phosphate, everything into the cell, and there will be electrolyte imbalance in the serum. So what is the hallmark over here? Hypophosphatemia is the hallmark. We all understand this, right? Moving to the next question, what is the dose of zinc in a 1-month-old child? I think this has been covered. We also cover this zinc supplementation whenever we talk about pediatric diarrheas. So remember, zinc supplementation is mandatory. We give that for 14 days. And what is the dose? If the child is less than 6 months, we give 10 mg per day. And if the child is above 6 months of age, it's 20 mg per day, right? So the correct answer here would be 10 mg. Moving to the next question, they gave this tape, Shakir's tape, and asked about the measurement, right? So can you notice over here? It is pointing towards red. So what is red? Red is actually SAM. So you all understand this Shakir tape, this colorful tape. We have 3 zones: red zone, yellow zone, and green zone. What these each zone represent? Red zone is less than 11.5 centimeters, SAM. Yellow zone is MAM, 11.5 to 12.5. And then we have green zone, which is a normal child and a well-nourished child. Moving to the last question, I believe you had a weight for age girl WHO growth chart, and they asked you to interpret that, right? So you all understand anything beyond plus minus 2 standard deviation is abnormal. Anything beyond plus minus 3 standard deviation is severely abnormal. So if in the growth chart they have pointed towards 50th centile, that is the normal. That is the normal, right? Anything beyond 15 and 85 would be, that is minus 2 standard deviation, and plus 2 standard deviation would be abnormal, and beyond that would be severely abnormal, right? So if so the answer here would be normal weight, right? Normal weight. If it would have been here, that would be a underweight child. If here, severely underweight child. If here, overweight child. If here, obese child, right? So with that, we end up this session. But before ending this session, I want to emphasize that FMG exam, I know this time was more tougher, more lengthier, right? It was draining, very stimulating exam. But once you're thorough with your concepts, those concepts stay with you and help you in the long run. And that's where this FMG predictor book comes. In the last moment, we did a marathon session, we did a predictor series. And as far as pediatrics is concerned, there was 100% strike rate, right? Because pediatrics and FMG is something which is very clear cut. They ask about very common concepts, very clear-cut questions are there, no twisted questions are there. And with that, we end up this session. If any other question, any other doubt is there, my social medias are there, drop the message over that, and we'll be able to cover that, right? So without further ado, let's wrap up this session, and I'm handing over to the next faculty. Vineet sir, please take
Thank you,
over.
ma'am. Thank you, ma'am. Thank you. Thank you. All right, guys. So let's discuss with the anesthesia recall. Anesthesia questions were fairly simple. I'll try and finish them as fast as possible. And as emphasized by everyone, all the questions were covered with our predictor and the marathon series. Here is the first question. And the first question was basically about which of the following tubes is most suitable for endotracheal intubation. All right. So here they had given 4 images. This was an image-based question. And options given were about the oropharyngeal airway. It was about the nasopharyngeal airway given here. The third was the endotracheal tube, and the fourth was the laryngeal mask airway. So it's a very simple question. All right. So the answer over here was which is the most suitable from the image based. This is the endotracheal tube, and this is what we use for the endotracheal intubation. If any changes, guys, please let me know. I am looking at the options. So this was the first question. Very simple, covered in all the lectures and all. This is our marathon series. We have covered about the endotracheal tube in detail. We have the oropharyngeal airway, nasopharyngeal airway all covered, right? Including the laryngeal mask airway. This was all covered, right? Even in the marathon series and the predictor series, it's all available over there. Next question. was about a child. Now, I want some clarification if someone can help me out with this. They have not mentioned the age of the child from what I got from the students. A child is choking while swallowing. This was what was mentioned. And the child has a complete airway obstruction due to foreign body. It has not been mentioned if the child is responsive, not responsive, because this also forms a very basic point before you give an answer to this. What is the most appropriate emergency maneuver? Options, two options, I'm pretty sure. One was 5 back blows, the back slaps, basically 5 chest thrust. All right. And 5 chest thrusts were there. The second was a Heimlich maneuver, abdominal thrust, blind finger sweep, and immediate endotracheal intubation. There's one question from Dr. Savage King. Sir, it was RTA with option including metal tracheostomy and plastic 1-2. Image was given. Which one? There was no child mentioned. Okay, fine. So child was not mentioned. Very nice. So this one point that child is not mentioned. So therefore, the point is someone is choking and has an airway obstruction due to foreign body. What is the most appropriate emergency maneuver? In that case, remember 5 back blows and 5 chest thrusts. So if you are talking about choking and about the response has not been mentioned, there are two things. If the patient is responsive, we would be going for a Heimlich maneuver. And if the patient is not responsive, normally the answer is to go for chest compression or to start the CPR. If that point has not been mentioned, we'll stick with the answer Heimlich maneuver. Okay. Initial maneuver by American guideline, American board guideline. Ideally, guys, point is if it's an adult patient, we will go for Heimlich maneuver. If it was an infant less than 1 year of age, then in that case, we go for 5 back slaps and 5 chest thrust. Okay. Otherwise, the answer is B, Heimlich maneuver. And this is again what we've covered in all our sessions. Choking is always covered. We've covered in the marathon sections as well. You can see about the Heimlichs and 5 back slaps, 5 chest thrusts. All these points we have discussed. Okay. But if there's any changes, then let me know. And anesthesia was very simple. All of them are covered in the predictor series as well as the marathon series that we've done. Adult and responsive, correct. The answer is Heimlich maneuver. Dr. Zamin Bhatt says that. Done. So our answer is Heimlich maneuver. Let's go to the next question. This was a video-based question about the Mallampatti classification, and where it has been said that during a pre-operative assessment, patient was asked to open the mouth, protrude the tongue without phonation, which is the meaning we are doing a Mallampatti. Based on the image, what was seen, I think the answer, what was said by the students was complete uvula was visible. And when you can see the complete uvula, remember the answer is Mallampatti class 1, which forms easy intubation. All right. So therefore, this is again covered in our predictor series also, as you can see, or even in the marathon. Everywhere, whenever we have discussed, we always covered Mallampatti, always said, just look at the uvula and you know the answer. So it's covered in the predictor series. And Dr. Yasin Bhashin says all was seen. Correct. So therefore, the answer is uvula. And here we have Mallampatti class 1 as the answer. All right. Patient was RTA, different tracheostomy tube, adult person, A, class 1. I think everything is okay. Most of the points. Finger sweep was also mentioned. So I think most of the, overall, we are fine with the 3 questions. The last question that I got from anesthesia, I got only half a question, that a patient is on warfarin and is planned for surgery. So the point was whether to stop it 5 days prior, continue the medication. The other 2 options I'm not aware of. But whenever a patient is on warfarin planned for surgery, you need to stop it 4 to 5 days prior to the surgery. Right. Again, we have discussed this in the marathon series. You can see this. Warfarin is supposed to be stopped 4 to 5 days prior to surgery before we do it. All right. If there are any other options, guys, that you can recollect regarding this, you can let me know. Or if there are any other options, you can let me know. RTA question tha, which tracheostomy tube? Dr. Zamin Bhatt says stop warfarin and switch to low molecular weight heparin. That was given. Acha, stop warfarin and switch to low molecular weight heparin. And switch to low molecular weight heparin. In that case, even this is right. But then what was the answer about this? Was it 5 days given? If it was given 5 days, then that is fine. Sir, stop it on the day of surgery. Stop it on the day of surgery, wo galat hai. That is not to be done. Stop on the day of surgery. So we got all the options. Stop on the day of surgery. So this is a wrong option, right? Continue medication is a wrong option. Ideally, other drug was stop the surgery on the day of. We can give vitamin K as well. Vitamin K kahan pe tha? Anyways, that's not important. The point is, if it was given 5 days prior to surgery, ideally it is stopped 5 days prior also. And yes, you switch to low molecular weight heparin. But I need to know if there's any other thing in the surgical part as well. So even both the options are almost correct. stopping 4 to 5 days prior to surgery is also correct. But normally the point is, if a patient is on warfarin, we basically switch it to low molecular weight heparin. So therefore, in that case, we would even think about answer C to be the correct answer. Okay, so A and C ideally both are correct, and I feel there has to be something else also into the question. No, the answer was given stop warfarin 5 days before, and with that to a low molecular weight. Acha, stop 5 days prior and switch to low molecular weight. Then that is the correct answer. Correct. And that is if you stop 5 days prior, you need to switch it to low molecular weight heparin and switch to low molecular weight heparin. That is the correct answer then, guys. Okay. So let's stop. Here there is something else written then. This option has to be something else, right? So 4 to 5 days and switch over to low molecular weight heparin. This becomes the correct answer. All right. In that case, we'll go with option A. Option C is then what we need to see. That is something regarding vitamin K is to be given to the patient, right? This is one point. And you need to get rid of same old medical language. The option was nowhere near. हाँ तो वो तो रहते ही ना वैसे, but this is what is from the recall, guys, right? This is what the students have recalled, and this is what we have done the best that we can. You're right with the fact that, the language is not going to be exact. Absolutely correct about it. All you need to know is everything is simple. Basically, it's all been covered everywhere. And if you guys have, if you have read things out, trust me, you'll be right with all the answers. That's the point. Okay. The point is not to have an absolute discussion as to what is there and what is not there. But I think all of you know the answers. And I think about anesthesia, most of you will have all the answers correct. Okay. If there are any other doubts or something, you can share it with me. If any other question, you can let me know. You can have my number and my Instagram ID. You can share me questions directly on my Instagram or my WhatsApp. Okay. So students got confused with the answer. Correct hai bhai. If people would have got confused, I think these are the 4 questions which I got. If there any other thing, guys, please let me know. Otherwise, I'll wrap up with the session. So hopefully, there was one more question, says Dr. Savage King. What was it about? Dr. Savage King, your question is, he's saying one more question. What was that question? Anything? One more question of which we don't know. Okay. So one more question from anesthesia, the 5th question, which I am not aware of as of now. There were 4 questions which we got. One more question regarding fast anesthesia. Propofol, ketamine. Propofol and ketamine. So yeah, fast anesthesia to basically propofol se hoga. Ketamine comparatively slower hai. If propofol was something low BP, fast anesthesia, low blood pressure. Low blood pressure mein propofol not to be given. Patient with mechanical heart valve, thiopentone also. Okay. Ketamine question, patient with accident with BP 80/60. Okay, low BP 80/60, you have to give fast anesthesia. In that case, what drug will you give? So you will not give propofol, you will not give thiopentone. If it's a low blood pressure, I will be going with ketamine as the correct answer. Then ketamine becomes the correct answer. Okay. If this is the question, guys, I have no idea. No one had recalled this question. All of you are recalling it. So it's the 5th question coming from anesthesia. Okay. So maybe RTA patient, right? Planned for surgery, low blood pressure, fast anesthesia to be given. Ab sevoflurane kahan se aaya? The 4th option. No, sevoflurane will not be used. If sevoflurane is the 4th option, again, that's not the answer. If the BP is on a lower side, 80/60, the only drug you're supposed to use is ketamine ideally. It is going to raise the blood pressure. Everything else is going to sort of decrease the blood pressure, decrease the blood pressure, decrease the blood pressure. Ketamine is the only one that increases the blood pressure. And therefore, the answer ideally should be ketamine if this is the question. Low blood pressure patient, fast anesthesia, BP 80/60. My answer is going to be ketamine. All right, guys. So thank you for helping me out with that. That's my number. If there's anything else, you can WhatsApp me directly on my number or on my Instagram ID. Okay, Dr.Vinish. We'll be sharing all this with you, so you can just share the questions directly with me as well. That's my WhatsApp and that's my Insta. Let me wind up over here. Sevoflurane was of the option, guys. So that's sevoflurane I mentioned kar diya as a 4th option. It was a topic related to daycare. तो क्या 6th क्वेश्चन भी आ गया क्या? अगर डे केयर पूछा है तो डे केयर में आंसर इज गोइंग टू बी ओनली प्रोपोफॉल और सीवोफ्लोरिन आइडियली. कीटामिन रेयरली होता है. So propofol or sevoflurane is going to be the answer for daycare. If someone has asked daycare, guys, so in daycare surgery, ideally the answer is going to be either propofol normally or sevoflurane. Sevoflurane. CNS complication. CNS complication. So guys, I think you need to let me know because it's very difficult to build up a question over here. All right. I think, okay, the same question, daycare surgery. So guys, agar BP fall kar raha hai na, there's a BP falling down, then ideally you're not going to use propofol, sevoflurane, thiopentone. Answer is going to be ketamine. Okay, so they are saying rapid anesthesia with hypotension if a person's BP is fallen down and it's a daycare surgery, right? So in a daycare surgery, ideally the answer is propofol, but if the BP is falling down, you're not supposed to use anything else, just use ketamine. Okay, it's a trauma patient with hypotension. Fine, guys. I think let's not waste time on that. We cannot be constructing the whole question, I think, with this way. But I think we've got the gist of the question that it was regarding daycare, rapid anesthesia with hypotension, and therefore the answer to the question is going to be ketamine. Hopefully that was the point. Okay. So anything else, guys? Right? Trauma patient, BP fall, anesthesia of choice. Ideally, the answer is ketamine. That is what we will stick to the answer from what we have recalled till now. This is the 5th question from anesthesia, guys, that we recalled over here. Anything else, guys, please you can text me directly on my WhatsApp or on my Instagram, and I will wind up over here. Thank you so much for joining me at the session. And as you have seen, all the things basically, even this question is covered in our predictor series as well as in the marathon. So yeah, I hope it was helpful to all of you, the marathon as well as the predictor series. Thank you, guys. And I think Dr. Sandeep would be there, would take over from here. And all of you want to connect to me, can connect me on Instagram and my WhatsApp.
If someone has asked daycare, guys, so in daycare surgery, ideally the answer is going to be either
I think Pradeep sir will be taking now, sir. Pradeep sir, are you there? You are taking or shall I? Okay, sir. Yeah. Okay.
Guys, I think you need to let me know because it's very difficult to build up a question over here. All right, I think.
Hello. Hello.
It's very difficult to build up a question over here. All right, I think. Okay, the same question.
You can proceed.
Guys, agar BP fall.
Hello.
Pradeep sir, you can proceed.
Am I audible and visible?
Yeah, you're audible, sir. You can proceed.
Hello.
Pradeep sir, you're audible. You can
Am I
proceed.
audible? Hello. Hello. Okay. Hi. Hello to all of you. So Dr. Pradeep Pawar here. How was your anatomy today? सब FMG predictor series और marathon से आ गया था, काफी easy था anatomy. चलो, let us discuss the questions. This is a quick recall. The entire session will be coming back to you later. Okay, we'll start with the first MCQ. Fracture of the neck of fibula is followed by foot drop, weakness and dorsiflexion and eversion. Weakness of dorsiflexion and eversion. Fracture of the neck of the fibula, which is a nerve which winds around the neck of the fibula. That's a common peroneal nerve. Common peroneal nerve divides into a superficial and deep. The deep peroneal nerve supplies the anterior compartment. Anterior compartment does dorsiflexion. So dorsiflexion is lost, so that is foot drop. Superficial peroneal nerve does eversion of the foot. So eversion is lost, that will be inversion. Clear? So answer is common peroneal nerve. This is clear. Common peroneal nerve. Right, so this is what we had discussed from the marathon. Right, coming to the next MCQ. एक video based question था जिसमें nerve supply of little finger and the medial aspect of ring finger. Yes, student, what is the answer for this? Little finger and the medial aspect of the ring finger. Yes, that is the ulnar nerve, the superficial branch of ulnar nerve. Right, we have also done this in the nerve supply of the hand. Clear है ना ये भी? Ulnar nerve था इसका answer. Little finger and the medial half of the ring finger that is supplied by the superficial branch of ulnar nerve. I have not got the entire questions. जो भी है a quick recall करते हैं, बाद में will come with the full video. Right. Coming to the next question, person is unable to flex the index finger while making a fist. There is weakness of the thumb opposition and sensory loss on the lateral palm. Which nerve is injured? Yes, what do you say? Weakness of thumb opposition. So opponent's pollicis is paralyzed. So median nerve है, sensory loss on the lateral palm and 3.5 fingers. So that would be median nerve here also. So सारे nerves पे ही आए सब सवाल, and I'm sure you must have all answered this very well. है ना? इसका भी median nerve है ना? बराबर है? यही था ना सवाल? Okay, coming to the next. A patient has a slowly enlarging painless mass in the right parotid gland. FNSC suggests parotid gland tumor. The surgeon wants to assess the first lymph node group involved in metastasis. क्या था इसका option? कुछ याद है? Preauricular lymph nodes था. The first lymph nodes. The parotid is drained by the preauricular lymph nodes. इसका option क्या था? Yes, preauricular. I've not got the options. So ये preauricular lymph nodes होगा इसका आंसर. ठीक है, वीडियो बेस्ड क्वेश्चन था. साइनस ये भी पूरा सवाल नहीं आया है मेरे पास. व्हाट वाज दिस रिगार्डिंग व्हिच साइनस वाज इन्वॉल्व्ड? वाज इट फ्रंटल, वाज इट मैक्सिलरी? दिस क्वेश्चन आल्सो आई हैव नॉट गॉट. यस, आंसर दिस. ये तो इजी है. दिस इमेज वाज गिवन एंड which nerve was damaged? So this is pointing index finger. Pointing index finger is flexor digitorum superficialis and profundus is involved for the index finger, and this is supplied by the median nerve. So यहाँ पे भी damage to the median nerve. Median nerve. Right, so this is damage to the median nerve, correct? Pointing index finger. So this was also easy. Video based question tha jisme person was holding a metro card and the sign elicited was asked. Yes, what is this sign? This is Fromet's sign for the ulnar nerve. Ulnar nerve supplies the adductor pollicis. Adductor pollicis, ये adduction of the thumb नहीं हो पाता है. So this is Fromet's sign for ulnar nerve. The person cannot hold the metocard between the thumb and the index finger. So that is adductor pollicis. Options, these options were given. Submandibular, jugulo-digastric. अच्छा, ठीक है बच्चों, जो भी है बाद में I'll again come with a detailed video. What are options? Submandibular, jugulo-digastric, omohyoid. ठीक है. Parotid का main is preauricular lymph nodes. Carpal tunnel syndrome, that's median nerve. मीडियन नर्व. कार्पल टनल सिंड्रोम के बारे में कुछ था मीडियन नर्व के बारे में? यस, इतने सवाल मिले हैं मुझे. सो दिस इज अ सुपरफिशियल रिकॉल. विल कम विद द फाइनल रिकॉल लेटर. ठीक है स्टूडेंट्स, सो एनाटॉमी एज फार एज पॉसिबल मोस्ट ऑफ यू मस्ट हैव बीन एबल टू आंसर दिस. हमने सब करा था मैराथन में एंड प्रेडिक्टर सीरीज में. ठीक है, विल कम विद द डिटेल वीडियो लेटर. थैंक यू सो मच. Thank you so much.
Thank you so much, sir. I know you were in a very remote place. You've taken a recall from the airport. We all appreciate the same. I'll take up from here, sir. Thank you so much. All right, so yeah, so very good morning to all of you. You wrote the exam yesterday and we are doing the recall today. I know it's going to be a lot tedious. Before we just complete off the recall, two things. The exam was literally unfair, and I don't know why every single time they want to experiment something new into medical education, they all start up with FMG exam. Either they're screwing up in their own head or their whole system is screwed up, right? That's my closing statement for them. But anyhow, let's get on with the recall. See, Surgery fairly was straightforward. I don't know, a couple of videos people was telling, but I didn't get them any to the point where I can reconstruct a question. But most of the questions which were there was doable. Very hardly there was any tricky questions. Let's see if you can get something around that area. Now, the question number one, we know 25-year-old female with spontaneous unilateral bloody nipple discharge. What is the most probable diagnosis? The answer here is going to be intraductal papilloma. The age does not suit for carcinoma, ectasia also. It is to be greenish nipple discharge. It can have bloody nipple discharge, but age above 40. Fibroadenosis does not have any nipple discharge. It has got cyclical mastalgia. Right. Priya, we got that question. We'll get back to it. A 58 years old man diagnosed with colon cancer, which is the gene most commonly associated. Remember, it is going to be KRAS gene when you look across the entire component. So when you talk about the gene involved in colon cancers are APC gene, then you have KRAS, then you have DCC gene, and the last one is P53. This is the tumor initiation, this is the tumor progression, and this is the tumor transformation. None of them are the other one, so hence the answer is going to be KRAS gene mutation, right? Yes, Priya, that is zone 1. Which among the following options correctly describe the neoadjuvant chemotherapy? We have been, like, every single question which has been here has been described as a concept. We have spoken about in our marathon, in our predictor, in our regular lectures. If you've just attended that 50 question predictor series, all surgery questions were from one that 4-hour session that we did. So it's quite simple and detailed. Don't worry about it. So neoadjuvant chemotherapy, neoadjuvant means chemotherapy prior to surgery. So chemotherapy given before surgery, right? That is what we call it as neoadjuvant chemotherapy. Now, a young man had a stab wound. That is, somebody's asking the same thing. Between the cricoid cartilage and the clavicle, that is a zone 1 injury. If they've asked you what is the zone of the injury, the answer is zone 1 injury. But if they ask you how do you manage a zone 1 injury, you see stable or unstable. If the patient is stable, then I'll go with CT angio. If the patient is unstable, I'll take the patient for exploration. Now, according to the question that I got, the BP is low. I would say it is hemodynamically unstable patient as in hypotension. All unstable patients, I would go with exploration, that is surgical exploration of neck. Okay, so if you have a mother diagnosed with colon cancer and daughter diagnosed with endometrial cancer, then it can be a Cowden's disease where you have a PTEN gene mutation, right? So that could be another context that you have. Do remember it, or it could be linked to also. They ask the zone plus management. So zone 1, and if it is unstable, then the answer is going to be surgical exploration, right? Both of them are sorted. Now, a patient diagnosed with esophageal perforation post-contrast leak was confirmed. What is the next step in the management? See, when you have a esophageal perforation, if it is given with an endoscope, then it is going to be only conservative. But if it is a spontaneous esophageal perforation confirmed on a contrast leak, it has to be an early surgical exploration. No if, no but. Right? So the straightforward question from our Boerhaave syndrome, it is from the macular striate, same component. We have discussed it before. A patient diagnosed with localized rectal carcinoma, it is rectal carcinoma, without having any metastasis, what is the best management? If there's no metastasis, remove it. What else would you are waiting for, right? So here it has to be surgery followed by chemotherapy. So for all rectal malignancies, we go surgery followed by chemotherapy. Surgery alone is not, we don't do a neoadjuvant, we don't go for observation. It has to be surgery followed by chemotherapy. There's no metastasis. Now, Chuvastic sign video is there. It is seen in hypocalcemia and it is a facial grimace, right? In your twitch it, the face starts to grimace, and that is what we call it as the facial grimace, which is seen in your hypocalcemia, right? Refeeding syndrome, all of us have discussed it. Which is the electrode imbalance, or the most characteristic. Same question that was asked in your recent INI exam. Also, it is hypophosphatemia. Same question we have also discussed in our marathon as well as your predictor series. Which among the following statement is wrong about the image given below, right? So it is a Trendelenburg position. It is a Trendelenburg position. So what is right about this? In a Trendelenburg position, the central venous pressure will increase because the whole blood is flowing towards it, right? Obviously, the preload to the heart will increase. The preload to the heart will increase. The blood going into the brain will increase. So increased intracranial pressure. So all these are true. So when you say which of the following is wrong, see, raised CVP and raised ICP is correct. CVP decrease and decrease ICP are wrong. So I got two statements which are wrong. So just see what are the options that are suiting. One question was liver surgery, early post-operative surgery. What is the most common complication? That was okay. If they're asking for most common complication for re-exploration, that is going to be bile leak. Most common complication leading to re-exploration in a liver surgery, the answer is going to be bile leak. All right. So if there's a question, blunt trauma, what is the initial management? There's a pneumothorax that is there. You can see this is the lung shadow. This is the air that is present. For pneumothorax, what is your initial management? Initial management is a needle thoracostomy, right? So where would you insert the needle? For adult, it is fifth intercostal space. For child, it is second intercostal space in the mid-clavicular end. Adult is fifth intercostal space. It is going to be in the mid-axillary line. All right. So answer here is going to be needle thoracostomy. Now, according to ATLS resuscitation protocols, the 20% body surface area burn, second degree burn. If a second degree burn, according to ATLS, it is 2 into weight, that is going to 50 kilograms, into percentage of total body surface area burnt. So answer here is going to be how much? 1000 into that, 2000. That's got 2000 ml of ringer lactate. So answer here is going to be 2000 ml of ringer lactate. ठीक है? Physiology, there was another question. Tries. Okay, physio sir will take care about it. Tall man with sudden chest pains. If you're looking at Marfan's, they have Willis lung disease. Yes. चलो EDH का management हर बार बोल दिया है, it is going to be craniotomy, it is not burhole, so please do not mark burhole. We have already dealt that before. Intermittent claudication में there's a question which is asked for management. If they're asking for management, it's the level of intermittent claudication is important. Now, if it is at ioto-iliac, if the question said if it is at ioto-iliac, if the ioto-iliac occlusion was there, then it is going to be ioto-bifemoral. It is your ioto-bifemoral. If it is an iliac occlusion, then it is your ioto-femoral. Ioto-femoral. If it is going to be femoropopliteal, if it is femoropopliteal, then you have iliopopliteal bypass. Right? So just look at whatever was the question, if these were the suitable options for the rest of them. See, there was a lot of overlapping questions which I left, which were covered in ENT, pediatrics, as well as medicine. All right. So this is all in all, with respect to the entire recall, we had close to 15 questions which I've got. Students told they're close to around 30-35 questions, including the overlap. We have strictly stayed to the surgical questions. See, again, this is only a first-hand recall that we got with all the confusion and all the pressure, all the stress that you have been in today. So henceforth, let's just take it on the face value of it. Do not try to over analyze this and take it as an absolute this thing. The exam is done. It was difficult. So if you have done exam a bit logically, let's wait for the result. So don't worry about it. You have done enough amount of hard work. You have done enough amount of work behind it. So please do not let yourself down. अब हो गया एग्जाम, खत्म करो कहानी, जाओ सो जाओ आराम से. रात के 1-2 बज रहे हैं यार, अभी पार्टी करने का टाइम है. आराम देखो, जितनी 6 महीने से आपने नींद नहीं पूरी की ना, 2 दिन दबा के सो. उसके बाद देखेंगे जब रिजल्ट आएगा तब सोचेंगे क्या है. तब तक के लिए रिलैक्स, डोंट वरी अबाउट इट. ठीक है. सर्जरी फॉर पाइलोनोडल साइनस अगर पूछा था, देन इट इज गोइंग टू बी योर लिम्बर्ग फ्लैप. पाइलोनोडल साइनस एक्सट्रीम में लिम्बर्ग फ्लैप. ठीक है. Okay. So whatever it is, keep yourself absolutely calm. कोई टेंशन लेना नहीं है, बाकी देखेंगे जब आएगा. इसका परफेक्ट जो रिकॉल है, दिस टाइम वी आर ट्राइंग टू पुट इट ऑन द यूट्यूब ऑल्सो. विल ट्राई टू रिकॉल द एग्जैक्ट सम ऑफ द क्वेश्चंस एंड देन पुट इट अक्रॉस देयर. ठीक है. Whatever questions that you feel were incomplete over there, please do send us on our PW Medit Telegram group. We have our Instagram group. I have my own Instagram channel as well as Telegram. You can just DM me also. I'll be available. We'll try to reconstruct it. ठीक है. अभी के लिए you have done well. Just go back and relax. No matter what happens on the either side of the exam, you have worked hard enough, right? We're there for you. See, we started this predictor series to help you all guys, where we had around 2,200 questions in this book, and every teacher took time to analyze the question paper material, and then we have created a small predictor series which are there from this book on our YouTube channel. You can go watch that also. It was quite helpful for a lot of students. Most of the questions were there from this book only, and it was actually very, very beneficial. So we've been doing this for NEET PG and INI also. I hope you all finish your FMG exam with flying colors, and do meet us on the NEET PG spectrum. Wish to see you on the residency cycle as well. Thank you so much for being out there. You guys have been absolute rock support. You have done absolutely well. Throughout the journey, we've been supporting each other. Thanks for the same love and appreciation from your side also. तो अभी जो भी हो गया, ठीक है. अब रिलैक्स करेंगे, चिल करेंगे, बाकी देखेंगे जब एग्जाम का रिजल्ट आएगा, उसके बाद सोचेंगे क्या करना है. ठीक है. डोंट वरी अबाउट इट, वी ऑल आर देयर फॉर यू. और आप जो ये रिकॉल देख रहे हो ना, मतलब रात के 1-2 बजे तक, वी ऑल आर देयर. संतोष सर इज वेटिंग डाउन देयर. The whole team is working. There are a lot of people who you don't know actually work really, really hard in order to put this recall in front of you. From the point the exam finishes to the point we actually finish the recall, the whole team, starting from Dr. Haraprasad, who is, a lot goes into his head from the academic side. We have Dr. Anton. He just keeps coordinating with with a lot of students. That guy is the workhorse that we have. And more importantly, the technical guy who's behind this, you see all the seamless streaming that works through is by Aditya. That banda is been rock solid from last 4 years. Every single recall, every single time, चाहे रात के 2-3 बज रहे हैं, वो बंदा खड़ा रहता है, and he makes sure everything is absolutely to the point. Shout out to him and all the 19 faculties who have put a lot of effort. I mean, thank you for all of them. So thank you so much, guys. If you have anything else, please reach us out anytime, any moment, right? With that, we finish our June 2026 FMG recall. If any questions, any queries, just reach out to us. If Santosh sir is there, if he is there for last closing statements, stage is yours.
Okay, guys. So now stop worrying about the exam. All of us are, of course, praying for your good results, and let's hope the result is positive and on our side. It's time for us to wind up the session. Relax well, and मुझे पता है सोए नहीं हुआ बहुत दिन से ठीक से. So have a nice sleep. कल सुबह ब्रेकफास्ट के लिए नहीं, सीधा लंच के लिए उठना.
लंच से पहले उठना ही नहीं है.
हाँ, लंच से पहले उठना ही नहीं है.
All right, thank you guys.
Okay, sir.
Good
We'll wind
night.
up.
Bye. Thank you,
Good
sir.
night,
Thank you
guys.
so
Good
much.
night.
Thank you so much for the effort, sir. Bye, sir.